Good morning, everybody. Welcome to day 2 of Law 2030. Welcome, everybody here in Pennovation in Philadelphia, and welcome to our global audience who are viewing us online virtually through our live stream. Just a few housekeeping items for our group here. A reminder, those of you seeking CLE credit, you do need to re-register for CLE if you registered yesterday. The front desk can help you out with all of that. We do have extra copies of Vijay Govindarajan's 3-box solution book up front if you'd like to grab a copy if you weren't able yesterday or you weren't able to join us yesterday. We have t-shirts over here in the hallway, so please help yourselves. And this is a sustainable conference, so you should have received a glass water bottle in your bags, and there are refilling stations around the venue. So yesterday, what a day we had. We talked all about what real innovation looks like, some of the challenges in the legal profession, and some of the major shifts happening that we need to think about how we should respond to. Today, we're moving into a new area. So one of the main goals of this initiative is to be truly interdisciplinary in the way that we think about solving problems. And the best way to do that is to hear from people who've solved problems in other disciplines. So all day today, we will learn from others. We'll start the morning with a panel led by our dean of innovators in the healthcare space who will share with us some of the challenges, successes, and weaknesses in trying to innovate in a very complicated and complex marketplace. After that, we'll hear from flash presenters who will issue 15-minute presentations, and these presenters come from disciplines that are wholly unrelated to the law in many ways, but we can extract lessons from the innovations and the solutions that they've designed to those problems. We'll have a moderated discussion at the lunch break with our flash presenters so that we can delve more deeply into some of the challenges and big wins that they had in creating these solutions. After that, we'll hear from Professor Gary Cazalet at the University of Melbourne from Australia. He'll talk all about how we can use user-centered design as legal professionals to enhance the legal service delivery we provide to our clients. In the background of all of this, our students are right now over at Wharton, on Wharton's campus, working with a real client to walk through the 5 stages of user-centered design to solve a non-legal problem that plagues our profession. And they will be back here in the afternoon to pitch their solutions Shark Tank style and compete to win amazing prizes. And we'll wrap up the day with our advisory board member and president emeritus of Legal Services Corporation, Jim Sandman, who will issue a call to action. At the end of all of this great conversation, where will we go with these ideas? What will we do next? What will our action be? So with all of that, I will turn it over to our dean to get us started.
Thank you. Thanks very much, Jen. And as Jen said, and I appreciate her leadership in structuring this agenda because today we build on what we did yesterday and take it in some new directions, learn from some colleagues from other fields. So yesterday was mostly we heard from people from such a wide variety of perspectives and settings working within the law or analyzing the legal profession. Today we have lessons from the healthcare field, from other fields, and bring some students with their new ideas into it later this afternoon. So I'm really excited about today. This panel I'm excited about. It's an area that I've studied through my academic career. I've worked as a lawyer working on healthcare issues and pharmaceutical issues. And I think, and the 3 panelists who I'll introduce briefly in a moment are colleagues here at the university who I really admire for what they've done over their careers and currently in analyzing and shaping change within the healthcare field. Now, what I think, for we lawyers and some of the themes that came up yesterday about the challenges of reforming or changing a field with kind of entrenched professional norms and big institutions. I think when we look to the healthcare field, we would say that, number one, we're not alone in facing those challenges of professional authority, state licensure regimes, deep regulatory barriers perhaps to change, payment and cost issues. So there, I guess another way to put it bluntly for we in the legal profession, when we see what's happened in medicine, there is no excuse from these barriers for thinking about changing our own legal services delivery, because in almost every instant, be it the regulatory burdens, be it professional authority and conflict, it's at least as great in the health field. Now, one major difference that I think all three of our panelists will speak about is the presence of major third-party payers in the healthcare field that generally doesn't exist in the legal field. And so I think one thing all three of our guests will speak to is both the challenges, but maybe the opportunity, the way that payers, both public sector, Medicare, Medicaid, and then private insurers have complicated, but perhaps in some cases helped catalyze change in a way that we don't presently have available in the legal community. So I'll briefly introduce them, but we really want to hear from Ralph and Mary and Roy. So to my immediate left, Ralph Muller has led some of the largest health systems in our country. Very recently left the CEO position after over 15 years leading an $8 billion organization, the University of Pennsylvania Health System, and all of the complexities involved there. And Ralph will speak to, and over the period 2003 to 2019, so a time of great change in our healthcare system. But before that, he was head of the University of Chicago Hospitals and Health System, and has worked in many other settings, also in the public sector for Massachusetts as Deputy Commissioner for Public Welfare. And he's a member of the National Academies of Medicine, which is kind of the highest honor within medicine, as is our next guest, also a member of the National Academy, Professor Mary Naylor, who is the Marion Ware Professor in Gerontology at the #1 nursing school in the country and the world, the University of Pennsylvania School of Nursing. She's worked on as architect of the transitional care model, which is a care management approach tested and approved by the NIH in clinical trials to improve both the quality of care and efficiency for older adults' experience and health outcomes. She's the recipient of, just a few years ago, of Academy Health's Distinguished Investigator Award, and has worked at the highest levels also of the federal government as a commissioner of the Medicare Payment Advisory Commission, the National Quality Forum, and the Agency for Healthcare Research's Quality and National Advisory Council. So a very eminent expert in academia and in the government. Roy Rosen is the Chief Innovation Officer of this large and complex healthcare institution, Penn Medicine, who is working and has worked with Roy and Mary and colleagues to help redesign the care delivery for hundreds of thousands, maybe millions of patients. Before that, Roy had a distinguished and very innovative career in Silicon Valley and in the tech community, where he was the first vice president for innovation at Intuit, and has advised many startups and Fortune 100 companies on creating a culture of innovation. I think I'll note with one, I think this is the first day all year that, Roy, you've worn a tie. And so this is, and it's one of the few days that I don't. So this, I will note, as we're trying to transition into, this is a phenomenon somebody should write an article or a student note about, where I think it's evocative of an O. Henry story, right? Where I don't wear a tie because I think the tech folks are, and then our innovation officer is wearing a tie. So we'll have to work that out next time. But let's get. So I know. This is a tall order, given all the change that you've worked on. But what can we lawyers learn, and what has happened in the healthcare system that you think might be helpful to us? Ralph, I know you're going to lead us off.
Yeah. Thank you, Ted. I'll stand to make it a little easier to project in this beautiful setting. I was saying to Ted, we have a space like this at Penn Medicine, but we don't have wine there, so we have to an innovation that we have to bring over to Penn Medicine very quickly. just a glass, yeah. I want to speak about three themes briefly, but Mary and Roy and I decided we'd just give a brief introduction and then get into interaction with all of you. And the first one is really that how much payment drives the organization of medical care. By and large, while we think about all the technology that's going on in healthcare the last 50 years, since really World War II, the great innovation in American healthcare, whether it's in pharmaceuticals and devices and care delivery and so forth. But part of what I've found in the years that I've been doing this, as Ted said, I've been CEO for 35 years, is how much it's really driven by payment as well. Because if the government, as you probably know briefly, roughly half the cost of healthcare in the country are covered by government, which means you and I as taxpayers pay for it through Medicare and Medicaid program. The other half is provided by private employers like Penn. So what they're willing to pay for in many ways shapes what kind of technology is brought in. Now, in recent years inside our field, we have this kind of jargon of volume versus value. In some ways, and this happens in law as well, just think about an Uber ride versus a ride in a taxi. You know, basically in the taxi, you have your taxi meter going, then at the end of your ride, you get the kind of bill. Uber does it in advance. And basically what Medicare especially has tried to do the last 35 years, and really accelerated in the last 6 or 7 under Obamacare, is to pay more on what are called bundles or episodes or procedures. I mean, an easy one for all of you to kind of have in your head is kind of a hip replacement or a knee replacement. By and large now, we get paid not on how much a surgeon charges and the anesthesiologist and the nurse and the operating room and the rehab. We basically get a payment in advance, let's say $30,000, and then we have to figure out how to divide that among the professional people, among the hospitals, and obviously if you have had a knee or or hip replaced, anybody in your family, you know, you need to do a little rehab, prehab before, a little rehab afterwards. You may go to a rehab facility. You may need some care at home. It's all in one bundle, an episode. And increasingly what Obamacare tried to do, and it's been mirrored as well in the private market with the big insurers like Blue Cross, et cetera, Aetna, and so forth, is to go more and more towards what are called bundles, as opposed to letting, quote unquote, metaphorically, the taxi meter run. And obviously that's a challenge inside law as well. Now, this started back in 1983, so it's not as if this is when the prospective payment system went to something, those who have any familiarity with medicine, called DRGs. So it's not as if this just started a year or two ago. And the fact that we're sitting here, 37 years later, still trying to implement this tells you change in these big complex institutions is very difficult to secure. Increasingly as well, we're being asked to take risk on a population where we're told, here's a set of patients with heart failure, here's a set of patients with lung cancer, and what can you do and take some risk around those populations, not just procedures, and that is increasingly happening too. Again, it's very difficult to do. Obamacare tried to do this very fully. By and large, the evidence of success is very mixed, meaning some places worked it out, some places did not. We can get into the question and answers after it. Largely that has to do with how doctors and nurses are organized, and they're not as good at learning how to develop those kind of skills. And if you grow people, just like if you grow a law firm by analogy, with everybody you've kind of trained and socialized, you get a different set of people than when you kind of hire them, or if you have, I used to be in Chicago, as Ted said, if you take the big law firms in Chicago or here in Philadelphia, now they have national and international branches. You know you get a different set of characters when all of a sudden you pick up a law firm in Minneapolis or Houston, as opposed to growing your own. So part of the challenges in healthcare is by and large, how do you put your set of professionals, nurses, doctors together, as opposed to affiliating and amalgamating that. But the simple theme here is, how do you get paid often shapes. Again, to go back to my knee and hip replacement, you get paid for the procedure, all the professionals, the 30 days before, the 90 days after, it's all have to be caught inside that bundle. So no matter how much of a kind of taxi meter you run, you're just going to get X. So you have to figure out how to do that. One thing that's happened as well inside healthcare is that we've gotten bigger. There's a lot of consolidation going on. Hospitals have been consolidating, insurance companies have been consolidating, everybody's consolidating. This goes back, the kind of theory is going back 67 years of kind of countervailing powers, and people by and large feel you have to get bigger to negotiate with the insurance company and so forth. Rob Burns and I, who is a colleague of ours at the Wharton's, we've written about this and basically have said it doesn't work. The bigger is not better in healthcare. So it'd be interesting to see, have a conversation whether bigger is better. Meaning it's not better in terms of there are not better outcomes or better cost controls. There's very few economies of scale in healthcare. But what you can do by getting bigger is get better prices, and that's another matter. Second theme is how do you organize professionals? I'll talk more about doctors. My colleague Mary is a professor at the nursing school, so we'll go into comparative expertise here. And so one thing that we've had to do is to consider how much do you focus on the geography. For example, Penn, my theory is, those of you who are sports fans, which I am, Penn medicine goes whether there's Phillies fans or Eagles fans. We don't go where there's Yankee fans. Now, why do I say that? By and large, medicine reflects the culture of society. So if you've grown up on the Inquirer versus the New York Times, or SEPTA versus New York Rails, or the department stores versus Macy's and so forth, that reflects your kind of consideration. it's been very difficult to create national medical groupings. The ones that have tried, Cleveland Clinic and Mayo Clinic, have failed at it. I mean, they won't tell you they failed, but they really have failed at it. If you're going to go to Mayo Clinic or Cleveland Clinic, you're going to Rochester, Minnesota, or Cleveland. You're not going to some branch down in Jacksonville or in Naples, Florida. So basically, and essentially places like us, whether, my old days in Chicago, we divvied up Chicago between the White Sox and the Cubs, Northwestern and Chicago, or when I used to live in Boston, I always knew the dividing line between the New York and Boston medical markets were Hartford, and north of Hartford, they're Red Sox fans, south of Hartford, they're Yankees fans. And I don't mean that facetiously, again, it reflects the medical patterns. So by and large, what we have focused on here is our geography. And that is true around the country, whether you're at Stanford, whether you're at Michigan, whether you're at Houston, Baylor, et cetera, Vanderbilt. The big medical systems focus on geography. The exceptions to that are health companies that really are not integrated groups, but are just holding companies, like the big for-profits. And the other one, more mission-driven, the Catholics have organized themselves nationally, and that's basically a form of income redistribution between the poor inner-city hospitals and the suburban hospitals. So they did it more for that reason. But the care delivery has not changed. So by and large, the elite places, whether they're the Mayos, the Clevelands, the Harvards, the Penns, the Dukes, the Stanford, et cetera, Chicagos, and so forth, they organize themselves geographically. I know your field has gone very much into both national and international kind of affiliation. It has been very difficult to secure the benefits of integration and outcomes. For example, recently, about 2 years ago, Johns Hopkins, one of the elite hospitals in the country, took over a children's hospital down in the Tampa, Clearwater area. Within a year, had a major quality disaster because the doctors there were doing unnecessary surgery, had poor outcomes, so it devastated the Hopkins brand because they didn't have their doctors down there. So it's very unwise to put your name in a field like medicine on places where you can't control the quality, and Hopkins found that out very brutally. Another question is, how big does a group get? Now, as I mentioned earlier, you can think about growing your own, as basic academic medicine often does, or the Mayo and Cleveland's do. When you try to affiliate other groupings, it's very difficult to secure the advantage. Again, as we've written, the quality outcomes and economies of scale really do not exist. You have to then deal with the autonomy of your various subgroupings, whether surgeons or cardiologists or internists or radiologists and so forth, let alone nursing and pharmacy and so forth. So one of the things we have found nationally is it's very hard to really create multi-specialty groups. If you're a Cleveland or Mayo or some of those clinics, and some academics do it more, like the Penns and the Harvards and the Hopkins do it more around creating affiliation groups. But it's very difficult really nationally to create multi-specialty groups unless you grow your own and aggregating people together. So, and again, something for you to consider inside your profession. How much can you really aggregate across subspecialties? And we have found if you grow your own, you can do that. But if you're basically trying to take an independent set of orthopods and link them to a bunch of neurosurgeons, it's very difficult to secure. And the third issue here, and again, Mary will speak more about that, what is the relationship among professionals, doctors, nurses, pharmacists, and so forth? The good news in American healthcare is the public still trusts us. The highest rated professions in the United States by Gallup polls or NORC polls are nurses, doctors, and pharmacists. I remind the doctors that 20 years ago they were at the top of the heap. The nurses have overtaken them. I think the doctors started to be seen as being too mercantile.
That's one difference between lawyers, our field and yours. It's the trust. Yeah. I've seen those ratings.
You're not down there with members of Congress and used car salesmen.
We'll always have Congress.
There's a lot of room in between. So, but the serious part of that comment is, I tell people, don't blow that trust. Because if you blow that trust in the eyes of the American public, you're going to be treated like Congress and lobbyists and so forth. So it's important for all of us in healthcare to maintain that trust. So my theme is on the organization is you're best off growing your own. If you can't grow your own, you have to do it selectively over a period of time. The notion you can just glom people together in different geographies has not worked inside healthcare. And by and large, if you don't want to have the same quality, like the big for-profit firms like HCA, they're willing to take choice demographies around the country, the Boca Ratons of the world, and the kind of Hinsdales around Chicago, and the main line around here, and base themselves on geography, but they basically don't try to run any kind of common practice after that. So again, very difficult to aggregate in any kind of national scene. And the third theme I want to just go over is the innovation, and Roy will speak a little bit more about that than I have here. And I'll speak about two kinds of access. One is just kind of access to health care, and that debate is going on in the primaries right now, with Senator Sanders and Warren talking about Medicare for all, which is a way of getting people insured. By and large, as you know, inside this country, about half of us, as I mentioned, are insured by employer, and then the bulk of the rest of us insured by Medicaid and Medicare. But we still have 30 million people who are not insured, and that's what Sanders and Warren are talking about. And Mr. Trump has not been helpful on that front. But I think the access I want to talk about more today is how are people now getting access to care that may be less expensive. So one of the things you now see around the country, you have CVS's and the Walgreens having walk-in clinics. All of us now carry this great health device called an iPhone, which you can do echocardiograms and do all kinds of monitoring on that, your smartwatch and elsewhere. So what you're seeing is people trying to, since medicine is very expensive, especially in the United States, largely due to pricing, we can get into that later. Since healthcare is so expensive inside the United States, the question is, are there less expensive forms? Now, as I tell, my kids are kind of millennials, and if you tell that generation, you can text your doctor for free every 13 seconds, they're going to do that. Even places like who allow telemedicine with their doctors are now limited to 8 times a month rather than having to do it all the time. The Walgreens and CVS's, they do $49 visits and so forth. By and large, what has happened there, that is added to national healthcare expenditure. It is not substituted for what doctors and nurses do. It's, by and large, if you get a $49 visit, you'll get a $49 visit. That's pretty cheap. Because if you go see one of our doctors, you're not getting away for $49, as you know. So by and large, what's happened in this innovative space is essentially one more add-on to the healthcare system. The aspiration was that it would substitute for what doctors and nurses do, and again, it's been one more kind of add-on. One thing we're trying to do through these watches and iPhones and so forth is, one thing you learn about disease is you have to basically hover over patients. Patients, unfortunately, are not very good at following instructions. They don't do what's always, some things are more difficult, like stopping smoking, but just watching your weight and your blood pressure and so forth. One of Roy's colleagues of mine, we've written about what we call automated hovering, where we text you and remind you constantly. So you see a doctor maybe 2 hours a year, there's other 5,000 hours that you don't see a doctor. So we're increasingly learning how to hover over you to remind you to do things. And now that can be a little creepy and annoying, but by and large, we think in between smoking and dietary control and blood pressure and so forth, it's a good thing to do, and increasingly we're experimenting with that. And the last thing I'll speak about briefly is we're doing a lot of work in terms of accumulating data. One of the things we've developed largely due to the push in Obamacare is electronic health records everywhere. So now when you go to Penn Medicine, other places around the country, almost everything is there right in front of you. You can get it on your iPhone, tells you your allergies, and it tells you your vital signs, it tells you your images and your doctor's notes and nurse's notes. It's all right there. It's all instantaneously. So when you come see one of our doctors, they know exactly what happened the last time you saw us, even if it's 15 seconds ago. So having that information there, we now kind of curate that information so we can start telling inside populations what you're disposed towards, what kind of treatment we can do. So increasingly, we're doing this kind of machine learning of all the information we have on our 6 million patients, and we kind of, it allows us then to kind of titrate and curate what we need to do for you. Now, I've rushed through 30 years of healthcare in about 7, 8 minutes here. We'll be glad to talk about more fully again, but to repeat the themes, how you get paid has an enormous effect on what you do. Secondly, organizing professionals is difficult. The healthcare is the most complex, according to Peter Drucker, the most complex social institution in America. It is just filled with all kinds of different professional groupings, all of which, as Ted said, have their own licensing requirements. How you get those silos to cooperate is a major challenge. And my theory is, at best, you can try to take care of a population in a certain region. It is very difficult to do national health care. And the third theme is, in terms of access, I didn't talk very much about insurance access today. Perhaps we can get into that later, and that's obviously a big issue now in the political debates on the Democratic primary side. But increasingly now, you're seeing more and more innovation going on to try to avoid going to expensive medical institutions by using technology such as smartphones, iWatches, and so forth to basically hover over you. Now, probably you're less willing to share your health data with Google than you're willing to share a lot of the things that you do. And so I think there will be some limitations on how much sharing can go on because people don't like sharing their health data for obvious reasons. But increasingly now we have that data on you, and we can use that to help manage and improve your health care.
Thank you.
So I'm delighted to join Ted, Ralph, Roy, and all of you in a conversation about what I think of in terms of important changes in healthcare and the implications for the future of professions, not just healthcare professionals. And I thought I'd just start by providing some context for some of the thoughts that I have. And what are the drivers, key drivers of change, and some very different perspectives on that. One is, as Ralph suggested, that we do have a new consumer emerging over the last couple of decades. Consumers such as my daughters who are informed and engaged, and regardless of what I tell them, will be using Google Health and relying on Amazon for services, who will go to CVS Health before they'll go to primary care. And that's the nature of them. And when they enter the traditional healthcare system, they are expecting to be much more engaged in the decision making. They want to be active members of the healthcare team. And so that is one part of the future consumer. But the other part of that consumer group are really what we call patients. And we are watching the influence of a growing group of very vulnerable subgroups within our population. We have children who are living with obesity, who early in life are developing heart disease and diabetes. We have youth and their families who are confronting the devastating effects of the opioid epidemic, behavioral health issues. We have a vastly aging society, rapidly aging society, and a shrinking family caregiver workforce. And I mean this sincerely. Family caregivers are part of the invisible workforce within healthcare that we rely on tremendously, but as a society have invested very, very little in them. We have people living in communities who are going to have lifespans 20 years less than those living a few zip codes away. So that's just a sense of who the consumers of healthcare are. And within the healthcare system itself, we have places like Penn and Stanford and Mayo and Harvard where you can access the best in innovations and technological advances, a tremendously very informed workforce working as teams. And you can do this, and we have remarkable results. These evidence-based practices that they're delivering are achieving remarkable results. We had a paper released in the last couple of weeks that shows challenges associated with cancer. Not only are we reducing mortality, but we are actually making much higher quality of lives for people diagnosed with cancer. On the other hand, in just a few communities away from here, we have people who have basic challenges in accessing primary care services, behavioral health services, who enter community health systems where they do not receive the same kind of care, and who leave those systems, and there's huge disconnects, fragmentation, and all of that has tremendous human and economic consequences. So that's the kind of picture of the context. So let me tell you where I think there's an opportunity not to bridge those different views, but to kind of make that view of the patient and the people who have very limited access to the services that we need to kind of help rise all boats. The first of them has to do with, let me push back here. Okay, there we go. The first, though, is this notion that we should figure out how to unleash the capacity of all of us working within the health systems. And in particular, within health systems, this really means thinking about full practice authority. Non-physician providers do not have full practice authority in the United States. And yet they are prepared in the most glorious educational programs, licensure, accreditation, certification is better than anywhere in the globe. Abundance of data that these individuals provide care, in some cases better than physicians, increase access and decrease cost. So the first, on the left,
the slide is not there.
it's not there. So anyway, on the left there, that a diagram shows you in the United States, 23 states have allowed nurse practitioners to be able to achieve what it is that they have been prepared to do. The remaining states place restrictions, varying levels of restrictions on them. And this, by the way, has major implications for access to care, major implications for the way that we think about delivering services, especially to at-risk populations. But this is not limited to nurse practitioners alone. Dental hygienists are quite restricted in the United States by the profession of dentistry. And yet we know we have 3-year-olds, 4-year-olds, 5-year-olds who are living with dental caries, who are having extractions at ages 6 and 7 that dramatically affect their health and well-being for the rest of their lives. So we need advocacy for regulatory change throughout the United States that unleashes and maximizes on the contributions of all health professionals. We need also a culture within organizations and leadership that say that those individuals are going to be equally valued in the delivery of care. A second theme, which you would have seen a great picture of, is this notion of that we know, even though we need to really say people should do what they can in their roles, that we know solutions to the big health problems we are facing will not happen by any single discipline or even multiple disciplines. Disciplines need to function in teams. We also know that we need to be expanding our definition of teams. One of the groups beyond nurses, the most trusted health profession that is really trusted, are people like medical assistants who are greeting people in the offices. Roy will talk a little bit about community health workers, peers, family members, but I want to talk about the family members. Family caregivers are a group that we invest in very, very little, and yet we've begun to realize the negative effects in all of our respective environments when we don't do that. Presenteeism, where people come and are spending most of the days trying to help mom and dad get the appointments they need. We have people leaving the workforce early or interrupting their jobs, et cetera. States have begun to take this on. States of Washington, Oregon, Arizona, beginning to really say we need to invest in every workplace in family caregivers. Organizations themselves are extending benefits to family caregivers in the form of leave, flexible pay, and even support groups, recognizing that as the family workforce is shrinking, employers need to take a much more active role in this. The third point that I would make is that while most of us think about care delivered in hospitals, where the needs are is in the community. This is where people are really desperate for services. We have an infant mortality rate in this country that is a disgrace. We are 33rd out of 36 OECD countries in terms of infant mortality rate, yet we have evidence-based solutions such as the Family Nurse Partnership. A nurse begins to partner with a family, a low-income mom who is pregnant, and works with them and their children for the first couple of years of life. And the impact of that program for those individuals, for community, and for society has been astounding. We are now watching these children at age 18 who are having much higher educational attainment compared to other at-risk groups, and much greater cost savings for the health system as a whole. So these are examples of the roles that we need to be preparing our future. It's not just the hospital, it's the community that really needs the future of health professions. And my last point is we need lawyers. The kind of work that I do in engaging at-risk older adults and their families is exposing us to the kinds of needs that we can't solve. These individuals are experiencing debt, financial exploitation, abuse, and we know that medical legal partnerships can have a major, major impact on improving the health and well-being of these individuals. Cincinnati Children had a 3-year study where lawyers were in primary care practices doing the kind of work, consulting with healthcare teams who are early identifying problems and enabling them to be able to get the consultation and in some cases full legal representation that those families needed in order to address the health issues that they were confronting. They had an 89% success rate in the referrals within that. So there are huge opportunities as we think about the changes in healthcare and the needs of people related to health that I think say we've got to unleash the capacity of everybody to do what they can. We have to enable them and create environments that allow them to function as teams in solving problems and value the contribution of every team member. We have to think about very different settings for the future of health professions, because that's where the needs are. The needs are not necessarily the greatest needs, and we need to be doing this not just as a group of health professionals or even health and family caregivers and community health workers. We need to be doing this in partnership with you. So thank you.
Thank you.
Sign of a
Seat
true expert.
choice?
Yeah, I have to stand too because I'm too short to sit there. You don't need no stinking slides. I think it's going to be your.
I just had pictures. They're beautiful.
So you'll hear some redundancy in the comments that I make as well. So again, I've been running the Innovation Center. We've been around for about 8 years or so. We were formed under Ralph when he was CEO. And our goal has really been to think about the transformation of healthcare delivery. How do we get to high-value care models? How do we fundamentally change the patient outcomes we see? And recently, we've worked on over 100 projects now, and we did kind of stop and take stock and say, what can we look at if we look across projects? And this is just a sample of projects that we've done over the last 8 years. And this sample happens to represent successes, ones where we've really materially moved a needle that we care about. Maybe that's readmissions, maybe that's time in the hospital, maybe that's infections, but we've actually seen something work extremely well. And we said, well, what lessons can we learn and can we kind of abstract from the experience going across this work? There are 3 buckets that you typically hear that I think do in some ways capture and reflect at least a part of it, and I'll try to give you some of the nuances behind those buckets as well. So who gets care, who gives care, and where care happens, which we also heard Mary talk about and Ralph talk about as well. So who gets care, first of all? So we all know you have limited resources, and you have to allocate those resources efficiently and effectively. That's not really a surprise. The nuance under that is really interesting. So if we need to find where can we make the biggest difference? Where can our intervention actually create the biggest change in the world? What we've been finding is that there's extreme power in this algorithmic care and algorithmic identification. Where do we pay attention? If you have a population that's a very large population, how do you know where an intervention will make the biggest difference? That could be in a legal profession, which client might you want to work with to make the biggest difference. So a couple examples right under that green box. MEND is an integrated behavioral health intervention that we've recently designed in the hospitals. And it was really fascinating. One of the things, we always knew that we had more people who needed behavioral health interventions than we were really addressing or helping or even finding. The beginning of algorithmic identification, we actually started finding 8 times as many people who would benefit from a behavioral health intervention than we ever found before, which was a good starting point for that intervention. One of the things that was actually interesting there, we'll get into hopefully in the talk, is payment models. Ralph actually was the person who came to us and said, don't really think so much about getting paid for behavioral health or mental health. There's always been this long theory of if you do a better job with mental health, you might be able to do a better job taking care of physical health. That intervention actually cut a full day off of time in the hospital, which is where the economics were, not getting paid for the actual mental health services. So often in business model innovation, you hear things like a 2-sided business model. You have one customer and a different user and a different payer, and that's really what's going on there. Core, you'll actually hear about David Sermon from our team is here. He's going to talk about this in more detail later. But this is really, maybe at this point, the best intervention for patients with opioid use disorders. So you all know we have quite an opioid crisis going on in this country. Again, starting with algorithmic identification, this team was actually able to connect what you'll hear about in a minute in peer recovery specialists. The care team was actually able to connect with, because they were able to find 15 times more people just in the first phase of that project. So really, really remarkable. And under data-driven risk assessments, one of the interesting examples there might be under palliative care, where it's difficult for a lot of caregivers to move to palliative care because there is a sense that I hear from some of my colleagues that they're giving up on a patient who's near end of life. I want to maybe keep trying, keep doing more. In the data-driven risk assessment, what we're able to do with our data science team is actually do a mortality prediction. What is the likelihood of this person still being alive over the next short period of time? And what was interesting about that kind of almost quantitative view of what's happening in this situation is that it changed the perspective of the caregivers from giving up on a patient to actually bold, empathetic care. I'm actually going to have an end-of-life conversation, and I'm going to do a different type of care given what this prediction model is now telling me. So that's a little bit of the nuance under who gets care and how. Under who gives care, one of the things you'll hear a lot about in medicine is top of license, right? You know, like have the sort of the lowest person in some ways on the totem pole do the work, who can do it well and do it cost efficiently. You know, again, we find that that's sort of that it doesn't serve the purposes. It's a little bit oversimplified. So what we're finding in this space are the three things in the box. The first one is what I'd call escalation models. And in an escalation model, an example there might be a person with some kind of rheumatology issue might go to their primary care doctor and be on their way to a specialist. And you know, a specialist is much more expensive, it's a higher cost, and actually there are fewer of them available. What we found in these kind of e-consult or escalation models, of the people who are being sent towards that specialist, only 1/3 of them actually needed to go there. Right? So you know, you end up with a much lower cost, but also what's really fascinating, I think there was fear of, well, wait a minute, you're sending people away from the specialist, you're losing business. Like, how does that make sense? What actually is going on is that now the specialists are still full, but now they're treating the people who really need them, and actually at a higher profit margin, because those people also have, for example, needs for specialty drugs, specialty medications, where the profit margin is better for us. So the people who need help are getting help, and we're actually doing better off financially. And the people who don't need help are staying out, so everybody wins, and the payer and society wins as well. You know, automation, actually I should say on MEND and the mental health intervention, the same kind of escalation model. That behavioral health intervention used to be all doctors, all physicians. Now it's only about 20%. That you've introduced much more nursing work into that mix. You've introduced much more social work into that mix. So it's 80% non-physician now. In automation, you know, can we get to the point where nobody's doing this work? We've been building virtual care team members. You might think of these as chatbots. You can, you know, chat with a robot. So these are clinically trained and deeply clinically trained. So an example here has been in oral chemotherapy, where you know, chemotherapy has moved home, so you're no longer coming into the hospital, which is great. But these are very toxic, very complex regimens. And so somebody gets home and you have very low medication adherence, very low compliance, and you have lots of side effects. Almost 1/3 of these patients end up in the emergency room in a given year. So, you know, all kind of side effects and symptom management needs. And so by putting essentially a SMS, just a texting chatbot in their hand where they can start to text and get immediate answers that were trained by our clinicians, we saw medication adherence go from 50% to 98%. We immediately started seeing people being kept out of the emergency rooms and out of the hospitals. And 70% of the interaction is programmatic. It's robotic. It's not humans. You know, you're taking that off of the humans plate altogether. And finally, and Mary talked about this a bit, novel roles. You know, there's all kind of things that we're seeing that we're excited about here that are non-clinical and non-traditional. In the community health space is one of the ones that's probably the most interesting. Impact is the name of a program that was designed by Shreya Kangovi, and it's really wonderful. It's a complete redesign, complete reimagination of a model that's hundreds of years old, but never had an effective, you know, measurement, never really was effective as a model, frankly. And she completely changed how you identify these people, how you train them, how you deploy them, how you manage them, how you track progress over time. But these are people who came out of the community with a shared experience and shared background as very vulnerable populations. And the impact here of Impact has been remarkable. They recently published that there's a $2.47 return for every dollar invested, which is not something you see all that often. Similar in what you'll hear Davis talk about in the opioid intervention, one of the real strong levers were these peer recovery specialists, people who themselves were in long-term recovery from addiction. And they made an amazing difference. Not only are they very cost efficient, they're extremely effective. They can engage with patients in ways that the physicians say that we just can't do. We just can't have that kind of an impact. And then finally, and Ralph did talk about this, it was really interesting to me. When I came in about 8 years ago, Ralph had just written that article that he mentioned. It was really a seminal article on automated hovering. But yet, despite that article and despite the thinking that was starting in Penn and other places, if you asked most of my colleagues for the next several years, you know, they would have said there's no way we can be responsible for what people do or what happens to them once they leave the hospital. After they leave the hospital, after they leave the practice, after they go back to their house, their job, their work, their life, how can we be responsible for what they do? And I will tell you that that's not the way we think anymore, right? So this idea of automated helping, this idea of staying connected to people over longer periods of time to change what happens is essentially our philosophy now. So it dimensionalizes where care happens quite a bit. Normally where care happens is, okay, let's not do it in the most expensive place. Let's not do it in the hospital. Even within the hospital, let's not do it in the emergency room. We've set up specialty clinics where we can do things more efficiently for hypertension, for actually complications early in pregnancy. We've designed a lot of these specialty clinics that can do things faster, more cost effectively, and actually better. So even within the hospital, you're moving where, but it's not just where, it's also when. Right? So catching things much earlier. We're seeing things we never used to see before. We're seeing them much, much earlier, which means we can act on them before bad things develop. So the when is critically important. One of our signature projects has been a one called Heart Safe Motherhood, where we send at-risk mothers home with a blood pressure cuff, and we start a texting program with them. And because we've been able to do this, we can actually see elevated blood pressures. And so this is in the area of preeclampsia. So it was the leading driver of morbidity, of readmissions, even mortality for this particular maternal group. We have now seen an 80% reduction in readmissions, 80% reduction of people coming back to the hospital, 80% reduction of things like strokes and other morbidity, just because we're staying connected longitudinally and we're able to act in ways that we were never able to act before. It does mean that we have to change what we can do at home. We have to train home care nurses to do different things. We have to be able to, for example, do IV diuretics at home instead of in the hospital if we want to keep people out of the hospital. So there is some changes in what we can do in different sites. And then my final point is across all of that, we have found we absolutely have to invest in effort reduction. Partially because we have extremely busy colleagues, nurses, doctors, and others. Like there's no room on their plates. There's no ability to do more. They're already working incredibly hard. That's part of it. And so we have to create room on their plates if we want new things to happen. But that's not really all. What you're talking about here is change. And people don't like change. Change is hard. People resist change. If you make change not only easier, but easier than the old way they used to do things, it's actually easiest. Now you can actually have a real impact. And we've been able to actually, in many cases, just dramatically reduce what it takes to do your work. So that's where effort reduction comes in.
Thank you. Well, thank you all. There's so much content and wisdom here that I know has will catalyze a lot of questions. I want to myself ask a few follow-up of each one of you. Mary, maybe starting with you, and you had the map of the states, and this is something that's really similar between our two fields. Yesterday we have here today, and the president of the American Bar Association, Judy Perry Martinez, who spoke yesterday, and as you said, Judy, to me, you're not a regulator, which I had two responses to. One, you kind of are for law schools, right? Through the accreditation function, we care a lot about that group. But however, more pertinently, I wish you were a regulator. I wish that some of these ideas of reform that if we catalyzed and talked at a national level, we could kind of implement with after appropriate discourse. But no, we're working as with your field, Mary, across 50 state capitals. And I wanted to ask you to speak a bit to the kind of way that change happens in that diffuse manner. Now, and then there's something you said caught my attention. I think you mentioned Arizona, Washington.
For the family caregivers.
Yeah. And what struck me, and it'll struck some of us, I think, is that if we were to rank the top 4 or 5 states on legal licensure reform that seemed to be forward-looking, those probably would have come up. And
right.
So
the West Coast, yeah.
So what is it, both generally the phenomenon of working for change at the state capital level, but then is there something distinctive about the political economy or the governance of some of these Western states that makes it, in both of our fields, a fertile ground for reform?
Yeah. I mean, just thinking about the future professions, maybe there's an opportunity for collaboration around these kinds of efforts, because we have been engaged as a profession, and here we're talking about nurse practitioners just as an example. That's a subgroup of nurses. 3.2, 3.3 million, the largest health profession group in the country, and of which an increasing number are masters or doctorally prepared. And so what has been a real effort is to build state coalitions, groups, led by national organizations, but really deliberately coming out with similar messages around, for example, I and others have been involved in synthesizing a robust body of evidence that shows that that we are, why regulations exist. They exist to protect the health of the public. And here there's no evidence whatsoever that those are issues. So we have been working with state coalitions to make sure that everyone is informed about the current body of evidence. We're helping to build advocacy skills within those coalitions and bringing in a really wide table sometimes of people that have been resistant to these kinds of changes to make sure that that kind of messaging has come across. It's, there's been pretty substantial movement since 2010 when the National Academy of Medicine took this on and said the future of nursing really needs to be able to make sure that we remove these restrictions. And so that has been really, really helpful. We've also been, I work in the National Academy of Medicine group to engage people, patients, family caregivers in the advocacy effort because they are tremendously strong voices who can tell their stories about what it's like to be able to receive the care and services of individuals when they need them. So it's been that kind of multi-pronged effort. Federal Trade Commission, we began to work with them. They now have a white paper that is out and now reinforces everything I just told you, which is there is absolutely no reason not to advance. So this is really been efforts trying to figure out who are all the people and groups that we can engage in this. As to why certain states, I mean, we've watched this not just with changes in terms of regulations, as you're describing, maybe there is some parallel groups, but there have been certain states where leadership has really been out there thinking, always forward thinking. And I don't know what the ingredients to that are. Certainly, some of what we see in terms of healthcare is access to primary care is a big driver of willingness to change. Increase rural communities, for example, states with large rural environments know, absent the engagement of nurses and nurse practitioners, they will have nobody delivering services. So I don't know what the ingredients are relative to culture of states, leaderships of states that make them more likely to be doing, but I do know that they have been forerunners in more than just changing regulatory practices around nurse practitioners.
Mm-hmm. Thank you. Ralph, I want to ask you to kind of knit together the first two principles you talked about. Number one, that payment drives change, and number two, that it's difficult to change with professionals. And so this is a question about that came up yesterday about the internal reward and compensation structures within big health systems, or in our field within big legal institutions. At Penn Medicine or Chicago or others you're aware of, I've seen some stuff that Geisinger has done. Yeah. Has there been any success in changing the way physicians and nurses and others are compensated to effectuate this change from volume to value? In other words, can you compensate? How hard is it to compensate for value in a world where traditionally we've rewarded volume of hours, volume of procedures?
As I said, the change has been slow in coming, even though it's been aspirational. But some of this really goes back to the mid-'80s, so it's accelerated quite a bit in the last 7-8 years under the Affordable Care Act or Obamacare. So let me give you two simple stories here. For example, many of you who are from the West Coast have obviously heard about Kaiser Permanente Health Plan. It's a big health plan that covers California and goes up into the Northwest. They are both an insurance company as well as a set of doctors as well as a set of hospitals. And they get, therefore, since the practice is all internal, when you go to a Kaiser facility, you've paid in advance, roughly $10,000 a person or $20,000 a family. Once you've paid that amount of money, it's in Kaiser's interest to not necessarily have you see a doctor. So half of Kaiser's visits are through telemedicine. Because once they've been paid their $10,000 or $20,000, to go back to my earlier analogy, they don't want to run the taxi meter anymore. They don't need to have a cardiac surgeon or an endocrinologist or other people see you if they can. So in that sense, once you're paid in advance, then you start thinking. And same thing if you're paid in an episode or a bundle. If, as I said at Penn, we get paid $30,000 to do a hip or knee. Once we do that, then we don't necessarily want the orthopod or the Mary's advanced nurse seeing that person. If we can do it with a home health aide, if we can do it through telemedicine, if we can do it through other forms of that. So in that sense, you start allocating who does what you're doing through the payment model. Then to go to Ted's point, how does that shape kind of compensation inside? Obviously, we are still market-based, whether you're sitting in Kaiser Permanente in LA or San Francisco or sitting with Penn Medicine here in Philadelphia. If a cardiac surgeon costs X and a neurosurgeon costs Y, that's what you have to pay to compete in the local marketplace. You can't just say, we're going to pay a lot. And even Kaiser has their own set of... So the marketplace still works. You can make some modest changes. By and large, the bigger places tend to be more salaried. So, we don't pay our doctor more to be there on Friday afternoon, frankly, the way private practice works. So you do have some sense of, you set annual salaries, and we've worked very much on that, and to have it tied to teamwork and quality outcomes. So you measure patient satisfaction, not just how many quote-unquote RVUs the doctor has done. So increasingly, you have those kind of measures as to how the outcomes that society, and by society I mean not just patients, I also mean the Medicare agency and Blue Cross, they measure us all the time. So increasingly you try to measure those things as well. It is still a challenge, I would say, to have as much sharing of income as one would have in a more Bernie Sanders type society. So essentially, surgeons still get paid more than neurologists, and they get paid more than primary care. So those kind of differences that have been there for 50 years still there. They're more modulated than they were before, but they are still very much more market-based. So to repeat those themes, one is the payment model will dictate exactly the skill mix that you use. And when you're just paid, quote-unquote, fee-for-service, what I call the taximeter, then you want the surgeons and neurologists and the primary care people seeing people. That's how they get paid. Increasingly, we're moving away from that. So therefore, once you get paid in advance, the extreme is a kind of Kaiser model, where you're both an insurance company, and Geisinger, which is a system here in Pennsylvania, does the same. They're an insurance company as well as a set of doctors and hospitals. So once you're paid in advance, it does change. That is still a very difficult model to create in most parts of the country, and most people who try to do it without growing their own, creating their own doctors, their own nurses, and so forth, have failed at it. It's just the skill set that's hard to do. Secondly, the more and more you put people onto annual compensation, as opposed to having a high differential in incentives, it does start shaping behavior in different ways. And third is, I'd say, the marketplace still works. So efforts to pay people more equally based on years of service, the kind of civil service system and so forth, really has not come to medicine yet. There's still differentials based on the marketplace. So we have to compete against, the Harvards and the Dukes and the Hopkins and the Stanfords and so forth in terms of professional talent. So you have to be responsive to that. But on the other hand, for example, we are both in Princeton and in Lancaster, to go back to my Phillies example of this, or Phillies fans are. So the Lancaster market and the Princeton market are a little different than the Philadelphia market. So you take advantage of some kind of local variations.
Thank you. Roy, what's distinctive about your really impactful career is that you've worked in such different settings. So the kind of huge and established medical system for the last several years, but then this kind of quintessential or what is perceived by those of us who don't live and work there as the quintessential innovation hub of Silicon Valley. I ask this as somebody who's spent more hours in my life watching Silicon Valley, the show, than actually resident or president of Silicon Valley. So the caricature, I want to invite you to kind of complicate or put nuance on. The caricature would be, Silicon Valley, your role is, there's just so many ideas, your role is almost weeding out most of them and getting people to focus on task. And then in the more established medicine like law, you're trying to get people to think creatively. Is that story too simple? And how would you complicate it for us?
Yeah, I think it is. It's an oversimplification. But so what's true is that it's a wonderfully active ecosystem. It loves problem solving. It loves novelty, sometimes, unfortunately, for novelty's sake. But You know, the thing that ties these two together is this sense of what's taken over Silicon Valley, what we're trying to infuse through medicine, at least Penn Medicine now, is this idea of extremely rapid experimentation and validation, which means that you can get into creative problem solving, but you can do it safely if you're driven by a hypothesis and you design an experiment to test that hypothesis. So really what's happened in Silicon Valley is a compression of cycle times. I go much faster in cycles, experimentation cycles, and I can go much faster and much cheaper based on the kind of methods we use to test whether I'm right or whether I'm wrong. So I have an idea for a new product, a new service. How are you going to figure out if you're right or you're wrong? You know, I'll vapor test it. I'll take an image. I'll computer generate an image. I'll put it on a website. If somebody tries to buy this thing that doesn't exist, I'll say it's out of stock. And I learned whether people ever click to try to buy it or not, right? It's contextual demand testing. There's a million ways to do these things in healthcare as well, all safely. Certainly there's more conservatism, for sure. But what we found is that we can craft techniques and experimental methods that are safe and allow us to have a similar cadence where every week or every 2 weeks we have a new version of what we're trying to do that drives change. And there's no doubt, I mean, just to build off what Ralph was saying, payment model change almost enables us to exist, right? Us being the innovation world. You know, some of my favorites recently, Ralph talked about lower joint bundles. You know, as soon as we have lower joint bundle, now we have the remote monitoring that we both talked about. You know, now I'm tracking people when they go home, and we've cut more than half of readmissions out of that, right? So you get to experiment because something has changed. My favorite one recently is in breast cancer and breast reconstruction. They went to a global payment, so you get this fixed amount of payment. You know, it's again just building off of Ralph's comment. Fixed amount of payment in the 90 days post-surgery, right? So in the old days, you'd come in 5 times or 5 appointments, right? And we actually just had an innovation where we've eliminated 4 out of 5 of those appointments, right? In the old world, if you eliminate 4 out of 5 of your appointments, you've lost 80% of your income. But in the new world, you're getting paid a fixed amount. Your goal is to keep women safe and to make sure they have a good outcome. As long as you're doing that, you've actually created massive new economic opportunities because you've opened up all these clinic visits. So now 4 of those 5 have gone to home care, have gone to the remote, you know, let's just text pictures back and forth and let me make sure you don't have an infection on this site. Get rid of all this work that's unnecessary work because I'm not getting paid to do work anymore. So what's making it a little bit more like Silicon Valley is actually breaking this old hold of the old way of getting paid where you can actually do better by being creative. Right? In the old model, if we were creative, we did the Silicon Valley thing, we experimented, we changed, we got better, we would lose money.
Do you, just a follow-up for you or any of you, so that's an important point, and it's as we think about legal change, when you take fixed payment, you're taking on some risk.
Yes.
So, and you're almost performing an insurance function, or at least you're insuring around the variability in the cost of the legal service. That do you have to be big to do that? I mean, it's a question that, or how big do you have to be? Because
yes and no. In part, the bundles, the episodes, these clusters have been more around defined procedures. So in kind of simple graphical terms, it's more around surgery than the kind of cognitive specialties where there's a lot of variation. So basically, in kind of statistical terms, when there's not a lot of variation, you can do a bundle more fully than when there's an enormous amount of variation. So by and large, the bundles and episodes have not gone to fields like diagnosis of MS and autoimmune, when there's, you can have a very simple case, a very complex case. Whereas, frankly, replacing a knee is replacing a knee. I mean, here and there, you get a hemophiliac or something like that. But by and large, it's more of a defined operation. So in that sense, if you're going to take, in the insurance jargon, if you're going to take incidence risk, meaning is Amtrak going to crash in North Philly and have 10 trauma patients come rushing into your hospital, you're going to take the risk on that. In each case is $200,000, maybe not. If you're an employer that has 20 people and one of the people has premature twins that cost a couple $100,000 each, you don't want to probably take that kind of risk. And therefore, you probably want 2 million people, to pick a number, to spread the risk of a Amtrak crash in your backyard or premature twins. We're increasing what we're finding right now with the opioid epidemic inside this country. For example, when you're a substance abuser, your heart valves get reasonably clogged up and so forth. We get paid, a heart valve case was based on come to the hospital for 5 days. The people who are substance abusers may be in there for 40 days. Do you want to take the risk if you're in West Philly, as Penn is, on all these substance abusers coming in, having to be in the hospital for 40 days. So you can see you probably want a big population before you take that kind of risk, as opposed to more limits. So essentially, one of the reasons I've not got directly at Penn into becoming an insurance company is many people as we see, we don't have 5 million patients. And so basically, you want to have millions of patients to spread that risk on whether it's liver transplants or train accidents or premature birth and so forth, as opposed to. So I think a lot of places, and my counterparts around the country, have gotten into big trouble, Hopkins, Mass General, and so forth, by taking on risk without necessarily having the scale. And those are big places, so that tells you have to be pretty big.
And they're bigger than even the biggest law firms. So I mean, it's an important topic for our field about this notion of changing payment and taking on risk. I want to. We have 10 or 15 minutes left. I want to invite questions from the audience. Yes. Well, I see a few. I see at least 3. We'll go here, and then here. Okay, 4.
Good morning. That was really illustrative and beyond. But I wanted to ask you about federally qualified healthcare centers, because they are a congressional allocation to kind of create the equivalent, I don't know if the analogy flies, but of legal services, right? Those are healthcare facilities, community-based clinics that are there to help the people that will not qualify for Medicaid, migrant workers, the uninsured, and things like that. They're not hospitals, they're clinics. And they tend to be generally located mostly in either certain zip codes or really rural areas, like where I live. My question to you is, are your systems and your innovations overlapping or interfacing with federally qualified healthcare centers, which would be the equivalent of legal nonprofits funded by the federal government, to help with some of these innovations, like with the community-based practices, with the helping people take care of themselves at home when they're in very remote rural locations or very snowy areas, etc. Just the overlap between your big urban centers, your innovations, and then infrastructure that exists specifically for the very low income and uninsured.
Very good.
So first of all, the federally qualified, thank you for that question. The federally qualified health centers are a major contributor in the evolving healthcare system, and with the Affordable Care Act got quite a boost in terms of increased investment. So just so that you know, the work that we do here at Penn, while we obviously have a major partner in the University of Pennsylvania health system, is about changing healthcare delivery across the country and across the globe. So we partner with federally qualified health centers to really think about how to extend the work that they're doing and make sure that it's guided by evidence-based practice, the best use. Many of these federally qualified health centers are, in fact, led by nurse practitioners. So just to give you an example, we're working with a group that is helping them to think about how to extend the work that they do in the health center into the home, enabling the nurse practitioners to be able to follow people who are at risk into the home and prevent them from ever having come into a healthcare system. So that's the way in which the kinds of innovations and evidence that we're producing is being used both to help existing very important infrastructure in addressing the needs, health needs of our nation, but also extending the contributions that they can make.
Let me make both at Penn and Chicago. First of all, we staff one about 10 blocks from here. And as your question implies, having doctors, nurses, social workers, everything under one roof is helpful. But let me speak to one that we have downtown in Center City. Based on your political preference, it either serves undocumented or illegal people. So basically, this serves the Mexican people who work in the restaurants of Philadelphia. None of them have insurance. And what we have in there, we have doctors, nurses, social workers, lawyers, and so forth. So we have law students and social workers who help them get driver's licenses or apply for public housing or just deal with the activities of daily living in addition to giving them free medical care. And so it's a great model. We do it basically for free because we have good altruistic people who want to be medical students, young lawyers and doctors and social workers at Penn, and we staff that totally for free. I did the same thing in Chicago. our emergency room was just being overrun. University of Chicago, for those who know Chicago, in the south side of Chicago, which is a kind of combination of West Philly and North Philly. And so basically we set up a FQHC, Federal Qualified Health Plan, 2 blocks from the hospital to keep people out of the emergency room. And we staffed with all our staff. It gave people great access to care. And by the way, we got paid twice as much per unit as we got paid by Medicaid. So instead of hemorrhaging on Medicaid, we're actually able to break even on doing primary care. So one of the advantages, what one learns in the kind of role that I've had, is there's a lot of opportunities inside the federal payment system to get paid for people who are poor. And you have to figure out how to tweak that to make sure. And one of the things the Penns and the Chicagos of the world can do is figure out, it's like the Mr. Trump's version of tax loopholes. There's a lot of ways to serve the poor if you figure out what the federal system is. And one of the things that Penn can do very well is get access to those funds to take care of the needy.
Mm-hmm. Yes, we have time for a few more.
Hi, I have a medical education question. So I'm a law professor at Brooklyn Law School in New York, and I've been curious and really trying to study how the medical profession has been directly addressing as part of the curriculum things like student fear or anxiety or stress or vicarious trauma, or how to have hard conversations with patients, or financial strains about some of the things that we've been talking about. And based on my research, at least, it seems like medical and nursing education have been making innovative strides in that curriculum area. Even the Silicon Valley example of just allowing students to make mistakes, but in a safe environment, in a low-stakes environment, so then when they get out in real practice, it's not as high stakes. So I'm wondering if you can talk at all about those educational initiatives, and if you think they're effective to prepare med students and nursing students for the realities of practice and having well-being in the profession.
Mm-hmm. Mary, can you?
So I'll start by, thank you again. That's really important, is how do we have, and this is, I don't think unique to medical students or nursing, but law students, how is it that you position them to really optimize, build the trusting relationship, enable them to be able to help you understand what their needs are. So we use, for example, a lot of simulation as a strategy, and that also is a very big part of the medical school education. So the opportunities are first to create the comfort level within the trainee, the nursing student or the medical student, and then gradually introduce them to the kinds of interactions. But there's a lot of oversight. I mean, with all of the wonderful work that's coming out of Silicon Valley or the Innovation Center, at the end of the day, it's about relationships. It's about the kind of trust that people have with each other that enables us to be able to really optimize our contributions. Interestingly, we are being called on, I don't know about the medical school, but the nursing school, we're working with groups like Bank of America, Merrill Lynch, to help them think about how their financial planners can better establish relationships in order to be able to maximize on what they're hoping will not just be a relationship with the person with whom they're working initially, but ultimately a family, a long-term relationship. So there's a lot of cross-fertilization opportunities that we have. I think that here at Penn, we try to really maximize on those linkages, but I think that maybe we could spread ourselves into other fields and make contributions as well as learn from how it is that you do it that could enhance our work. So did that answer your question?
Well, one thing we've learned is that people need training all the time. And this notion that you get trained as a law student, a medical student, that kind of stays with you for life, I just don't believe that. So just like there's this whole, you can get YouTube now on almost anything in your house and so forth. So one of the things we've tried to do at Penn, and we have an enormous internal training academy, which we call the Penn Medicine Academy. So basically, you want 30-second snippets here and there to remind you. So when, obviously with the coronavirus going on right now, you may have been trained on how to deal with infection 5-6 years ago as a nurse, but you want to remind yourself to do a little 30-second snippet. This is what you do. Here's your checklist and so forth. So that kind of technology now, when 30 seconds here, 3 minutes here, you can remind yourself of what to do, whether it's around infection, whether it's around control, how to discharge a patient to home, whether it's around billing and so forth. Just a little refresher, so we have that all the time. One of my phrases I always use is, if Roger Federer can have a coach, he's the world famous, we can all have a coach. So the notion that you only need to be coached when your remediation is wrong. So everybody can improve their backhand, so to speak. So we coach people all the time, and we try to make it easy by saying 30 seconds here, 1 minute here, rather than come come see us for a month. So that sense, I think, that's much more powerful now than it used to be.
Yeah. And Roy, is that something you view in your jurisdiction as an innovator, like about kind of HR issues and supporting the employees,
For
doctors
sure.
and nurses?
Yeah, I mean, both because I think there are technologies that matter. You know, simulations are great techniques. You know, AR, VR simulations can be even better, right? You know, because they can get you more in a more realistic scenario. You know, we layer on technology carefully because I agree with Mary that it ultimately it's a human relationship. You know, when I talk about automation, I mean for the things that robots can do well, leaving for humans the things that humans do well. You know, so certainly we look at this quite a bit. We also, you might not think of it as training, but you know, Ralph and I have spent a lot of time on the health system side also building a group called the Nudge Unit, which actually is about behavioral science. And as opposed to training, it's structuring an environment in which the right thing tends to happen even without the training, right? You know, changing the defaults, changing the way information is presented, how, when, et cetera. And you know, what we've found is we can actually move needles tremendously by re-architecting the environment, not the human always. And I think that's extremely important.
Yeah. Thank you. So we have a few minutes. A couple people have been waiting to ask. I know you have, and then this guy. And one more minute? Yeah. Well, okay. Let's try to get to the two questions who've been waiting for a while, and we won't get a quick question. We'll have one quick answer, and then we'll come down here.
So quick question. I'll go quick. I was going to say, first of all, great presentation. So many similarities. I wanted to ask Ralph, you were talking about the fact that you had looked at self-insuring or insuring the population in the area, but that the sample size was too small. And I was wondering to what extent, hospitals might be able to work with other hospitals or the insurance industry to lay off that risk into the secondary market in some way, or if some secondary market could be created in order to kind of solve that problem.
Yeah. Well, could hospitals kind of cooperate? First of all, there's antitrust reasons that get in the way of kind of sharing prices and so forth. So that's almost so dispositive. You really can't share prices with others. In some ways, that's what insurance companies are for. Now, as Sanders and Waters, others point out, they're a little bit too expensive. There's things one can do without going to Medicare for all, which I think would be a big mistake. So it's not the purpose of today's conversation. But one can lower those kind of costs. But I think by and large, employer coalitions and so forth, frankly, don't work. I think it's, people try it, but by and large it doesn't work, and getting people to cooperate has all kinds of antitrust problems.
Okay. Yes, last question.
Yes, so my name is Tanina Rostein. I teach at Georgetown Law Center, and I should mention that for many years I thought of myself as a legal tech innovator, but now I know it has to be in air quotes, having heard from this panel. So my question has to do with the financing model and Ralph's observation, the rest of the observation that economics drives organizations of practice and innovation within different professions, and also follows up on Mary's description. The last thing you talked about is the need for lawyers embedded in healthcare provider settings in order to provide other services and in fact create better health outcomes because of legal interventions. So is there a conversation going on in either the public insurance or private insurance space about actually using private or public insurance to subsidize lawyers in those settings? In other words, there's beginning to be some conversation / evidence about law as a social determinant where they're all, and that's a bigger movement in medicine. Is there is that conversation beginning? Is there a place for that conversation to continue?
Yeah.
So I'll start. I think that the Bipartisan Budget Act of 2018, which has housed in it, it's the Chronic Care Management Act, it really talks about thinking about how, and for Medicare Advantage patients, which about 31% of Medicare beneficiaries are in the Medicare Advantage program, and that's expected to grow pretty exponentially in the next couple of years. What they're doing is trying to say, tell us what's needed in terms of health or social services in order to get to better outcomes. And I think that is unleashing, if you will, the capacity to think about a whole different team delivering services. So they are saying, if we need X, if we need housing support, if we need help in getting people to get benefits, and there are barriers to that, how are we going to address it in order to make it happen? So I think at the federal level, in Medicare Advantage is a good example of where we're seeing some opportunity to play out, and where innovation, I think, could abound.
Yeah, I think it's demonstration projects. Like, nothing succeeds like success. So you're seeing these emergent things. An analogy is putting people with tax preparation in emergency rooms, right? You're seeing it in a couple of places emerge because an inordinate number of low-income people don't claim their low-income tax credit. It's $3,000. The difference between a healthy diet and an unhealthy diet is about $500. This is $3,000, right? You know, so you're seeing you can actually get people $3,000 just by doing quick tax prep in the ER. So I think demonstration projects and create emergent strategy in policy.
So I'm going to, this could keep going. This is so enriching. And I want to thank all three of you. Our next panel actually continues some of this discussion, and we'll hear from an innovator, another Penn colleague, about addressing the opioid epidemic and continue these themes. But we have learned so much. We have so much we can continue to learn from all three of you. Thank you for your participation in this effort.
Thanks for having us.
And we'll start again at 11 o'clock.
Served as a trusted advisor to entrepreneurs and emerging growth business across a wide range of industries. We understand that emerging companies require more than just expert legal advice. They require advice that is practical, responsive, and cost-effective. Through our program for startup and early-stage entrepreneurial development, Pepper Seed, we assist startup and early-stage companies during their formative years. Pepper Seed's holistic approach combines the resources of an experienced, multidisciplinary team into an affordable package for startups and early-stage companies that are accepted into the program. The unique, deeply discounted programs include a nominal entry fee, a full suite of essential basic legal documents, effective legal counseling, and, for no additional charge, mentoring in areas such as board development and management, business plan review, and investor relations. And, leveraging Pepper's extensive array of relationships, we can introduce Pepper Seed clients to angel investors, seed funds, and venture capital funds, and help tell their story to the world.
rejoining us in the main area to continue our conversation. After that very rich and informative and educational, inspirational conversation with leaders in the healthcare system, we are going to hear now from some innovators in other disciplines who have used different approaches to solve intractable problems so that we can learn as legal professionals how we might draw lessons from them. Okay. So as we move into the conversation, we would all just like to take a moment to express our gratitude for the generosity of the W.P. Carey Foundation, which made a very, very generous gift to the law school in the fall. And that gift will promote and advance interdisciplinary conversations like the ones that we're having today. So we really want to thank the Carey Foundation, and we're very happy that Will Carey is here with us today to enjoy and engage with us in these conversations. So thank you so much. And with that, we will continue to learn from other disciplines, and we will start with Kiran Musunuru, who is Associate Professor of Cardiovascular Medicine and Genetics at the Perelman School of Medicine, and also a student in our Master of Law program at the law school, which is in and of itself an innovation, bringing people from other disciplines to the law school to learn how the law impacts their work. So thank you so much, Kiran.
It's on. Okay, great. If you open a newspaper, if you go to a news website, what is getting all the headlines these days? Coronavirus. So I'm not here to talk to you about coronavirus, but I do want to put something in context. As of yesterday, about 3,000 people have died in total, at least that have been recorded, over the last few months with the coronavirus epidemic, soon to be called pandemic, I'm sure. And that's a lot. It's a serious problem, no question. But to put that in context, how many people have died of heart disease in the same amount of time? Well, each year around the world, 18 million people die of heart disease. It is the #1 killer. It does not discriminate. It is the #1 killer in women. It is the #1 killer in men. It doesn't matter your ethnic background. It is the #1 killer. If you're in the United States, it is the #1 killer. And now, as of a few years ago, even in the poorest countries on earth, it is the #1 killer. It is the preeminent global health threat of the 21st century, bar none. Now, all the women in this room, what is your chance of getting a heart attack, at least one heart attack, sometime in your lifetime? It's about 1 in 3, just to drive it home. And if you're a man, what's your chance in your lifetime? It's worse. It's 1 in 2. So look to your left, look to your right. One of you is in real trouble. So that sets the problem. This is, as I said, the preeminent global health threat. Now, I want to start by not focusing on heart disease writ large, but talking about a very unusual presentation of heart disease. So this was in our hometown paper here, the Philly Inquirer, just last summer. This is a 10-year-old girl by the name of Avery Watts. She has a condition called familial hypercholesterolemia, which means she has sky-high cholesterol levels, like on the order of 1,000 or more, if that number means something to you. And her condition is so severe that she doesn't respond to standard medications. She has to be hooked up to a machine, you can see it right there, hooked up to a dialysis-like machine every week, and it's really a burden on her because the nearest center that has one of these machines is a few hours away, so on Sunday her family has to take her to the center. They stay overnight. She has to miss a day of school. It's only open on a weekday, the clinic. So she misses a whole day of school. She has to recover from that. And she has to do this every single week and is looking at doing that for the rest of her life. And guess what? Despite all that, she is still a very sick kid. So this newspaper article was last year. Since that time, she's had a heart attack. She's had severe valve disease. Just last month, she had to undergo open heart surgery to get bypass surgery as well as replacement of one of her valves. She's 11 years old now. So a very severe presentation of heart disease. Now this particular article, as you can see from the title, asks the question, can CRISPR fix the problem? CRISPR being a gene editing tool that you've probably heard about in the news. Gene editing is a technique that potentially allows us to make changes to the DNA in all of the cells of our body. And I think the answer is yes. And the reason for that is this person. She's not actually a patient. She's actually what we would call perhaps a genetic superhero. She's actually the opposite. She's surprisingly well. And so she came to attention quite a while ago, actually, say about 20 years ago. She was attending an employee health fair. She had a spot cholesterol check, and it was very, very low. So low that the physician at the fair had no idea what to do with that. I've never seen a value so low. So referred her to a lipid specialist who found that she had not only low cholesterol, that's what we usually think about as a driver of heart disease, but also low triglycerides. That's the fat content and the cholesterol-carrying particles in the blood. So like a double whammy, both very low, with no explanation. And it took more than a decade to figure out what was going on. It turned out 3 of her siblings had the same condition. And so about a decade ago, when I was a postdoctoral fellow up in Boston, had the opportunity to study her family's DNA and use a very new technology at the time called exome sequencing, and was able to figure out that she and her siblings are naturally born with a particular gene, a particular protein, turned off. A gene called ANGPTL3, a mix of letters and numbers. It's not that important exactly what that means and what it does. But the point is, by having this gene turned off, these people naturally have low cholesterol levels and low triglyceride levels. And since that time, we've searched the larger population and found that about 1 in 300 people have won the genetic lottery. They're born with one of the 2 copies of this gene turned off, so it's turned down halfway. And they have lower cholesterol levels, lower triglyceride levels, lower risk of heart disease, and the evidence suggests also lower risk of type 2 diabetes. So when I say have won the genetic lottery, I really mean that. It's a quadruple whammy. And so you're probably thinking, wow, I wish I was that fortunate. Now here's the thing, with gene editing, we could potentially take what has naturally occurred in her and her siblings and apply it to people at risk for heart disease, which, as we've already discussed, is most of us, or many of us. And so what can you do with gene editing? This is work from my laboratory and collaborators of my laboratory. These are liver samples. These are mice, not humans. But the same effect can be produced in the human liver. What you see on the left is a protein that causes disease. That's what's stained in brown. And what we can now do with gene editing with technology like CRISPR is actually turn off that gene and eliminate the protein that causes disease across the entire liver. And you can look on the right and you see that brown stain is almost entirely gone. And we can do that with gene editing. So what's the strategy here? Well, let's use gene editing to turn off that same gene that was found in that genetic superhero and apply it in a patient like Avery Watts and treat her condition. So we had a mouse model that has the same condition as Avery Watts. It has the same genetic mutations essentially that she does that causes her sky-high cholesterol levels. And what you see on the left is a plasma sample. So it's a blood sample with all the red cells removed. That's why it's not red. But you can see on the left, you can see it's translucent. You can see all the lipid content, all the cholesterol, the triglycerides, gumming it up. When we use gene editing in this mouse model to turn off the ANGPTL3 gene in the liver, you can see what happened within a few days. It is entirely cleared up. And that is a permanent effect because we are changing things at the genetic level. It's not a pill you have to take every day. It's not an injection you receive every few weeks. It is once and done. So that is the potential. So now imagine Avery Watts, if you took her blood right before she undergoes the dialysis-like procedure, that's what her plasma looks like on the left. Now imagine if we can develop a therapy with gene editing to have the same effect you see in these mice. That would be transformational for her. She would no longer need to undergo dialysis every day. She could live a full life, not have to suffer from heart attacks and valve disease, probably ongoing for the rest of her life, have to undergo additional surgeries. It would be truly transformative for her. Now, she's unusual. She's rare. Her condition only strikes a few thousand people in this country. What about the rest of us? Because that's how I started this problem, right? Is the #1 killer. Well, it turns out this same treatment would not just be beneficial for her and other severely affected individuals like her. It would actually be useful for all of us because we know that cholesterol and triglycerides to some extent are drivers of heart disease, and it's drivers of heart disease in all the people who are getting heart disease. So in theory, the same exact treatment would be relevant not just to these unusual individuals, but to all of us. And so you can imagine applying it broadly across a population. You could apply it as a preventative, in a sense, and give it early and permanently reduce your cholesterol levels, triglyceride levels, and give you lifelong protection against cardiovascular disease. You can start to see how this might play into a strategy to tackle the #1 killer in the world, the global health problem. Giving pills every day, giving expensive injections every few weeks, that's not going to tackle a global health problem. But a vaccination-style strategy might be able to do it. Now you might ask, well, that's fine if you're talking about global health, but practicality is that we already have treatments. We already have drugs like statins that millions of people take. Isn't that enough? Why do we need newfangled technologies, things like gene editing, changing the DNA? Why do we even need to do that? Why not just apply the existing therapies? And it's true that if you could get widespread adoption of these therapies, it would definitely have a beneficial effect, but it's clear that it's not enough. So I want to show you now the statistics in the United States, the causes of death. The green line on top, that's heart disease. And right below that is the blue line for cancer. And you can see it's kind of alarming. It looks like everything's going up, but you have to take into account that the United States population has more than doubled between the time of the beginning of this graph and the end of the graph. And what you can see is that heart disease, we've actually done a reasonably good job over the last few decades in keeping it tamped down and reducing death. It was flirting with no longer being the #1 cause of death in the United States, and what you can see over the last few years is it has started to climb again. And that's almost certainly because of the prevalence of obesity and diabetes. So despite millions of people taking statin drugs, we're not sufficiently tackling the problem. And then there's another issue. Patient has a heart attack, ends up in the hospital, has some work done, has the arteries opened, has stents, and so forth. We always give them a prescription for a high dose of a statin because we know that will prevent the next heart attack. But what we also know is that a year later, half of those patients are not taking the statin for a whole variety of reasons. And this drives the point home, medications don't work if you don't take them. And so a once and done therapy would address this issue in the sense that while they're still in the hospital, they could receive this treatment and get lifelong protection. Adherence no longer becomes an issue. So I've been doing this work in my laboratory for the last 6-7 years now, and it got to the point where a small academic laboratory, well-funded, but still small in the grand scheme of things, couldn't carry it any further. So a couple of years ago, some colleagues and I co-founded a company called Verve Therapeutics. And in fact, the company's first lab was just upstairs here in the Pennovation Center. And a couple of months ago, we graduated. We got to a large enough size that we needed to move to much larger space, and now it's in a growth curve, and we moved just 2 months ago, and we're already outgrown that space, so we're going to have to move again in a few months, and so that's actually good. That's a success story. But this company's goal is to do exactly what I have outlined, to develop a once-and-done gene editing therapy that can be initially given to patients like Avery Watts, who have very severe conditions, and then applied, once we've established its effectiveness and its safety, then be applied perhaps to any patients who's had a heart attack and give them that treatment while they're still in the hospital. And it'll take a few decades to unfold, but then really start to think of it more as a preventative and offer it as a vaccination to anyone, say, around 20 years old who wants to protect themselves from heart disease. And you can imagine applying this widely across the population. And again, we're talking about the #1 cause of death. If you can eliminate it or at least push off heart attacks by decades, it would be transformational. It would improve life expectancy. There is absolutely no question about that. So that is all I have to say, and I have 15 seconds left, so we'll close with that.
Oh, you get bonus points. Please join me in thanking Kieran. Thank you so much. And we are going to have an opportunity after lunch or during lunch to explore some of the concepts here by talking with our flash presenters in a moderated discussion as well. So next, we're going to welcome to the stage David Muhammad from the National Institute for Criminal Justice Reform, and David's going to share a little bit with us about his and his colleagues' approach to reducing gun violence in the city of Oakland. Thanks, David.
Thank you. Good morning. Good morning. Good morning. All right, there we go. First, I want to thank the conference for having me and for everyone here. I do have a 2-hour presentation I'm going to fit into 15 minutes. Always wanted to give a presentation at the Oscars, so I heard there's music that might play if I go over. So I want to dive into this discussion around preventing gun violence. And I know that's a particularly necessary discussion in this city of Philadelphia. But I want to first outline a few things. One, this issue of what is prevention, intervention, reduction, because there's so much that fits in the paradigm of violence prevention. And depending upon who's given a grant for what, different organizations describe what they do as violence prevention, regardless of if that is the actual outcome or even intended effect or not. So a oversimplification of kind of the continuum around violence reduction, violence prevention, violence intervention is this kind of graphic of thinking around prevention. What are those activities that you do that if you are effective at preventing people who have some long-term high risk of engaging in violence or being a victim of violence, if you engage in that prevention, that in 5, 10, sometimes 15 years, you can reduce that individual, and if you're doing it on scale, a large number of individuals' likelihood to be involved in violent behavior. In the middle, the crux of this presentation is around intervention. What can we do right now to help someone, to prevent someone from being in violence in the next 12 months, the next 24 months? And the point here is that is very different. Primarily, it is who you're focusing on. The previous presentation around heart disease talked about first focusing on those patients with the most severe condition who need intervention right now, while trying to develop it out further, decades, he said that could be a preventative way to prevent heart disease and heart attacks. Very, very similar in violence prevention world. Now, there are parts of the city of Philadelphia that don't need an intervention, that don't need the ceasefire program. I would love for those parts of North Philly and others to not need that type of intervention. That would cause a full-scale transformation of those communities. How do we change the full-scale, how do we change the communities entirely so that they no longer need an intervention today? They don't need outreach workers and intervention workers and crisis response because of their income and resources are such that they don't have this level of gun violence. So communities that are plagued by gun violence all over the country look pretty similar. Communities of concentrated poverty and neighborhood blight and the proliferation of liquor stores and low-performing schools, easy access to guns, high incarceration rates, drugs readily available. These are those neighborhoods that also have very high rates of gun violence. So if we change these conditions, we can change the need to have the type of programming that I'm going to talk about. So yes, I would love to work myself out of a job. It would be preferable to not have to have the type of urgent implementation and intervention that we need in so many communities. One side note, about half of the work I do at the National Institute for Criminal Justice Reform is around criminal justice reform, and about half the work I do is gun violence reduction. Most often I'm either talking about one or the other, and the room's full of different people, but really they are very similar work. The work of the youth justice reform that I do is around reduce, improve, and reinvest. Reduce the size of the system, improve what happens to people in the system, and then reinvest the enormous amount of money that we spend on the criminal justice system back into communities hardest hit by crime and violence. Now, the most innovative thing I want to share, this very revolutionary point, is that our actions should be connected to our desired outcomes. And although obviously that's somewhat of a joke, a lot of the work I do in cities to help them develop a gun violence reduction strategy is just to understand this most simplistic of point, that what you're doing should be tied to what you want to achieve. But this is what I get in return. we want to reduce gun violence in the next 12 months. We're going to start a mentoring program for middle school students. A mentoring program for middle school students is great. It will never get you gun violence reduction in the next 12 months. To take it further, gun buybacks, which feel good, and we're getting guns off the street. Every study ever done on them says they have zero effect around gun violence. Now, it's great. Do it. Provide some money to the community, get some guns off the street. Just understand that that activity will never get you the outcome of reduced gun violence. And so what we did in the city of Oakland, we've now done this in nearby Stockton and working on it in a few places, including Portland, because of the chief there at the time, who happens to now be the commissioner of police in Philadelphia, asked us to come work on this program there. So it's a four-pillared strategy. One is identification of the people who are at highest risk to be involved in gun violence. We'll talk a little bit about that. Two is direct and respectful communication of that risk to those individuals. Let them know. Three is offer them services and supports and opportunities that are real, that are transformative, that they can receive immediately. And fourth is focused enforcement, to really take enforcement away from low-level, massive arrest of every small little infraction of the law and focus the limited resources that police have on the most serious issue of gun violence. So it's a partnership of several organizations in Oakland. This only really works as a partnership. Not one organization is at the lead. That has been both challenging and a best practice to really be a collaboration among a number of stakeholders. So number one, data-driven identification of the people at the highest risk. It turns out a very small number of people are involved in gun violence. Despite a popular opinion, it's a small and identifiable population. So we did a protracted study in Oakland, looked at every single gun incident, a shooting incident, an injury, shooting, and homicide over 2 years, and looked at the profile of those both who were victims and perpetrators of gun violence. And so this is, the city of Oakland's about 425,000 people. There's 20,000 too many who are under some form of correctional supervision, who are in the community on probation or parole or various versions of them. And only about 300 people at a time who rise to this level of being at very high risk of being involved in gun violence. A small, manageable population and identifiable population. So 65 to 75% of everybody involved in gun violence in the city of Oakland, that's either victim or perpetrator because they have the exact same risk profile, have this risk profile. 18 to 35-year-old males, quite honestly, Black or Latino males. The average age of a homicide suspect in the city of Oakland is 28. Not teenager, as everybody thought. My quick back-of-the-envelope look at the city of Philadelphia is exactly the same. Two, significant criminal justice involvement. So in Oakland, 65 to 70% of everybody involved in a gun incident, a victim or perpetrator, had 7 or more prior arrests prior to the gun shooting incident. Associated with a crew, gang, group. In Oakland, we don't have like LA gangs, but we have these cliques. And less important is like the gang warfare. More important is this is an identifiable population. The national number one risk of that you'll be shot is that you've been shot before. And so been shot, and then last you have a family member, friend, i.e. fellow clique member who's been shot in the last 12 months. If you have all 5 of those risk factors, but if you have at least 4 of those 5, your likelihood of being involved in a shooting incident, either as perpetrator or victim, is exponentially greater than anyone else, even someone else who's formerly incarcerated. Because those are risk factors specifically of folks who are being involved, and that's a small number of people who have those risk factors. So 2 is we tell them, like a public health approach, you have symptoms of coronavirus, you should be informed of it and take the appropriate precautions. right? So we inform them, not in a scared straight type of way, in a direct, you have the risk factors that make you likely to be involved in gun violence. We want gun violence to reduce. We want you to be safe. We want you to be alive. We want you to be free of incarceration. And you should know that the police department is aware that you have these risk factors as well. And we want to provide you with supports and services to help you move you away from this risk zone. And so third is services, supports, and opportunities. So everybody who was identified of having these risk factors are offered numerous services and supports. So in the city of Oakland, size 400,000 people, there's 14 full-time life coaches that we call credible messengers or life coaches, people who are sometimes formerly incarcerated, all of whom are from the city of Oakland, all of whom have been trained thoroughly on how to engage in a relationship with people who are at the very highest risk. We had to retrain people out of traditional case management. It's not just about service brokering. It's about developing a trusting and positive relationship with someone to help influence their decision-making to make better decisions to improve outcomes. Clients are eligible for a small financial stipend, not a huge amount of money. But unlike the late 80s and early 90s, the people involved in gun violence today do not have money. It's another misnomer. It used to be true. Basically, it was tied to crack sales in the late 80s and early 90s. It's no longer the case. They're broke. Small financial incentives can be incredibly helpful. And there's improved coordination. So small version is in 2000 when we really did a deep dive. 2017, pretty much 100% of the people who wanted a job got a job. Two caveats: they had to want a job. The other caveat is keeping it was a whole other question. But the point being is the resource that we had was that they all got a job. And then there's other several supports. Relocation, people that we know are in imminent risk of being involved in gun violence, we're able to physically locate them either temporarily out of the area in a hotel, or if they have some family to go, we completely relocate them, and other services. The outreach is around identifying the people of high risk, finding them, going to get them. That includes people going into neighborhoods. Some of this is social media now. Connecting with them on social, finding them, and then engaging them in what we call life coaching, which is about a relationship. Then it's about helping to change the mentality, helping to change how people think and the decisions that they make, and then providing the necessary supports and services, employment, housing, mental health, drug treatment, counseling, whatever it is that they need. And then there's focus enforcement. It's having police focus their efforts. I've worked a lot with police departments around the country and have been surprised around the lack of focus, the lack of specific strategy around some of this. Often that's because they say all we can do is respond to 911 calls. We can't be proactive, we can just be reactive. So this is focusing police around, let's focus on stopping gun violence specifically and most importantly. There's a whole working process that's basically just sees as a million meetings that says focus, focus, focus. It's easy for police to say we're just going to start responding to 911 calls. It's easy for services to say we're going to work with the cute 16-year-old, not the hard-to-deal-with 25-year-old gang member. And so we have to constantly say, are we focused on the right people? Are we focused on the right people? Are we focused on the right people? And when we do that effectively, it's incredible outcomes. This are the outcomes. So in Oakland, 6 consecutive years of decline, 50% reduction in the number of injury shootings and homicides in the city of Oakland. Northeastern and Northwestern universities just did an evaluation, a long, protracted evaluation, and said that 65% of the city's decline in violence is specifically due to this strategy. They also controlled for gentrification, which was huge. And the small outcome of that is the census tracts in Oakland that had the least amount of demographic shift had the greatest amount of violence reduction. And last thing I'll say, the cost of violence is enormous. So my organization has done a study now in 10 cities across the country. This is one in Dallas where we looked at what does it cost society, the government, taxpayers to respond to a shooting. These are deliberately low figures. In the city of Stockton, California, where we just finished a study, it's $2.5 million per homicide. when you consider all the government response. So you can never say or hear from a politician or government official, we don't have the money to invest in intervention supports when we're paying it on the back end on the violence when we respond. So we have done this in Oakland effectively, and we continue at it. We've done it in a few other cities, and I'm certainly hoping to talk to our good people here in Philadelphia to help reduce gun violence here. Thank you.
Thank you so much, David. We're going to bring to the stage now Davis Herman. The panel this morning referenced Davis a few times. Davis he's an innovation design strategist from Penn Medicine's Center for Healthcare Innovation. Thank you so much, Davis.
All right, thank you. All right, so I'm presenting on behalf of Julie Dees, who's the Director of Behavioral Health Services at Penn Presbyterian Hospital. Unfortunately, she couldn't be here today, so you have me instead. This is the wonderful team that she's leading. I'm one of many folks contributing to this project. So a quick introduction about sort of the problem space that I'll be dealing with here. So as you may know, Philadelphia has by far the highest rate of opioid overdose death of any major city. Last I checked, Chicago was second, and we're lapping Chicago and then some. So it's a big, big problem. It continues to be a big problem. What may be less familiar to you all is that it's not just a Kensington problem, and it's not just a South Philly problem. There are opioid overdose deaths happening all over the city every year. So we looked at some historic data, and we saw that Penn Medicine's emergency departments are at the front lines of this crisis. So conservatively, we estimate that there are about 2,100 visits from individuals who have opioid use disorder, OUD, at our 3 center city emergency departments every year. And the truth is, it's hard to find tools that work in dealing with this crisis. Historically, rehab and detox were the standard treatment, but these modalities alone have a relatively low success rate. For the people they do work for, it's transformative, but there are many more for whom this isn't effective. On the other hand, there are medications that we know work quite well. Medications like methadone is probably the most familiar to you all, also naltrexone. And I'll be focusing mostly on buprenorphine, or BUP for short, because it can be used, it's legally allowed to be used in the emergency department, which is especially important for this presentation. Buprenorphine is a really incredible drug. It does some important things, like it controls withdrawal, and it also prevents or protects patients from overdose. So those two effects help to keep patients safe and feeling well. We also know that there's another tool that works quite well, and that is peers. So this has come up in a few instances already today. These are individuals who have a lived experience with substance use and who are in long-term recovery themselves. You see Nicole and Bryant here. They're what's called certified recovery specialists, meaning they have specialized training in guiding other individuals with opioid use disorder through recovery. Now, we do have good tools, and we know they work well. But when we started this project a few years ago, we saw that about 175 individuals with opioid use disorder came to the Penn Presbyterian ED each month. And of those 175, only 10 were started on buprenorphine, despite its effectiveness, and only 4 had a peer recovery specialist come to speak with them, despite the effectiveness of that intervention. And so in effect, we were underusing our very best tools in the midst of a crisis, and so we knew we had to do much better. So we started with months of shadowing, interviewing, secondary research, data analysis. I had a heck of a lot to learn because my background is in design, not behavioral health. And we identified a whole range of barriers that were preventing these important tools from being used. Those barriers fell into 3 buckets, which you see here, and I'll go into more detail about how we address those barriers. I'll also tell the story of how what began as sort of a plucky project is now a more established program, which is called CORE, Center for Opioid Recovery and Engagement. So I'll start with identification. There are a few barriers within this bucket that I'd like to focus on. The first being that patients who have opioid use disorder are sometimes difficult to identify. One example of that is we found that 75% of ED visits from patients with opioid use disorder were for reasons seemingly unrelated to substance use. They could be coming to the ED for any number of reasons, and it was sometimes hard to tell that these were the patients we were interested in. Secondly, our providers and the ED were not totally aware of all the available resources that these patients had access to. And then finally, the process for requesting a peer, a CRS, to come speak to a patient, although that service was available, that process was manual. You had to remember to do it, and it was relatively time-consuming. And that's a difficult ask of a busy ED provider. So I won't go into too much detail here, but suffice it to say we did some data analysis up front, and one of the things that really left off the page is that we were just missing many, many opportunities, as I already covered, to use these important interventions. And so we hypothesized that we could do much better using a more proactive method of identifying these patients. And so to test this, Roy mentioned rapid validation. The quickest, least expensive, but also effective way to do this we decided was for me to sit in front of my laptop pretty much all day, every day for a number of weeks, look at the electronic health record and try to find patients who are in the ED at that moment who might benefit from a peer counseling session. And what we found right off the bat was that we were identifying many more patients than we were at baseline. The recovery specialists were able to take action. The information that I sent to them, I actually sent it directly to their cell phones securely. They're able to take action very quickly, have very meaningful consults with these patients. And I think what surprised us most is that these providers who were used to requesting a consult were very happy to have the CRSs arrive proactively in the ED. They were, any help was very welcome. But I have to sleep sometimes, so it wasn't really a scalable solution. And patients arrive at all hours of the day and night. So what we did is we abstracted some of the lessons that we learned, namely what to look for, and created a system for automating identification. And so now we have a system running in the background of the health record at all 3 of our downtown EDs, looking for patients who who have certain characteristics. And if we find someone who we think is at high risk for opioid use disorder, a message like the one you see here goes directly to the phones of our peer recovery specialists. It's been a tremendously effective way of doing identification, and I'll get more into the impact in a little bit. So the second bucket I want to talk about is ED treatment. So once patients with opioid use disorder are in the ED, we wanted to ensure that they were receiving the most evidence-based care possible. And so we identified a few barriers here, the first being that not all ED providers at the time were trained in the use of buprenorphine. It wasn't really a frontline treatment at the time that we started this project. And secondly, not all patients can start bupe or want to start bupe. Obviously, they have agency, and so we can offer these treatments, but it's up to them whether or not they want to accept them. And then finally, there is a significant amount of stigma that exists around substance use, and we found a need to make some culture change happen in the ED setting. So I want to take a minute to show you that by the time this project began, there was a growing sort of base of evidence that the use of bupe in the ED was very effective. And so this study is from 2015. It found that ED-initiated bupe more than doubled engagement in treatment at 30 days. So these ideas weren't totally novel. We were building off of a growing evidence base. So Dr. Perrone, who's pictured here, is a fabulous emergency medicine physician. And when we saw that only about 5% of our ED physicians had the legally required training to prescribe buprenorphine, we knew we had to do something about that. And so she devised a way of using financial incentives to prompt ED faculty to complete the required training. So now, I think actually at this point, above 90% of ED faculty are trained to prescribe buprenorphine, and so they're much more comfortable with the treatment, and they're legally able to prescribe it. But of course, having training is one thing, but actually doing the thing is a different thing. And so we found that oftentimes when ED physicians were reluctant to start a patient on buprenorphine, it was because they weren't sure if or how that patient would continue that treatment after discharge, which makes perfect sense. They had the interest of the patient in mind. And so the reverse is also true, that having somebody who can ensure that the patient's connected to treatment after discharge is a really great facilitator, and it frees up ED physicians, making them feel more comfortable with prescribing buprenorphine. And this is based on research by my colleague, Dr. Lowenstein. And so now, I'm sincerely hoping a video plays successfully that'll explain why it's important to have a peer in the ED engaging with patients.
So the core model is really unique in that we're using IT support to identify patients more rapidly, and then getting peers to the bedside, and then the patient is speaking with somebody who they have confidence in before they get confronted by a clinician. Our certified recovery specialists, which can go by other names, peer counselors or drug and alcohol counselors, but these are people with a lived experience, and it doesn't help when I, in my white coat, go to a patient and say, you should really try this. What they see is judgment, shame, guilt, me telling them that they should do this. When it comes from Nicole or Bryant, they see somebody who has struggled, and they see role modeling, and they see, an opportunity for a future that they don't see. Unfortunately with me, I might have good intentions, but it just doesn't look the same.
You feel like nobody understands you, you don't really want to talk to people that don't have the experience you do. So seeing these guys come in that had 10 years, 12 years, it definitely gave me hope.
That was Eileen at the end, and you'll hear more from her in a little bit. So I mentioned culture and stigma. These are very sticky problems to address, but we attack them from a variety of angles. So I'll share two, or actually three. So on the left, we did a good job, I think, of sharing congratulating physicians who collaborated well with us and, from our point of view, did the right thing. And so we publicly displayed messages of thanks in the emergency department to make them feel good about collaborating with us. On the right, we gave pins for physicians to wear when they prescribed buprenorphine for the first time. And this was supposed to be a social norming strategy to sort of make buprenorphine a visible and noticeable first-line treatment in the emergency department setting. All right, so I think the slide before unfortunately didn't show the background, but I wanted to share that we also hosted a story slam at the College of Physicians. We invited the Penn community and the Philadelphia community more broadly to come in and hear stories firsthand from individuals who have experience with opioid use disorder. That was one of the strategies that we used to hopefully address stigma. So the last bucket I mentioned, continued treatment and engagement. So once a patient leaves our care, we want to ensure that they receive or that they continue their treatment and that we're able to prevent drop-offs, address barriers as they arise, and basically stay engaged with these individuals over the long term. It's difficult because this is a very vulnerable population, and so they face very significant barriers in continuing their treatment. And it also makes engagement difficult. Just to give you an example, a majority of our patients do not have reliable access to phones. Their numbers change often, or they lose their phone, or whatever the case may be. So it's a very challenging thing to do. One strategy that we use is Nicole, as you see here, and Bryant, and our third recovery specialist, will go out into the community at least once a week to engage with patients in person. So we're doing direct outreach. We're having discussions with folks, building rapport, but also providing material items, food, anything to keep patients safe and healthy. We've experimented as well with various forms of sort of automating check-ins. And so what you see here is an automated check-in to a patient that we engaged with in the emergency department to see how they're doing and if we can address any barriers that they were experiencing. Sometimes these messages went, they didn't have a response, but other times we were given some really actionable information. And so in this case, we learned that a patient had gone missing. We were able to track this person down and re-engage them in treatment. So a very light touch automated solution to finding and addressing present needs that our patients are facing. All right, another video real quick.
We're invited in to their life so we can help them reduce the harm that they're going to face from using.
Whether it's minimizing their drug usage, creating safe places for them to go, sterile environments for them to use, it's keeping them alive long enough for them to get the help they need.
Like for once, I want to do right. I mean, I'll be 42.
But it's not for once. You've wanted to do well before. Like it's not. Yeah. This is not for once. Like
I know, and it, like that's the thing. Like it's not a one shot, one deal thing. Like a lot of people can't get it on the first try.
And we never stopped. We never stopped looking for him. We never stopped talking with him, engaging with him, and providing him the resources that he needs. And when he found it was his time to seek help, he reached out. He reached out to CORE, and he's now in recovery, in IOP, and living life.
That was a little bit of Jimmy's story. So now some of the impact that we've had and where we're going next. Oh boy. Well, suffice it to say, the CORE model looks a little bit like this. On the left, you have the roles involved. It's a combination of a program manager, certified recovery specialist, care coordinators. It's a real team effort. On the right, you have the 6 sort of pillars of our intervention and the 3 settings where we're currently active. This is Eileen's story.
I thought recovery would be easier than what it was in the beginning. I thought I would be able to just go to the detox and then I would be good, you know, and like I got it out of my system and the physical thing was gone. I thought I would be okay, and that wasn't the case. I stopped doing the Suboxone and I relapsed kind of on purpose. Like I was in a really bad place in my head, so I went and got a bunch of heroin and tried to OD. Basically, I did it like to myself. This was my last chance. If I didn't get sober this time, I would be out on the street. I'd probably be up in Kensington, nodding out somewhere. I needed help. My name's Eileen, and I have been in recovery from opiates for about a little over 5 months now. When I went to Penn, when the core team showed up immediately, and they immediately started talking to me about getting what my next step was to get in recovery. They got me registered in the Suboxone clinic. It was like an immediate action. It didn't give me a chance to go back out there and change my mind. They basically like picked me up and put me into this, you know, into this program, which is what I needed. It's always there. There's a lot of communication happening. They're always making sure, like, if I, for some reason, like, miss an appointment or something, I have, like, 4 phone calls, you know, making sure I'm okay. And if somebody's using and they get to that point where they're ready and they're done, CORE is definitely the right pathway to get started on the recovery journey. I have all these things to look forward to now that, you know, I didn't even think about before. I wouldn't have any of this without Nicole and them.
I think Eileen's story encapsulates sort of how the core intervention looks for an individual patient. And so I'll keep this quick because I'm officially out of time. Some of the impact, more quantified. So we're currently serving 3 hospitals and the Crisis Response Center at Pennsylvania Hospital. The use of BUPE has increased dramatically in the emergency department. We're completing many, many more peer recovery counseling sessions than we were before. ED providers love this program. They gave us a 90 Net Promoter Score, which is considered to be world-class. 10 times as many patients are being connected to treatment at discharge. 14 times as many remain in treatment for at least 30 days when they have a peer supporting them and also medication. And then finally, a very conservative estimate of 200 overdoses prevented each year as a result of this work. And that's all I've got.
Much service. And we're going to invite Jehan Luth to the stage now. Jehan is another student in our Master of Law program. He is the founder of Rotomare, and he is going to talk about how he and his colleagues better connect manufacturers of recalled goods with the ultimate consumer.
Thank you. Well, good morning, everyone. It's great to be here. I will give a shameless plug later on about the Master in Law program, and not just because everyone from the law school is here, but to the earlier point being made about this Silicon Valley approach of testing hypothesis really fast. It's very, very important, I think, in the dawn of the technology era for everyone to be equipped with legal knowledge, not be a lawyer necessarily, but at least understand the framework around privacy and data and things like that, which ties really well with what I'm doing now. So Rotomare is a company which has pretty much 2 goals. You know, the first goal is how do we keep people safe from product recalls? And the second is how do we keep businesses from filing bankruptcy post-product recalls? So it really does help both sides of the equation. But it really started from a very, very personal story. I had someone really young and in my family who I was driving, and she was in the car seat in the back, and slammed the brakes, as you would on the turnpike, and she got unbuckled from her car seat and hurt herself pretty bad. You know, after we made sure she was okay, contacted the manufacturer, and turns out the car seat was recalled for the last 6 months. So that's when all of this really started for me, and diving deep into how do we solve this problem, right? Go in a store, you buy something, you're not a part of their loyalty account, you're not a part of their recording system that keeps a track of you, yet when a recall happens, I want them to notify me. It's this constant dilemma of how do you use data to do good? And that's something we struggled with quite a bit because financial data, as most of you might know, is as regulated, if not more, than health data, right? There's a lot of rules that govern credit card data and what you can and cannot do with it. But we figured a way out, and we figured that there is a way we can tell you about a recall that affects you without ever needing to know your name, your identity, your card number, any of that information. And that's where we realized problems like these that really affect all of us aren't something we could just create on our computers. It was actually a solution that involved a lot of relationships, a lot of partnerships with large financial institutions, partnerships with large retailers who are also facing a problem in a similar instance. And to the points being made earlier, following the payment, recalls is a tricky space. It's product liability at the end of the day. So someone gets dinged for recalls. And at first, we thought it was the consumer, but it's really not. I'm sure there's people in here who have experience in class actions and that side of liability. But how do we really make this and formulate the solution to be a win-win for everyone? Otherwise, we're not getting in the door with retailers. We're not getting in the door with manufacturers. The manufacturers' insurance companies are not going to let us work with them. Consumers are not going to let us work with them if we're doing funny things with their data. And banks will never work with us if we ask them for data. So there were quite a few pieces to the puzzle. I have a couple examples, and I haven't asked Starbucks for their rights on these images, but these are actually fairly common. There's just shy of 5,000 recalls a year, and each recall hits about 300,000 units. So if you think about it, it is a very large problem that can affect all of us. And sometimes the problem or the severity is different. It can be salmonella and cause a little stomach bug and you get over it. Sometimes it's your car and it can cause much bigger problems. But I guess the crux of it is we were able to find a solution to this really complicated problem by relying on knowing the law around data, right? That's really, really important. What happened while we were solving this problem is we realized that we actually solved something much bigger, something much greater. Ralph mentioned earlier about hovering over the patient post them leaving a hospital. That data is incredibly valuable, right? There's a lot of the biggest diseases we know of are actually diseases that are rooted in our lifestyles, and they're not caused by X, Y, and Z. And because of that, when lifestyle is such a big factor of us, how do we even figure out what products and what are we buying that overlaps, and how do we even analyze such data? There wasn't a way. And so what we realized once we were building these systems out, that now we can actually do very in-depth analysis across retailers, knowing what one person bought at multiple retailers without ever knowing their identity or their name or their credit card number. We've realized the value for something like this has really changed. We can do clinical studies now that really highlight that, all right, if you buy these 10 products, your likelihood of X, Y, and Z is here. Versus if you buy these 10 products, it's here. And maybe things like sugar, which seem pretty obvious to our eyes, but are very hard to back up with data, maybe we can finally start getting into that space. But there we go. The crux of what we've done is, what's funny is you might actually never know we exist, and we really like that. The service we have built relies completely on the back end. So we provide this to retailers, and retailers, in turn, offer it to consumers that shop there. And then financial institutions provide recall protection as a card member benefit. So we're the ones that run the service for everyone, but you never know of us. And I think that is really, really important. Other than that, one part which I think I'm going to come back to, and this is the the Master in Law program part. Innovating around this, so as you can imagine, linking a purchase back to your card without ever knowing who you are is incredibly complicated. It's quite challenging, and it's very important, as we've probably seen in the news with quite a few large tech companies often being the poster child of data privacy related issues. You see their founding team, they didn't know much about privacy regulations. Granted, back then, privacy wasn't such a big, important topic, but I think one thing which is potentially, hopefully a call to action for a lot of innovators is learn the law. Learn what you can do and learn what you should be doing, and then innovate around it, right? There are a certain set of principles that are meant to keep people's data safe, and we learned that, and we were able to innovate. With that being said, I now have a couple minutes, so I'll give my time back. Thank you.
Thank you, Jay. Thanks so much. Okay, so I'm going to invite to the stage now our fifth and final presenter, Margot Brooks-Carthen, Associate Professor of Nursing and Senior Fellow at the Leonard Davis Institute of Health Economics. And Margot is going to talk about how she and her colleagues use design thinking to improve post-discharge conditions for patients with socially significant challenges.
Thank you. Good afternoon. I think I am the last person standing between you and lunch, so I promise to be mindful of our time. So I'm really excited to talk to you today about how we use design thinking to address the needs of patients with significant social needs. But before starting to talk about how we use design thinking, I thought I would share a little bit about myself. I am a nurse. I've been a nurse for over 20 years. I am a researcher, and I'm not someone who thought of herself as an innovator, to be quite honest. A few years ago, if you'd asked me what innovation was, I probably would have pointed to my cell phone. And I actually felt like innovation sounded a little buzzwordy, but I am a researcher, and for the past decade, I've spent a lot of time looking at the needs of patients who have high social needs related to socioeconomic challenges, the neighborhoods they live, racial ethnic background, and what you've heard today from a number of speakers is that they're more likely to experience poor outcomes both during and after a hospitalization. And so my work has looked at the interface between the healthcare delivery they receive, particularly by nurses, and the outcomes that occur as a factor of variations in care quality. And so, like all good researchers, I've published extensively in well-respected journals, but after doing this work for some time, was increasingly frustrated with the lack of progress that I was seeing in terms of outcomes. And so that's not altogether unique in my work. It can take up to 17 years for published research to move from publication to practice. But if I add 17 years to my current age, I'd be retiring or near retiring. And so clearly that's much too long to wait, not just for me, but for the patients we serve. And so I was looking for a solution that would be straightforward, that would allow me not only to deeply discover the challenges patients with high social needs were facing, but also to rapidly produce solutions with the potential to scale. That's when design thinking entered, and that's where our clinical pathway was born. Typically, when we think about design thinking, there are generally 4 phases. Today, I'll talk to you about a few that our team use, and those are discovery, where you kind of take a deep dive into the perspectives of the patients in our case and the providers, the healthcare system, to really understand deeply the context of their problems, and also the processes that are in place currently to address them. And then, because some of these problems are so big and complex, it's important to narrow down in terms of what you'll focus on and your outcomes and metrics of interest. From there, we move to develop, and this is where you brainstorm, where you think globally and about some of the potential solutions to the problems that you've identified, and finally, rapid cycle testing that we've heard about today. And all of these are the steps that we went through to develop our intervention, which is called Thrive. Our academic clinical partnership was sponsored and funded by the Leonard David Institute of Healthcare Economics, and we are housed in the Penn Presbyterian Medical Center, which is located in West Philadelphia. And this specific area of West Philadelphia is an Obama Promise Zone. In 2014, the Obama administration designated certain cities across the country who were known for having, at one, the opportunity for revitalization, but two, had disproportionate rates of poverty, lower educational levels, and high housing vacancies, among other indices. And so as the safety net provider, Presby has a unique opportunity to also care for some of the city's poorest and sickest patients. And so we knew that our patients who were coming in for a medical hospitalization were also facing these social challenges. We wanted to know more about them because we know these social challenges get in the way or hamper recovery post-discharge. And so the first phase of the design thinking process is the discovery phase, and this allowed us to do what we call kind of contextual inquiry, and we spent probably hundreds of hours in the field doing focus groups, doing one-on-one interviews in homes, in the hospitals, shadowing and observing. And it was during this time where we met Andre. This isn't Andre pictured here, of course, to protect his privacy. But we met Andre during our field work, and it was in his home shortly after a hospitalization. Andre was in his early 50s. He'd been hospitalized for a small bowel obstruction surgery, and he came out of the hospital with a colostomy bag, which is a plastic apparatus that holds your feces. Andre lived in a one-room apartment with people who were actively drug using. Andre was pretty weak when we found him or when we saw him for the first time. We asked him how he was managing his new colostomy, and he said he was changing it every day, and that was concerning because he was supposed to be cleaning the bag, not changing the bag. And so we knew in the back of our minds that Andre would run out of his equipment sooner than later. We asked Andre when his follow-up appointment was for his surgeon, and he said he had an appointment, but it would take him an hour and a half on SEPTA, one way to get there. Andre barely looked like he could walk to the local drugstore. We asked Andre, well, what are you eating on a daily basis? And he said mostly eggs and spaghetti, some of the cheaper things that you can find at the local grocery store. We asked Andre if he had a primary care doctor, and he said, I wasn't sick before I went to the hospital, so no, I don't have one. And so we asked Andre, what are you going to do when you run out of supplies for your colostomy? He said, I'm going to go down to the ED. So you might think, well, surely healthcare systems have ways to address some of these things when Andre was in the hospital. But what we found is quite the opposite. What I know from a lot of the work that I do related to nursing care delivery is that nurses are well prepared to identify patients like Andre. They know what social risk factors are, but they're hampered by other tasks and responsibilities in the hospital. So taking deep dives into transportation and housing is beyond their capacity when they're focused on medical stabilization, documentation in the electronic health record. There was really limited communication between providers who were inside the hospital and who work outside the hospital. And when we went from unit to unit, there were different practices. Some units would say they would call social work. Some units said they might call a community health worker. Some people say they avoid asking those questions altogether because they don't even have the answers to them. And so patients like Andre fall through the cracks or they're lost in the crowd. So we asked ourselves as a team, what if? Which is kind of like one of those perfect design thinking questions. So what if we could use predictive algorithms to find patients like Andre? And what if after finding Andre or patients like him, we could connect him to post-discharge support? What if we could connect providers who work on the inside of the hospital and the outside of the hospital using cellular technology or an app? And what if we could reimagine the way clinicians, the same clinicians that are in place, not new clinicians, maybe we can reimagine what they do so that they could provide a better post-discharge support system for patients. And that's what we have developed and attempt to do with Thrive. Thrive patients are identified during the hospital using a predictive algorithm that we developed. Those patients are presented with an opportunity for a home health referral. Within a day, at maximum 2 days, patients receive a home care visit from a nurse who serves as a health coach. And in that role, the nurse is able to provide extensive post-discharge education, help with medication, transportation, bring in social work if necessary. And one of the things that we think of as a game changer is that the home care nurse is now able to speak directly with the attending or the physician who cared for the patient during the hospitalization. So back in the pre-Thrive days, a nurse would go in and kind of, it's the wild, wild west. And maybe you can connect with a primary care doctor, but in a case like Andre, he didn't have one. And so you're left to kind of figure out and pick up wherever you can. And now we have the opportunity because physicians have said, I'll stand in the gap and I'll provide supervision, and that nurse can call me for up to 30 days or until the patient has seen their primary care doctor or specialist. And so with Thrive, we've tried to create more continuity of care, more cross-sector communication, and more support, both medically and socially, for patients who have high social needs. And so I have to say that was a really beautiful graphic, but this is where we really began with Thrive. During the development phase, it wasn't pretty. It was messy, to be quite honest, but it was also something that was pretty unique for me as a researcher to be able to go in with kind of the limits off and to be super creative, and there was no bad idea. It was kind of come with your biggest, boldest. If price wasn't an option, if you want to build new houses in Philly, if you want to use FaceTime, like whatever it is, we just kind of put it out there. And it was through this process, and I have to say, like, some of the ideas we had did include, like, why can't we send text messages to caregivers in real time to let them know what's going on? And why can't we use FaceTime as the apparatus to have, healthcare providers talk? And, those ideas are great. And some of them, there are challenges because patients don't always have cell phones, and there are data costs to texting them, and FaceTime isn't HIPAA compliant. But these are all things that were on the table, on Post-its, on the wall. And it's through that ability to pull from multiple attributes from multiple solutions that we were able to end up with Thrive. So we're currently in rapid cycle testing. We launched Thrive in April of 2019. In phase 1, we just focused on West Philadelphia zip codes. We had 2 referring attendings from the medicine service, and when they were on call, they would send us their patients through Thrive. We've now moved to all Philadelphia zip codes, so if you're a patient in Philly and you live in North, Southwest, beyond West Philly, it's okay because we can now service you through Thrive. We've had over 30 physicians send us Thrive patients, and we are now soon going to be thinking about how to automate our referral patients. And so of those 70 patients, 100% receive a home care visit. And that's important because when we did our pre-implementation work, we found that of the patients who were Thrive eligible, about 20% were getting a home care referral. So right away, we were able to provide a service that they weren't currently getting. And I have to say that on average, our Thrive participants are 54 years old. So they're not patients that you typically think about, at least on the acute care side, as someone who would need home care. They don't even think about themselves as needing home care. They're like, I don't need anybody to come wash me up or help me with those, help me cook. And those are the kind of things that we've been able to actively educate patients about the benefits of home care. Patients are seen rapidly, and our goal is to really get to them right in the space where they might be experiencing a challenge. We knew that relationships with primary care and specialty care could be porous and tenuous at best, and so 80% of Thrive enrollees see a PCP or specialist within 30 days. We've decreased readmissions and ED utilization by 15% on both of those indices. And so I wanted to kind of end here with Derek. I told you about Andre, who obviously did not have the benefit of Thrive. but Derek did. He was 51. He was in the hospital. He's a single dad with hypertension, diabetes, obesity. He didn't even want to go home. He wanted to go to a shelter after discharge, but the shelters were full, and so he did go home. But when we called the day after his discharge to set him up with Thrive, he said, no, I don't want home care to come. My house is rodent infested. There's drugs and fights. It's not safe. And so it actually took us 12 days before we got him to agree to a home care visit. So one of the things our home care nurses do, which we on the inpatient side didn't know, is they'll see you on your porch. And that's what we said. We'll see you on the porch. We'll see you on the basketball court across the street from your house. Because the very concern he had for having someone come to his home is the very need we wanted to be able to address. And so after 12 days, he let nurses come in, he let social services come in. They were able to help connect him with transportation and shelter. He now lives with his niece. His diabetes is under control, and he's not been back to the hospital for a readmission or an ED visit. And so it's through these stories, and there are many, many more like Derek that keep us motivated. I'm going to end now by introducing you to the team. I started by what brought me to innovation and design thinking. And to be sure, design thinking was the fuel that got us started, but this is the engine that keeps us going. And when I introduced my colleagues to design thinking and innovation, I'm sure they thought I had gone quite mad, but they jumped off the cliff with me. And I'm just so grateful for them for sharing this experience and this journey with me. Thank you.
Thank you so much to Margot, and thank you to all of our Flash presenters. Can we give all of them a round of applause? It's really, really difficult to do this in 15 minutes. So these are all really, really different innovations. There were some common themes that came up, and I know we have lots of questions for our innovators. So we're going to break now here in Philadelphia for lunch and come back at 12:45 for a moderated discussion among them. For those of you joining virtually, please keep the conversation going. #Law2030, #Future of the Profession. Those here in Philadelphia, you can grab your lunch, mingle, and then bring your lunch back to the main area. As long as we're back here by 12:45, we can keep eating while we talk. Okay, thank you so much.
This conference makes so apparent the legal profession is in a state of rapid change, and many law firms risk being left behind if they continue to rely solely on the quality of their legal services to sustain future business. Pepper Hamilton recognizes that clients view excellent legal advice as a table stakes capability, and that true differentiation requires a commitment to innovation across both core practice areas and critical support functions. By investing in creative price structures, multi-model project management, and new technologies in both the litigation and transactional arenas, Pepper can deliver bespoke solutions to clients in a transparent, secure, and collaborative manner. Visit pepperlaw.com to learn more. 2009, Pepper Hamilton and Troutman Sanders announced that the firms had agreed to merge effective April 1st, 2020. The new law firm, Troutman Pepper Hamilton Sanders LLP, or Troutman Pepper, will have 1,100 attorneys in 23 offices across the country. Troutman Pepper will offer expanded capabilities and practice strengths while continuing to deliver powerful solutions to clients' legal and business issues with a hallmark focus on client care. From a deeper bench and expanded geographic footprint to innovations in technology and service delivery models, Troutman Pepper will bring together the complementary strengths of both firms to provide new opportunities for clients. Each firm brings a breadth and depth of experience serving clients in a multitude of areas, as well as complementary industry strengths spanning most of the industries critical to the U.S. economy and providing a natural client and cultural fit. These include flourishing corporate, litigation, intellectual property, tax, and bankruptcy practices, among others. Health sciences, energy, real estate, construction, insurance, financial services, private equity, and technology are the largest industries served by the combined firms. Troutman Pepper will have an office in 8 of the 10 largest U.S. markets. The firm's expanded footprint creates more robust practices in the Southeast, Northeast, West Coast, and Midwest regions of the country, and a foundation for further strategic growth.
sound like something that was really relevant for me. But as I was listening to so-and-so talk about what they did, I realized that this has real implications for legal. So we wanted to take an opportunity to delve more deeply, to examine some of the contours of the innovation. And we are thrilled to be joined by two of our Future of the Profession Initiative Advisory Board members, David Perla, who is the co-COO of Burford Capital, and Sozi Tulante, who is a partner at Deckert, to facilitate our conversation. So I'm going to turn it over to them now. Thank you, David and Sozi.
Okay. Hello, test. Thank you, Jen. David and I we couldn't stop talking about the presentations, and so we wanted to be able to sort of dive in. We have it triggered a lot of thoughts and a lot of ideas. David he's an innovator, and I'm the big law partner. So we're going to divide it up. He asks innovative questions, and I'll just be sitting there being wowed by what you guys say. So, David.
It's a great. Well, first of all, thank you all. It's inspiring. It's very rare to come to these and be inspired, which I think anyone listening was. So thank you. And what we do in law doesn't feel quite so innovative listening to these. But we have some questions. Some of them are actually going to be tough questions because one of the challenges we're trying to overcome is how do we learn from other disciplines in law? And a lot of the problems we're trying to solve in law are macro problems or national problems. And so we're going to talk about that. I think the first question we really want to get to, because all of you touched on it, you all in different ways said the word funding or how things were paid for, is when you look at the cost of what you were doing, how did you persuade someone to fund it? And maybe, David, we'll start with you in particular, where the costs of failure are higher than the costs of success, but they're borne by different people. Right, so then how do you convince someone who doesn't necessarily get the benefit to fund what is a very expensive experiment?
There's a good, very good question. So I'll try to be brief because there could be a 3-hour answer to that. So one example that is also an innovation that I didn't get a chance to talk about, so thank you for the question. The city of Oakland decided that it was going to have a ballot initiative in the city of Oakland to tax parcel owners, homeowners primarily, and a little bit of city-owned parking garages. Short story of a long, interesting is there were two separate ballot initiatives. One was just for more police, one was for more intervention services. The 2/3 passage to increase taxes. Both of them got more than 50%. Neither of them got 2/3, failed. 2 years later, they tried to do the same thing, same outcome. Someone had the brilliant yet simple ideas. How about we put them together? And that initiative passed overwhelmingly. It was 10 years. But an example of how you have to focus and you have to be data-driven. For the first 10 years, the initiative wasn't that effective. It was renewed, thankfully, by the voters, even though it wasn't all that effective the first 10 years. But the next 10 years is when we implemented this strategy that was very data-focused. And so the challenge with this example is that every city is not going to tax itself. That gives $12.5 million a year to the police department, $2 million a year to fire, and $9.5 million a year to violence intervention services for a city the size of 425,000 people. And so if you did that, the math in Philly or other big cities, it's a lot of money, but it's only about 35 cents a day for homeowners. And that's the way it was sold and it was passed, and not even the entire $9.5 million of the service money goes to this innovation. But that is what we did. Nearby city of Stockton, California, who had just come out of bankruptcy, did something very similar. They floated a ballot initiative that helped them get out of bankruptcy, but also paid for the creation of the Office of Violence Prevention. That my organization and other partners came in to help them do this type of focus. And so one other quick thing on this is, California is particularly expensive, but nationally, the average cost of a gun incident and injury shooting is about $1.2, $1.5 million. When you police response, ambulance response, fire response, DA response, an incarceration, a trial, a hospitalization, all of those public costs that taxpayers are footing the bill for is about $1.2, $1.5 million every individual incident. Here in Philadelphia, the controller did analysis that said for every injury shooting, it reduced property values by 2% within a 0.8 mile, about 10-block radius. And so that is a drain on the local economy because you're not collecting those property taxes. So it is actually a good investment. And for a city the size of maybe 1.5 million people, if you put about $1.5 million a year into a very dedicated, specific strategy, you can really significantly reduce gun violence and have a return on that investment.
So our experience is a little different. It's kind of born out of two things. The School of Nursing is interested in the space of innovation. It's one of its strategic goals. And in doing that, they had to invest in the faculty that they had in hand. So this is a really good kind of like Penn Law. If this is the space you want to go in, you have to invest in some of your infrastructure. And so the School of Nursing actually paid for an opportunity for me to be trained at the Center for Healthcare Innovation to learn design thinking principles. And so that was one thing that helped. And then the Leonard David Institution, which is out of Penn as well, they funded our work group. And so early on, we had what some would think of as kind of seed money to train, to do our contextual inquiry. The traditional research process, which academics work in, is that we would write for a project for federal or for private philanthropic dollars to fund this project, and it's slow. And so had we used the typical academic research project, we might still now be just trying to get the dollars. And so thankfully, clinical spaces don't work under that assumption. They're just like, we have a problem, let's fix it. So that was helpful. But now that we've shown proof of concept, we've shown some reduction in negative outcomes, we've been talking to CEOs, to be quite honest, to see if they're interested in funding or supporting the continuation of the program. And so we had early support financially, and now is about getting investments. To be quite honest, the question is, how do you get investments not just at the local, but really scale it? And so most recently, I had a conversation with Kevin Mahoney, and he's the CEO of UPHS, the healthcare system, and he said, how do you take Thrive and connect it with Epic or with a company that's national so that you really get national impact and scale? And those are the ways we have to think about continuing to fund something like Thrive.
I think one of the first jobs of any person leading a team, a research side, a company, is you have to be a salesperson. Right? You're selling constantly either to investors, to potential clients, to people to join your team. And one thing which I actually noticed, through a lot of my colleagues' presentations today, is how do you humanize something really, really big? And Dr. Kieran started with a really anecdotal story of making this person really relatable. And that's what I'll keep my answer short, but I think making problems which affect millions of people really simplified that, hey, this can be us, and this can be someone you know. So let's solve this for the someone you know, and that helps the millions of people in the country.
Well, I can share a bit about CORE, maybe. Similar to what Margot said, we're sort of in the process of figuring out how it will be funded, and you mentioned sales. We're trying very hard to sell what we're doing to relevant stakeholders to see if we can cobble together funding. Right now, unfortunately, as a result of limited bandwidth, about half of the patients who would benefit from our intervention aren't receiving it. And so the primary need that we have is to have many more certified recovery specialists to engage with folks in the ED, but also to stay engaged with them over the long term, which that in particular is a lot of work. And right now, we're funded partially by the hospital, Penn Presbyterian Hospital, and partially by federal grant funding. I can't remember how many years ago there was funding to establish centers of excellence, and that was sort of the precursor to CORE. Anyway, where we are now is we're in the process of selling what we're doing to the various hospital CEOs, because some of what we do benefits the hospital. We're also speaking to a local behavioral health payer, actually the payer, which is called CBH. It's a nonprofit, but they administer behavioral health in Philadelphia. One thing that they don't do yet, but I don't want to throw them under the bus, but they're a little bit behind the ball in terms of reimbursing for certified recovery specialist time. Our neighboring counties do that, and so when we send Nicole out to speak to a patient in the emergency department, for example, none of that work is reimbursable. There is a mechanism to reimburse or to attract reimbursement if that patient's connected to care and if we continue to stay engaged with that patient. It's very complicated. What we're going for in the long term is sustainable funding, some sort of sustainable mechanism for funding rather than sort of cobbling together all these various sources where we are now. So very complicated, it involves sales, involves using these personal stories. We do have early evidence that's exciting that we're preventing ED admissions and hospital admissions. Substance use is complicated because basically, as David alluded to in his question, the benefits of substance use treatment are felt by a variety of people, law enforcement, the city, hospitals. It's the ROI overall is like something like 12 to 1, but it's very unevenly distributed. So it's a complicated problem to solve for us.
So I guess I should say something since everyone else has had their turn.
I had a question.
Feel left out. Yeah, so when CRISPR gene editing technology first came to attention, this was late 2012, early 2013. I was actually one of the first scientists to use it. And around that time, once we saw how well it worked, a few colleagues and I went around to different venture capital firms and tried to get them interested in CRISPR, and it worked. Several companies actually came out of our going around and selling gene editing. But I couldn't get any of those early companies interested in cardiovascular disease. They wanted to go after rare diseases. They didn't want to go after the world's #1 killer. I can't imagine why, but that's just not how they were thinking. And so I had a lot of trouble in that respect. So I had to go the academic route, and it has its challenges. So I had to go very small scale with my own laboratory, write for NIH funding, write for funding from foundations, philanthropic organizations, and whatnot. And the success rate was nothing to write home about. A lot of those grants were not funded. But over the course of 5, 6, 7 years, I was able to continue to do experiments as I could, have one person in my lab working on it, get just enough funding from this source or that source, get some unrestricted funding from University of Pennsylvania that I was able to just do whatever I wanted. So I applied to this project. And it took time, but I eventually built up the proof of concept experiments in mice, the sort of data that I showed you that I think is very compelling, showing that you can take a very cloudy blood sample and turn it into a very clear blood sample, and just marshal enough proof just to, I think, make a very, very compelling case that I wouldn't have been able to do that without putting in all the legwork and just working on it on my own. And then at that point, once I had marshaled enough evidence, we were able to go around to VCs and say, hey, look what we've been able to do. It's going to work. You just need to fund this and make it possible. And then we found it was actually fairly easy to get VCs to invest in our Series A round. Ended up being $60 million. And so then we're off to the races. But that would not have been possible without all the legwork that I had to do basically on my own and kind of string it together.
So the most important question, are you still taking investment? I'm glad you mentioned that, because I think one of the challenges in doing a flash presentation on innovation is that you always have to end with successful innovation and everybody, and maybe with some time left at the end. And one of the things that we wanted to probe a little bit is, whenever you're thinking about innovation, there are always going to be people you're up against, and sometimes people you may have anticipated as allies. So can you describe some of the sort of challenges or groups of people or areas where you found challenging in a way that surprised you? Not necessarily people, if you're doing medication that may displace other pharmaceutical companies who are making money off the things you're not addressing, that's an obvious one. But were there surprises along the way in terms of folks who were threatened by your innovation?
I'll just say, one of the things that makes me think, we must be successful is because we have some law enforcement against it and some advocates against it. So I think we're perfect. But, there's a couple of quick things. This type of approach, has been attempted in several cities without success, and part of it is fidelity of implementation. Part of it is we really innovated the base core of the program, taken from Boston. That was called the Boston Miracle because of its success, but really took the core elements of success from it and then begin to tweak it a little bit. But then once we found success, made sure, the biggest work now that we're 7 years into in Oakland is just, let's stay the course, let's focus on it. But really quickly, some police are against it. They might say because it's hug-a-thug work, but really it requires a change in the way they do things, right? And so unfortunately, over the last few decades, police departments have turned into this, they just call for services. They respond to 911 calls, and this requires them to do something quite different. And they want change, but none of them want to change. And then on the advocacy side, they want you to never work with law enforcement. All we could do, we can handle all of it ourselves and with community-based organizations. And a lot of evidence that that's just not true by itself. And so this type of partnership is what has proven most effective. But we spend a lot of time either on one side or the other, often on both, trying to convince people that no, it takes this type of partnership, it takes this type of change in what we're doing. So there's a city I'm going to, leaving here to go work on this initiative, and they have had 4 consecutive years of record violence levels, which is there's no other really city in the country that I've seen that. And they have some in law enforcement saying we're doing everything right. It's like, okay, well, the outcomes are showing something different, and so it is sometimes more than anything just difficult to get people to do something different.
Great. So one of the things, because social determinants of health are kind of big and amorphous, and when you are working in an acute care space, people don't necessarily think that transportation, housing, and food is really what they are responsible for. And so in starting something like this, there were people who would say, isn't it really that Philly just doesn't have enough community-based services? Isn't this really, like, if we try to do this and it doesn't work, won't it demoralize physicians? And, so 1, it's not my job. 2, can't somebody else really do it? And 3, if there aren't enough resources, we can, do whatever we can, but it's not going to work. And I also think that you can meet resistance if you're using a different, I call it a love language. So, if I don't know, or I didn't know coming into what the metrics of importance were to the healthcare system. And so if you are talking from a kind of social justice, like we should do this because it's just in the best interest of patients, that's not necessarily going to move or shift. And so really learning how to reduce the barriers by thinking about, like, we have to partner and what are the things that are in the best interest of our patients and the healthcare system. And I think that was helpful. And also finding allies in the healthcare system that were in positions of power to work with us. And I do think that that helps mitigate some of the opposition that we saw early on.
I think in our case, to the point about ending the earlier session with success stories, we definitely had some failures early on. And one of the biggest things which surprised us was our solution originally was a consumer-facing solution. It was an app you could download. And we realized people did not want to download apps. And getting people to download apps is even harder. So that's when we had to take the more capitalistic approach, seeing who is going to benefit from this the most financially, and who's going to get dinged the most financially. And once we looked at it that way, which, might be a good thing, might be a bad thing, that's an argument of another time, but it typically solving, other than the medical side, typically solving most solutions, you can go at it multiple ways. There's multiple ways you can solve the same problem, and the one where you find that product market fit is the one that everyone gets excited about, right? The VCs get excited about, the people you're solving it for get excited about, and that in turn gets me excited. So it takes some time to discover that fit.
I think the point about excitement turned out to be a pretty critical one for us. One of our goals was to introduce buprenorphine as a first-line treatment in a setting where it wasn't already being used. And so we encountered ED physicians who were really excellent clinicians, but who maybe were a little bit slow to change on that particular front. And I think for us, one of the critical things that we did early on is we found a way of taking away all of their work as it relates to engaging with certified recovery specialists. So if you recall, before ED physicians were being asked to pick up the phone and call us, and we changed that. We flipped it, and so now the default is a recovery specialist just shows up in the emergency department and engages with a patient. And that actually had a really interesting feedback loop that we observed where because those engagements were so successful and because ED physicians began to see the value of it, we started to hear more from ED physicians. So we're getting more calls than we ever were before, in addition to the automated system, which to us is a really good sign of success. And I think one thing I would add to that, for us, we use success stories very intentionally. We learned early on that ED physicians were a little bit skeptical about buprenorphine and maybe a little bit cynical about how effective it could be for these patients who, again, have lived very vulnerable lives. And so one way that we mitigated that was by sharing back success stories. So if a patient was started on buprenorphine, for example, and then they were connected to care, and if they were doing well, we would make sure that the physician knew about that. We would come back and say, thank you so much for your cooperation, thank you for what you did, and tell them a bit about how the patient's doing. And that was actually really surprisingly effective. We only learned after the fact just how meaningful it was to physicians who don't often hear about patients after they leave the ED. They do all this work. It's just an extremely complicated and busy setting. It can be a very difficult job. So to have those sort of success stories shared back, I heard from them, was like a drink of water in the desert kind of thing. So it was a really small thing that we could do, but it built excitement about this treatment and made them more willing to work with us in the future.
So the most interesting, unexpected objection to our concept is the idea that in a sense it may work too well, in that if you are able to treat people and permanently reduce their cholesterol levels, we'll give them a license to not take care of themselves. Now they'll feel, oh, I don't need to eat well, I don't need to exercise because I'm not going to get heart disease. Now, of course, that's going to have other bad consequences like diabetes and obesity and bone problems and things of that sort. But I've encountered some of that resistance. And it's philosophical in nature because you can take that perspective and say, well, yeah, you're going to embolden people to engage in, more, gluttonous behavior or whatever it is. You're going to give them the wrong incentives. And it's going to sound weird, but the analogy I use is, giving free condoms in schools to address the problem of teenage sex. Right? You can take a very conservative point of view that you don't want to give condoms out because then you're encouraging teenagers to engage in sexual practice. Whereas the flip side, the more pragmatic point of view would, I suppose, be that, look, teenagers are going to have sex whatever you do. Let's encourage them to practice safe sex. Let's provide them with the condoms. Just accept the reality of the situation. I'm guessing I'm in the latter camp when it comes to a gene editing therapy because I look at what's happening. We're in a situation where heart disease is on the rise in the United States after decades of progress. It's clearly not working. It's still the #1 cause of death. It's not like physicians like myself don't continuously tell our patients, hey, you got to pay attention to the things you have control over. But it only goes so far, and as it becomes a global health problem, you just desperately need some solution. And yeah, there may be some unintended consequences. Some patients who, upon being treated, will not act in the optimal ways as a result of that treatment. But my view is that's the reality of the situation. But I feel like we're starting to get some resistance from those who are more conservative-minded, if you want to use that framing on it. And I suspect we're going to meet a lot of that resistance as we go forward. So it'll be interesting to see how that plays out.
So we've touched on, or spent a lot of time on technology here today, which I think is natural in innovation. But one of the things we were struck by in all the presentations were the human capital side, right? People. And I have 2 questions, and take them in any order. One, in all but a couple of your presentations, in order to scale your solutions, you require an enormous number of people. Right? It's very human capital intensive. Yours might even be. I don't really understand the science, but I suspect you need a lot of scientists. And the rest, you require a lot of intervention, a lot of specialists at scale across cities. So how do you adapt to that as you get outside sort of a laboratory setting or a smaller city or a smaller subset of a city? How do you then scale that nationally as we think about large, what I'll call secular legal problems? How do you think about that scale problem? And in a related way, all of you touched on behavior change. Everyone. They had to do it. How do you think about that as you bring your innovation to broader markets? How do you continue to evolve, having to change behaviors that, for any number of reasons, are fairly resilient?
I guess I've been starting. That's exactly right. And we're actually trying to push that as a field, to create this field. I think there's a burgeoning field of something called credible messengers. The great thing about that is there's also job creation for folks who are often shut out of the professional job market. And so people who are formerly incarcerated turn their lives around, who have similar lived experiences as the people that we're trying to have intervention with, often can be the most effective at doing this work. Not the only, I don't fall into the camp like that there's the only people that can do that work, but they can be most effective at doing that work. But there needs to be a lot of professional development and training and support. And so what we have found in Oakland is, we pay, now Oakland is absurdly expensive these days, and so we can't keep up, but we're paying our full-time intervention workers $55,000 a year for folks who are 4 or 5 years out of incarceration. Their first kind of salaried professional job is not that bad nationally. In Oakland, still pretty poor. And so we are trying to professionalize this field. So in Chicago, which something that grew out of Los Angeles, is trying to create a academy to train folks on how to do this pretty complicated, difficult work. To develop trusting, positive relationships ongoing with people who aren't looking for, so like these aren't folks who are like knocking on people's door asking for services, unfortunately. We're like finding them and engaging them, incentivizing to engage, and then bugging the hell out of them. Call them once a day, text them once a day, see them 3 times a week for 6 to 18 months. And so it is a lot of human capital. But the good thing is it's job creation, and we really have to do more to professionalize the field and recognize it. And similar to the outreach workers around the opioid, I'm on the state MAT oversight, medical assistant treatment, and similar type of work around the type of outreach. And so trying to professionalize the outreach work around health and reducing, and even public health around gun violence.
So some of the work that we do does require behavior change. We like to say that with Thrive, we are reimagining the workforce you already have. Like, you don't have to necessarily add a trained physician. Physicians are there. You don't have to add home care nurses. They're there. But as it stands, hospitalists, by their names, typically are bound by the hospital, and they don't see patients after discharge. Thankfully, they own their scope, so they can. So it's really about thinking about how can they do something that they didn't imagine that they would. And that behavior, asking them to continue to take a call about a patient when they've already discharged them, is pretty radical. So I too have questioned, why do you do it? What is it about it? But physicians by nature, I'd argue nurses as well, are problem solvers. And it's demoralizing to take care of a patient for 5 days and they come back in 2 weeks. So the very act of being able to take a phone call from another clinician and help problem solve over the course of a phone call and know that it mitigates an adverse event is reward. It is the drink in the desert. And so yes, it requires a change of behavior, but it's one that has innate rewards. And we found that it's been enough. And when we started, said, can you just do it for 2 weeks? And they said, nope, we'll do it for a month. So it was fantastic and surprising, but I also think that it was innately rewarding in terms of the benefit that they were seeing in patient outcomes.
I think, I forget who said this, but someone really famous laid out that there's 3 categories of inventions or innovations. Innovations that go from 0 to 1, so nothing in place, to what's optimal. Innovations that go from 0 to 0.5, nothing in place to something a little better. And innovations that go from 1 to 1.1. That there is something good, but let's make this even better. In the first two scenarios, when you start from zero, I think you always there will be some sort of behavioral change component involved. In our case, the goal is to eliminate that change, or whatever that change is to make it be the easier change. So make the default even easier or less work for our customers. But I think behavioral change will be a part of, should be a part of a lot of medical-based interventions, but a lot of tech ones, sometimes the goal is the opposite. How do you drive your innovation without getting people to change what they're doing currently? Because change equates more time to sell, more time to implement, and a lot more cost for us. So we are those companies that do the change for the companies, so they can do what they do every single day and still have a service they did not have yesterday using vendors like us. So sometimes that hesitance is a good thing because it incentivizes us to innovate.
Yeah, I think for us, it was definitely a story of taking work away. Most of the behaviors, we tried to either automate them, take them off of the plates of physicians and nursing and other folks in the emergency department, and put them onto the plates of certified recovery specialists who have a passion and an incredible ability to do those things. And then whatever was left over, in particular the prescribing, we need somebody to prescribe medication. We did rely pretty heavily on motivating through success stories, building excitement, and the bottom line is these physicians care very deeply about the patients, and so to the extent that we were able to show that this was effective, we saw some of our most reluctant folks get on board and become our biggest champions, which is really rewarding. About personnel, I think, as David mentioned, we have a lot of similarities. The certified recovery specialist role is somewhat professionalized already, but it's a relatively new thing. These training programs, I don't know a ton about them. I think they're administered by the state. And if we were to get to the bandwidth that we need, we would have to hire an additional 7 recovery specialists on top of the 3 we have now. And we've tried very hard to find people who are of the same quality or even more skilled than the ones we have now, and it's very challenging. I mean, the training is very uneven, and I think that the biggest hurdle that we face is finding people who share our philosophy about treating these patients. CORE is a very harm reduction-oriented program. You would think, perhaps, that certified recovery specialists would share those values, but the fact is they don't always. To give you just a quick example, a lot of people view buprenorphine as a drug, as substituting one drug with another. Bup is a partial agonist, so it's not an opioid, but it's also not the same thing. And so the people I work with view buprenorphine in a similar category as hypertension medications or statins, and it's something that you take over the long term to treat a chronic disease. Not everyone sees it that way, and it's actually kind of hard to change people's minds, at least it's not a guarantee. So it's hard to take a risk on someone who doesn't see things that way. Long story short, we're also considering training people ourselves. We're just not there yet. We have so little time to do it. But I think the ideal state would be for Penn Medicine to be the premier place to train certified recovery specialists. I mean, that's my vision anyway. Hopefully we'll get there soon.
So to the first aspect of the question, personnel and scaling up, yes, it will take a lot of people. And that's because it's more than just science, it's more than just research in the laboratory. You develop the concept, and then you have to go through a whole host of preclinical studies to establish efficacy, to establish safety. You engage with the FDA, and then there's a whole process of getting approval from the FDA to go ahead into clinical trials, and all that requires a whole host of different types of people. We're going way beyond the initial science in the laboratory, setting up manufacturing, chemistry, thinking about those issues, analytics, quality, then actually engaging with partners around the country, around the world to carry out the clinical trials. And so it very quickly escalates and balloons in cost to do. I mean, literally it will cost hundreds of millions of dollars to develop a drug that then goes through clinical trials and then is approved for use more generally. Now, fortunately, this is a well-worn path. We're not trying to create something from whole cloth. And a very standard model, standard outcome is a small startup company will develop some exciting new technology, take it up to a point, show that it's promising, and then we'll attract the interest of a large pharmaceutical company, partner with that pharmaceutical company. That pharmaceutical company will either invest heavily in the program, become a partner, or even outright acquire the company, and then take it to the next level. So that part, at least for us, is more well-worn and not as much a concern. With respect to behavior change, I anticipate we're going to run into some resistance from physicians, providers, patients, who are very comfortable with the traditional model of, I want to take a pill every day, and I'm fine taking that chronically for the rest of my life, because that's just how modern medicine has been for quite a while now. And so there's some patients, of course, who are taking more than a dozen medications. And physicians are very comfortable with that. Now you're talking about taking this new technology, changing genes, things at the DNA level. Yes, it's once and done, but it's weird, it's sci-fi-ish, and you can imagine how many people might not be so comfortable with that, and convincing them that this is truly a better approach than taking a statin every day for the rest of your life, even though that adds up to tens of thousands of pills over your lifetime. It can be challenging. Now, fortunately, we're not doing this alone. We're not the only ones coming out with the sort of transformational approach of a once-and-done therapy. Any company, any group that is trying to use or develop gene therapy or gene editing is in the same boat. And what I anticipate going forward is that as more and more companies successfully take these sorts of therapies into clinical trials, show success, particularly in rare diseases where there were no cures before, that will increase acceptance, that will breed familiarity with the approach, and I think over the next 5, 10, 20 years, we'll actually see that physicians and providers of patients will become much more comfortable with the idea of this type of therapy, of instead of treating chronically and taking pills or injections very frequently and trying to manage the disease as it's already happening, to take a more preventative approach and do a once-and-done therapy that halts the disease before it even starts.
This is kind of like a follow-up to David's question, and it's David Perlin's question. It's directed at David Mohammed. See, you're from Oakland. Everybody here is from Philly.
Yeah.
They're ties to Penn, so I'm going to have to come at you. And one of the things I really, and the reason is related to that is because we talk about how replicable innovation is, right? And so let's talk about violence in Philadelphia. We've had, we're at about 52 murders already, and I think your slide, Oakland, was at 60, around 60 last year.
Right.
And we had over 350 people murdered in Philadelphia last year, the highest rate in 12 years. We have a new police commissioner, Commissioner Outlaw, who you know from Oakland and who came from Portland. So the question for you is, when I was the city solicitor, as a city attorney, we worked on everybody has an anti-violence strategy. And you're right, people come in, they said, if I just it'll reduce gun violence, I'll get a grant. It doesn't matter what you're actually proposing. So my question to you, how do you take a lot of what you have done in Oakland, where you dealt with 6 police commissioners, 2 mayors, and try to replicate that so you can help address, we have a real crisis here in Philly, how you can help address that. And some of the crises are tied to the problems that they've been addressing.
Absolutely. I think you're in great context, and what we were able to do in Oakland, despite extraordinary political upheaval throughout, is, somebody earlier said something, nothing succeeds like success, because the community members, other government officials said, this is going to be our primary strategy. Like, regardless of who's in office and who's in what seat, we're going to stick with this. The great thing here in Philadelphia is that then Captain Outlaw, great name for a law enforcement official, Commissioner Outlaw, who's now here in Philly, is very familiar with it in Oakland and brought us to brought us to Portland to replicate there. This is a very replicatable program, and so there are a couple things. There are people doing great work in Philadelphia now. And so there needs to just be some pivots, some significant pivots that I think will make people uncomfortable, like the way data is collected and analyzed and shared. It's unbelievable how people just don't want to share information. They start making up stuff about, well, this is, what's the medical... HIPAA is not HIPAA compliant. It's not Corey. They just will make up stuff, the HIPAA boogeyman. And so so that's just a huge issue that takes political will for someone to start instructing people to do a job a little differently. The other thing on the programs, there's people right now who will say, I don't need to do anything different. I don't need anybody from Oakland to come tell me what to do. In North Philly, this is my neighborhood. This is what I've done. And some of that's true. And some of it is if you just focus a little bit, right? So you're working with 100 people that you're calling high risk. And yes, 10 of them are, all right? And if you just continue working on those 10 and take these other 20, right, who are actually at very high risk. And the other thing quickly about that is, when I talked about actions and desired outcomes, those 100 might be at high risk of recidivating, but that doesn't mean they're high risk of engaging in gun violence. And there's different levels of riskness. And most risk assessment instruments only are looking at risk of recidivating. How I largely got into this, and excuse the little bit of story here, is it was risk assessment that in Oakland with probation, and this one PO said, hey, these two people got the same score. One's a 45-year-old homeless drug addict. One is a 25-year-old gang member who carries guns. And when I talked to the risk developer about risk assessment tool developer, they said, yes, they have the same likelihood of committing another crime. And I said, yes, one's going to steal from the store, one's going to shoot somebody. I want to know the difference, right? And when you're talking about who should we focus on, the person who has the substance abuse challenges needs support and services. That's not this program. They need that, right? When we're talking about gun violence reduction, really focusing on, and so that is the type of technical assistance that we try to provide to cities to say, you can use similar apparatus. You have a series of organizations, great, fund them to focus specifically on this population in this way. In a way that is kind of unusual, not people who are asking for service, people you got to go find and convince to be engaged with you in a relationship. And so the way of focusing and the way of engaging is different, but you can often use the same people, police and outreach workers and coordinate government service coordinators. The last thing I'll say is you've got to get at least, especially in the city size of Philadelphia, some person whose full-time job is just this. Not who also has some other things on their plate. And that's what so many cities do. We're going to give it to that lieutenant of the police department. We're going to give it to that assistant city administrator who's got 3 other jobs. This type of coordination needs full-time focus and attention. Again, something we did in Oakland. And so I'd love, I lived on the East Coast forever. I'd love to come back. Oakland's my home, but I'd love to come back and help the city and my colleagues.
Well, you've promised us in your 50% decline in 6 years. What happened in Oakland, so
got it.
People remember that, David.
Yeah, so I'm going to start with Davis on this one. You talked about, well, the solution seemed to be sitting in front of your laptop for some number of weeks to figure it out, okay? And that's what I call the moment when you're like, this is the thing I need to do. Every startup has their aha moment there, right? I'll start with you, but I'd like, as many of you want to comment, how did you figure that out? That's not intuitive, any more than it's intuitive how to build that risk assessment model to get what we in sales call the funnel, right? You narrowed your funnel, right, to the, right, so that you can work upwards. How did you, to me, it's always a question of how. How did you figure that was the thing to do? And then what tasks to undertake looking at your laptop? And at what point did each of you have that moment, and what was the process?
Let's see, where to start. Well, I had observed that the process for finding these patients and requesting that a peer come speak to them was very reactive, and it required a lot of manual effort. And so I hypothesized that a more proactive and automated solution would be ideal, but I couldn't exactly go to our data scientists and say, build me that. I had to learn about what it should look like, how it should function, and whether or not it was worth the investment. So that's why I found myself in front of the laptop myself. And I didn't know what I was doing. I mean, I have lots of training just through the course of my job on how to use a health record, and I have all the permissions to look at the health record, and none of that was a problem, but I didn't have a background in behavioral health, and so I was really looking for low-hanging fruit. And there actually were a number of patients who had very well-documented histories of substance use in their charts who weren't being identified, and the recovery specialist was never called in. And so right off the bat, I was able to identify more patients, bring in the recovery specialist by communicating directly with them on their phones. They have a very mobile workflow, so that's the best way to communicate with them. Where it really got tricky was finding the less obvious patients, and that's where I relied pretty heavily on the data scientists, who by that time were more interested in what I had to say because I had some early evidence to support it. And I've worked with them extensively. We've iterated on this many times. Right now, the system we're using looks at basically events in the health record. It's not algorithmic, actually. It's high-tech and very, very cool, but it's not algorithmic. In the future, it will be algorithmic, and what they're doing right now, as we speak, is looking at the characteristics that would put somebody at high risk of having opioid use disorder. And so they're using machine learning to look at all these different characteristics of the health record in a HIPAA-compliant way to find patients who are at high risk. And the rest of the intervention would look more or less the same, where the recovery specialist would be called in to speak to these patients, talk about drug use, talk about treatment, and kind of it goes from there. I don't know if that fully addresses the question, but it was very, it evolved quite a bit.
Yeah, I'd like to, add on my story with something you mentioned, is finding, I guess, the path of least resistance. I definitely had 2 points. So the first one, identifying the problem seems like the fairly easy task, and you mentioned what you need to get really granular on what outcomes do you want to drive from this, and identifying that after when you surround yourself with the right people and do some digging is the easy part. Finding a solution that can be executed at scale is always the harder part, right? And in our case, the one challenge we had, there was a lot of data out there, but oftentimes when you just look at data, it can be very biased. And that's another risk of these big data sets, which don't include minorities, don't include low-income people. So for a solution, you hope it benefits society. And if you're just, running algorithms, not the right way, but just to see what sticks, it can be a double-edged sword because you actually end up seeing patterns that affect only 20% of the population who have very good records and who have complete records. It's a whole different story by itself. But I think once you identify the problem, and boy, we had to refocus on that because it's easy to, slide away from the problem. The problem is keeping people safe, and that resonates with quite a few people up here. And you could solve that 100 million ways, right? And we needed to make sure we stuck to the path which had the least resistance here. Sales funnel process. Reduce the people in the sales funnel, right? Reduce the departments we're selling to, reduce the steps, reduce the compliance associated with it. Find that one person I can go convince and this be deployed. And that's not easy. I don't think we've nailed it. That's a part and parcel.
Yeah, so in my case, the problem was clearly very easy to find, the number one killer in the world. So that was the easy part. With respect to the gene editing, so in the old days, pre-CRISPR, gene editing was a lot harder. There were some tools, but they were much cruder. They were much more difficult to use. They didn't work as well. I first got interested in gene editing as a tool to try to make changes in cells and predict the effects of potential drugs on those cells that I can then extrapolate and figure out what potential drugs might do in the body. So more for identification of drug targets that could then be actionable by the old-fashioned way of doing things, developing small molecules that inhibit proteins or bind to things and otherwise have a therapeutic effect. It never occurred to me that that tool could actually be used as therapy itself until CRISPR came on the scene. And because I'd been playing around with gene editing, had a lot of experience with it, this whole new tool comes about, CRISPR. The very first question that came to mind is, wow, is this just another gene editing tool or is this something new and better? And if it had turned out that it was just another gene editing tool, then I would have been doing things in the way that I had been doing for several years prior to that point. And what astounded me is over the course of just 10 weeks, I did apples-to-apples comparisons between CRISPR and the older tools, and what I found just blew me away. CRISPR just blew everything else out of the water. It was just a totally new game-changing technology. It just worked so well and so easily that I immediately realized, wow, it works so well in cells. It works so much better than anything we've seen before. Maybe this isn't just a tool to try to identify new drug targets. Maybe this is actually the drug itself. And then being a cardiologist, I immediately started thinking about the world's #1 killer and what kind of genes would you want to go after. And then it just became very easy to say, okay, well, let's see if this actually works in living animal mouse models that we typically use as scientists. And basically the first time we tried it in a mouse, it worked so well. Cholesterol levels came down immediately, dramatically, permanently. And then the concept was there. And it was just a matter of getting from A to Z. And right now we're at probably E or F along that process.
I think for us, when you think about something like patients with high social needs, that's so amorphous, and really needing to like nail who exactly we wanted to focus on. And so we too used machine learning and the electronic health record. And basically, machine learning will let you put in all of these predictors, and instead of you kind of telling it like who you want to focus on, it tells you who should be your target. And using that information and clinical expertise to say, like, these young, mostly young when you think about 50s, people with chronic illness who are poor, that's your target. And I don't know that intuitively that's who we would have decided to focus on. We probably would have focused on people who were older and poor and who were sick. And so being able to isolate using the machine learning, but also pairing that with kind of the clinical expertise of multiple stakeholders like community health workers and home health really helped us round out our focus to see opportunities that were being missed. Like, these aren't people who would have home care typically. And in the acute care side, they weren't people that they even knew would get a paid visit. So there was this opportunity to use data to refine the population, but then use clinical expertise to help come up with a reasonable targeted solution.
I can say one thing before I have to sneak away. One is, and one thing I didn't talk about, and this was earlier talking about failure, is one of the goals of this strategy was to improve police-community relations, and talk about it because it didn't work. Actually there's some evidence, there actually is a lot of evidence that there was incredible progress, 50% reduction in complaints and 50% reduction in use of force. So that's actually significant evidence. The feeling of the community wasn't quite there. But I say that to say, if we really transform the way in which we operated the criminal justice system, I talked about the folks that we're focusing on have at least 7 prior arrests, and most of them have several prior incarcerations, which if that was an effective intervention, incarceration, then they wouldn't have got to the level, right, to get to where they were as very high risk of gun. But we need to massively transform the way in which we operate the criminal justice system. I spent 10 years as a leader in correctional, community corrections and probation, and we made some movement, but if we really actually provide rehabilitation, treatment, services, support, rather than just deficit-based, punitive-based response that is ineffective, harmful, and excessively expensive, then, again, to that point of we can begin to not even need this type of emergency intervention to reduce gun violence. And so there's definitely some things we can do to correct our systems so that we reduce the need for this type of emergency intervention. I just want to really say appreciate everybody. I have to run. For those, the website is nicjr.org, National Institute for Criminal Justice Reform, nicjr.org. And thank you all as well.
Thank you, David. Well, this, as you know, this is a conference on innovation in the legal profession. And as David and I, as members of the board, one thing that we want to be able to sort of take from what you guys have done impressively is how to use that in our profession. And I start with a little bit of story. Like when I was at the city, I had the Commissioner of Public Health come to me and say, we want to start a place where people can inject drugs, and city property. And for me as a lawyer, that's an easy. You must be out of your mind. Of course, we're not going to be able to do that. And I felt that eventually we got there in terms of developing the process. So I say that in terms of, for lawyers, sometimes it's very challenging dealing with folks who are innovative, folks who are trying to push the envelope. And so I want to ask you, how are you able to? Because it always comes back to lawyers. How are you able to use lawyers in connection with some of the challenges you have? Because I know you have one of the things Rhoda Mayer offers is that the legal end. You work with Cozen O'Connor. Mm-hmm. You mentioned you can't use FaceTime. There are HIPAA challenges. And Karen, you talked about the FDA process, clinical trial, product liability laws. Yeah. And, so I would love if you could share with our group about, how you're able to deal sometimes with lawyers being a bit on the conservative end and you wanting to obviously achieve your goals.
So I think a lot of analogies can be drawn from the medical field where intervention, now we're realizing the value of intervention needs to start earlier and earlier in the process and not just be a reactive, come to the hospital and then need something. And it's, in my mind, I see legal services very similar, especially in the innovation side. It's when I'm in trouble or if I'm ready to launch a product and if I go to a law firm saying that, hey, I need my T&Cs built out, it's too late. We're already past every possible thing we could have done. And that's the bolting on approach of, oh, I'm just doing this so that it's a checkbox for compliance. And that's a wrong approach, and I definitely think the legal conversation actually needs to be one of the first conversations any entrepreneur needs to have the second you even have a rough idea about what you're doing. I'm very grateful for Cozen and Pepper and the two law firms that have startup programs, that incentivize, well, not incentivize, but actually make such good skill sets available to us before we had venture capital come in and be able to access these resources, because we've just saved ourselves 6 months of going back and forth and re-engineering our product to be PCI compliant and this compliant. You could just go down the list, So I think potentially flipping the script and maybe, a place to start for the legal profession might be to come in a little earlier. And one way they've done it is through the startup programs, but another way out through events like these on universities, which oftentimes are the birthplace of a lot of young companies. But yeah, it's starting that conversation earlier, and that's the same advice, doctors are often given about start your conversation earlier with your patients, and it's really similar.
So interestingly, HIPAA obviously is a barrier for FaceTime. FaceTime is probably one of the easier mediums to connect providers, but because it's not HIPAA compliant, we were forced to think about another vendor that, quite frankly, providers didn't like as well, and so we decided to table it. But how nice it would be to have consultants talk to us about some of these things when it comes to creating opportunities to share patient information, keeping it safe, but also really importantly, trying to think about continuity. The interesting thing about Penn is that the home health is a part of the UPHS entity. And so with Thrive, in order for someone to get it, they really have to use Penn Care at Home, but you can't legally tell patients that you have to go to our Penn Care at Home. They have to have choice. And so that's a legal barrier, and it's one we have to think about, quite honestly, and how do we provide a service, offer it, but then also say you can only use it if you use a specific provider. And thirdly, much of our services are focused on a particular insurer, Medicaid, and how are you able to offer a service to one patient population that's not offered necessarily globally? So we will take other patients who have commercial insurance, but we're trying to deal with a social need. Poverty is kind of the social need. And so legally, you have to be thoughtful about the withholding of services to other patients who have other payers. So lots of ways we've had to think about offering a service, not denying a service, offering choice, providing an opportunity that doesn't look like we're feeding our own healthcare system. So we've had a lot of conversations with general counsel to keep us legal.
We had some common themes, obviously dealing with HIPAA as well. Substance use information is even more tightly regulated. There are state and federal statutes specific to behavioral health. So it was very, very tricky. We were very fortunate, though, that we had lawyers in the health system who were able to work with us and problem solve with us. So, for example, we worked with Lauren Steinfeld, I apologize. She was fantastic. She helped us to think through the system that we wanted to implement, which would involve automatically identifying patients, automatically sending messages out to phones. Ooh, she was not happy at first. But we worked together, and actually I think in some ways she helped us to be a little bit more rigorous in the intervention we developed. So, for example, she gave us some principles that we could apply, like if you can work with de-identified data, you should always work with de-identified data. If it doesn't change anything about the intervention, then you should make that choice every single time. And it was really helpful. There were a few things that we weren't able to do, and that's okay. And I think part of her willingness to problem solve with us, I should also say she has a fluency with innovation methodologies now, because people like Roy Rosen have been in her ear for about 8 years now, and have been sort of working on that. So by the time it came time for me to have a conversation with her, I think it was teed up nicely for me, and we were able to implement more or less what we wanted to. So, yeah.
Great. Well, let me say thank you on Tozie's behalf, Jen's, Ted's. This was incredible for all of us. I think a lot we're going to take away, and glad you ended on the high note of lawyers can be helpful. So thank you.
And if I could thank you all the panelists. I will second those thanks heartily to all of the panelists and to David and Sozi. And I'll make a general point in a minute as we transition, but I am contractually obligated as a dean to brag about Penn. And on this point about interaction with lawyers, Lauren Steinfeld is teaching privacy law at the law school, and also just so proud to see two of our graduates or soon-to-be graduates of the ML program on this panel. What is the general trend, and this is, and I'm really glad we're expanding our education for non-lawyers, but the general trend that I think is good for legal education, good for the country, is that the fastest growing by far segment of legal education, I would say about 25% of law schools now are offering, is educating people outside the JD program, and just recognizing, as these brilliant thinkers have illustrated, how so many other fields intersect with law, and that we can benefit as schools, and certainly the reaching out beyond our conventional 3-year program has really been an important development. It's really just in its infancy, but there are by far the fastest growing number of students taking classes toward a degree in American law schools are not JD students. They're students like these ML students, which is a great thing for law, and it's a great point of connection. So, and it's not just happening at Penn. It's kind of sweeping through the country in ways that I think are very good. We're going to reconvene at 2 o'clock, and look forward to hearing from some more students and from our speaker from Australia. Okay, thank you.
Great.
This conference makes so apparent, the legal profession is in a state of rapid change, and many law firms risk being left behind if they continue to rely solely on the quality of their legal services to sustain future business. Pepper Hamilton recognizes that clients view excellent legal advice as a table stakes capability, and that true differentiation requires a commitment to innovation across both core practice areas and critical support functions. By investing in creative price structures, multi-model project management, and new technologies in both the litigation and transactional arenas, Pepper can deliver bespoke solutions to clients in a transparent, secure, and collaborative manner. Visit pepperlaw.com to learn more. On January 9, Pepper Hamilton and Troutman Sanders announced that the firms had agreed to merge effective April 1st, 2020. The new law firm, Troutman Pepper Hamilton Sanders LLP, or Troutman Pepper, will have 1,100 attorneys in 23 offices across the country. Troutman Pepper will offer expanded capabilities and practice strengths while continuing to deliver powerful solutions to clients' legal and business issues with a hallmark focus on client care. From a deeper bench and expanded geographic footprint to innovations in technology and service delivery models, Troutman Pepper will bring together the complementary strengths of both firms to provide new opportunities for clients. Each firm brings a breadth and depth of experience, serving clients in a multitude of areas, as well as complementary industry strengths spanning most of the industries critical to the U.S. economy and providing a natural client and cultural fit. These include flourishing corporate, litigation, intellectual property, tax, and bankruptcy practices, among others. Health sciences, energy, real estate, construction, insurance, financial services, private equity, and technology are the largest industries served by the combined firms. Troutman Pepper will have an office in 8 of the 10 largest U.S. markets. The firm's expanded footprint creates more robust practices in the Southeast, Northeast, West Coast, and Midwest regions of the country, and a foundation for further strategic growth.
Okay, everybody, thank you for rejoining us in the main area. Thank you to everybody online who is joining us in the conversation. I'm just looking right now at some amazing thoughts that everybody's sharing. Keep on sharing your thoughts. Hashtag Law 2030, hashtag Future of the Profession. Earlier today, we heard from many different innovators in other fields. I often tell the dean that one of the coolest things about my job is I get to go around campus and hear from people who are innovating in other disciplines. And if you put me in an MRI machine, I think my brain would light up in all new ways. And I'm not sure whether that is what actually would happen. And the medical people in the room could tell me if that's correct. But really infusing new ideas into a conversation that we've been having for a little while now. And some of our innovators reference design thinking or user-centered design, which I think for some legal professionals is something that you're really familiar with. For others, you've never heard of it before, never used it before, don't know anything about the framework. So we have brought an expert in user-centered design, and we also really wanted this to be a global conversation. So our expert hails from Australia. He is Gary Cazalet. He's an associate professor of law at Melbourne Law School at the University of Melbourne. He teaches across a broad range of subjects, including law apps, human-centered design, trial advocacy, dispute resolution, and law and literature. His areas of research include the teaching and development of creative thinking skills in legal education, human-centered design, innovation and technology, and civil procedure. He's also a qualified mindfulness-based stress reduction teacher. Prior to joining the law school, he was a barrister at the Victorian Bar, a mediator, and a solicitor. So we're thrilled to have Gary talk to us about how we as legal professionals can use the user-centered design framework to design better legal service delivery. Thank you so much, Gary.
Thank you, Jen. Thank you. Thank you for inviting me, and it's a pleasure to be here. First of all, I just want to see from the people who are in the audience, I can't see people who are watching from somewhere else in the world, but how many people here consider themselves teachers? Your hand up if you're teachers, okay. And how many people here have a kind of a job where their job is to inspire other people? Okay, so pretty well everybody in the room and probably most people listening fit that kind of description. So what I'm going to be talking about today, at least from my point of view, is from the main perspective of being a teacher at Melbourne Law School. But of course, as you've heard in the introduction, prior to that I was what you might call here a trial lawyer or a barrister, and I was also working in a law firm as well. And I've been asked to provide a description or an overview about human-centered design as it relates to lawyers and legal work. And whilst it's been described, at least in the program, as client-centered legal design, I want to describe it as human-centered legal design. As we've heard time and time again over today and yesterday, our work as lawyers and as academics is really about people. Even when we work for corporations, we're still working with people. We don't really talk to robots, well, at least unless we've got a phone and we have to ring up somebody and talk to a robot. But most of the time we're talking to people. So today I'm going to provide my perspective on human-centered design through a kind of a process, at least with a little kind of journey. So this is why I've got this photograph here. One of the reasons I've got the photograph here. I took this a couple of weeks ago when I was having a hike in Australia for 2 or 3 days. And I quite like having photographs of nature because we don't see a lot of it when we're in rooms like this where it's kind of dark with a bit of artificial light. So just look at it for a few moments and just imagine that you're somewhere else for a moment or two. Not too long, otherwise people might leave the room. But I chose the photo to illustrate a couple of things. First of all, I wanted to talk about my journey as a teacher and my journey as teaching the subject that I teach, to learn about human-centered design and why I introduced it into the subjects and some of the other things I'm doing. And recognising that I, at one point, didn't consider myself sufficiently equipped to teach the things that I wanted to teach, including the area of design. Then I want to talk about our journey as academics, as judges, as lawyers, as people working in the corporate area, maybe healthcare professionals. We've heard from a number of them today as well, about learning about both design, but also about unlearning some of the bad habits that we've got. And you've heard that I've been a lawyer for an awfully long period of time, so I think I can admit to learning some pretty bad habits. And I want to talk about unlearning them and relearning some of the things we used to know before we went to law school. And I will also talk to you about the process of human-centered design. Yesterday, our first speaker, VG, was talking about strategic intent. And one of the things that he said was, you need to have kind of an end date. Well, I don't have an end date for my strategic intent, but my strategic intent really is to inspire my students to be as best as they can, to reach their potential. And when I talk about that, I'm not actually just talking about them being leaders. So we've had a lot of talk about leadership, which is a really fabulous thing, but I also want to acknowledge that not everybody wants to be a leader. Not everybody can be a leader. So part of human-centered design is also uncovering some of the other things that people have. So in my classes that I have, they're normally in teams, they have to collaborate. And in a team, you generally don't have 8 leaders. If you have 8 leaders in a team, you've got a fight going on. So I also want to talk about some of the other things that students learn in that kind of process. Last thing I want to say about it before I move on is I don't want people to think that I think that human-centered design is the golden arrow that fixes absolutely everything in the legal sector. So as you've heard, I've worked in the kind of corporate legal sector, I've worked as an academic, I've been on the boards of not-for-profit organisations that work in the legal sector as well. So whilst I see human-centered design as being very useful for lawyers, it ain't going to fix everything, but it's something that's very, very useful. And the other thing that I want to talk about in relation to human-centered design is how it can impact on the personal lives of us as lawyers and of law students. So normally it's seen as something that's external. It's something that we can do and add to other people's lives. What I also want to talk about is how it can add to the lives of the people that are doing human-centered design and learning about it. And I'm going to focus on 3 aspects of human-centered design. I will talk about the process in a little while. I'm going to talk about empathy. I'm going to speak about creativity. And I'm going to speak about prototyping. Each of those areas, I think, have lots of challenges and lots of opportunities for us as lawyers. So let's start with a little definition of human-centered design. Tim Brown, in a really excellent book called Change by Design, describes it as a process or a set of principles or skills that can be used to generate breakthrough ideas that are implemented and therefore have impact. Or as my friend and colleague Margaret Hagan says, design is about making things that are intuitive, engaging, valuable, and beloved to the people that use them. Human-centered designs puts the client in the centre of the process, not at the end of the process. Human-centered design is a design process that uses the humans, uses the end users as part of that process. So we've already had a brief description of human-centered design and design thinking in a number of earlier presentations. I just want to take you out of the legal world to another world. We've heard a lot about the healthcare sector. So this is a sign that I took a photograph of when I had one of my parents, I can't even remember which one it was, in a hospital earlier this year in Melbourne, Australia. And I noticed this on the wall. For those that unfortunately have had anything to do with the healthcare system, and I presume it's similar in the States as it is back in Australia, there's been a real change in it in the last 15 or 20 years, in that the patient, who used to be just the kind of end product, has very much been involved in a lot of the processes. There's a lot of empathetic lawyering, doctoring going on. There's a lot of consideration of the patient in the context of healthcare. And design thinking, whilst traditionally was thought about design for objects, designed these beautiful chairs that we're sitting on here, designed for these couches, designs for iPhones and iPads and things like that, one of the major changes in the last few years is thinking about design around service delivery. And that's kind of what we are as lawyers. We deliver services, or hopefully we deliver services. So I'll take you to another picture, and this is from Argentina. A friend of mine down in Argentina is a design anthropologist. That was a term I didn't know a few years ago. It is a person that goes out into the community, works with the communities, understands what the community's issues are, and then provides effectively a brief about that. So this is a couple of pictures from her in Argentina. She was doing a project on behalf of Facebook. She was working with entrepreneurs or small business people to understand how they used the internet, they used Facebook and Instagram, etc., to grow their businesses, what issues they had and so on. So she went out with other people and teams to various parts of Argentina to understand that. It doesn't look like around a boardroom table. So they take objects, they work with objects, and they talk to people about those objects. As she says, the people are part of the team. And I want to emphasise that as for us as lawyers is our clients are part of the team. Consumers and the wider community is part of our team in human-centred design. It's not what we do things to, it's not people we do things for, we actually involve them as being part of the team. And as I said, I'm going to be talking about some of the challenges in design thinking, so we'll have a little think about that as we go on. So a few things that I'm going to bring up here is some challenges and opportunities. As I said, I think you probably all recognise that design thinking is used in a whole lot of areas, objects, some kind of service delivery as well. But what are the challenges for us as lawyers with human-centred design? Some of them are the way legal work's been done in the past. And we talked about that a lot yesterday. It's always been done in that kind of way. That's the way we do it around here. We work our way through firms and eventually we become partner, and that's when nirvana happens. Apart from the fact when you talk to a partner of a law firm, you find out it ain't nirvana, but don't tell people that are still working up to become partners. So there's one of those kinds of things. And then one of the other issues is the kind of common character traits and outlooks of lawyers. And we talked about a number of those yesterday as well, and I'll talk some more about that. What is it about us as lawyers that I'm going to say really challenge the opportunity for us to be good design thinkers? And what I'm going to reverse that and say, what are the great opportunities for us as lawyers to become good design thinkers? And so what I'm going to say is there are really some profound things in design thinking that can change both the delivery of legal services, but also effectively our happiness and our enjoyment in being what we are. So let's talk about why. Why should we use human-centred design at all in relation to legal services? First one is there's problems. We've had people talking for yesterday and today about the real problems in legal services delivery, access to justice, people understanding the legal system, cost, etc. So there are a number of reasons why in relation to legal services delivery we need it. We need to reimagine how that delivery services will go. And as I've said, that's an external factor. Internal factor, and we've had a little bit of talk about it, but I know that this initiative that Penn Law is doing also thinks about well-being for the legal profession. And the statistics in relation to well-being for lawyers and law students in this country are as bad as they are in my country. They aren't good. And they get worse once you start law school, and it kind of doesn't recover that much. Now, we may have a lot of happy lawyers in the room, or we may not, but I'm sure we've got a lot of lawyers that have got a number of other issues too, because that's just part of effectively what a lawyer is in the United States and in Australia. And what I'm going to suggest is that human-centred design actually has, or possibly has, a possibly good impact on the well-being of my students and lawyers. Because essentially human-centred design at its essence is about two things: creativity, and we'll talk about a link between creativity and well-being, and care. Because if you're using human-centred design, the design of legal services or any other services, you're thinking about the end user. You're caring for the end user. You're thinking about how she will operate the system, how she will receive the services, how she will understand those kinds of services. So there's some really wonderful things about the aspect of care in the delivery and design of legal services that I want to talk about. And then there's this other thing called creativity. So there were some discussions about that yesterday as well. So from the World Economic Forum report of 2018, we heard some statistics yesterday. This is the one from 2018, which says, as you'll see here, that today in 2018, that's a couple of years ago, that's where creativity, originality and innovation go. And you can see them moving up the scale. We heard yesterday that it's the number one skill that our employers are looking for, or companies are looking for, this thing called creativity. The question is, what is it? So in the most watched TED Talk of all time, 64 million this morning, it said, from Ken Robinson, he says it's the process of having original ideas that have value. That's out of his book, Out of Our Minds, Learning to be Creative. Another definition says developing solutions or responses that are novel, that is novel and appropriate. And there's a lot of work that's been done to show that there's a clear relationship between creativity and people's feeling about being able to be creative and well-being and happiness. In fact, at my university, the University of Melbourne, there is an interdisciplinary partnership across a number of faculties looking at creativity and well-being. One of the things about creativity is you've got to have a tolerance of ambiguity. That's not something that lawyers are normally very good at, because we kind of want not ambiguity. We want to know what things are. We want to have certainty. And if we look around the room and ask the room, how many law schools here teach critical thinking and analysis, I should hope that everybody will put up their hand, because that's a core skill for law school and law students, critical thinking and analysis. But how many people here could say that it's a clear objective of their law school to teach creativity, originality, and innovation? That's another thing, and that's probably not taught, at least in my discussions, that often, or at least explicitly, around the world. It might be a byproduct, but it's certainly not something that is taught explicitly. And I'll come back to that a little bit later on. So this is some students, in fact, in one of my other classes. I'm going to be talking about one of my subjects called Law Apps in a moment, but this is students in one of my other classes, my Law and Literature class. So in my Law and Literature class, we look at literature about the law, we look at law as literature as well, and then I take my students across to a gallery we have in the university, and I don't give them any warning about this, because if you give them warning, they probably wouldn't turn up. They go into a room, I hand them pieces of paper, I hand them Sharpies and crayons, and I say, hey, draw your relationship to law. This is the kind of typical things that they draw. So you may or may not be able to read that, but it's career, success, all of those kinds of things on one bucket on one side. And on the other side, there are the other competing demands called family, home, familiarity, time, comfort, things like that. That's kind of how they see part of their job and their home and their other interests as being balanced or out of balance. Well, this is another one. So I wasn't teaching an art class. I was just asking them to draw. This is a greasy pole. I think you probably know what a greasy pole is, because I can hear from the audience they know what a greasy pole is. So this is a law student trying to climb the greasy pole of her career. They're not necessarily very positive things. I'm not actually going to ask you to do this. I was, but I'm not going to ask you to do it now, because it might be just too intimidating. But I'm going to ask you or suggest to you sometime at home, maybe when nobody's looking over your shoulder, spend 30 or 40 seconds and draw your relationship to law and see what it tells you in the visuals about your relationship to it, and then maybe have a chat to somebody else about it as well, and think about both the process of drawing, because if I said to you now, and I know because I've done it plenty of times, if I said to you now, I want you to put down your iPads and your computers, and I want you to pick up a piece of paper, and I want you to pick up a pencil and draw something, there probably wouldn't be anybody left in the room pretty quickly. Most of us find it very, very difficult as lawyers to do that, to express ourselves in that kind of way. But part of human-centered design is visual. You're expected to be able to draw, not necessarily well, but draw a number of things while you're doing it. So creativity, and I'm just going to speak briefly about it here, is central to the process of human-centered design and innovate. It's been said that the law sharpens the mind by narrowing it. Narrowing the mind doesn't normally assist creativity or innovation. We've heard countless speakers, a number of speakers talking about that. So what do we do about this? as academics, as lawyers, as working in the legal system. If creativity is important for innovation, what do we know about creativity? I've given you a definition, but let's have a little think about some of the things about that. One is that creativity is something that can be killed, beaten up, or crushed. And I have to say, when I talk to people around the world about their experiences of university and particularly law, is that they often feel that their creativity and that's part of their personalities have been crushed or left out entirely. In Ken Robinson's talk on YouTube, he talks about, does education kill creativity? 64 million people, the most widely watched YouTube of all time, suggests to you that other people think that too. His focus is in primary school and secondary school. I'm not sure, elementary and secondary, is that what it's called here? First two, not universities, but I think universities have just the same issue as well. But we're all born to be creative. If you've had small children and you handed them a pencil and a crayon and said, draw your dog, draw your relationship with your sister or your brother or your mum or your dad, they'd just start drawing. There wouldn't be an issue about it. They play, they talk, they make up imaginary creatures and so on, but there's this process as we get older that we just don't do that. So as I said, I think it's a very deeply personal thing, this creativity stuff. It can be killed, it can be crushed, but it can be inspired again, given the right circumstances, the right modelling, the right teaching, and the right environment. So what kind of environment is that? So if we're in a law school or we're in a firm or we're in a company and we want to inspire creativity, what do? So my reading on this and my experience as a teacher says a number of things. First of all, you've got to create a psychologically safe environment. Okay? If everybody's stressed and they're worried about losing their jobs, they aren't going to be very creative, because creative is about risk-taking. So it's got to be a psychologically safe environment where ideas and fears and possibilities can be expressed without worrying about being shouted down or being looked at as a fool. The other area is the idea of an informal and open setting. Creativity rarely happens sitting around a boardroom table, and it rarely happens sitting around a table where two people are facing each other. There's no pens or paper or drawing paper or anything else there. In my experience, creativity happens. That's why we're in a space like this. It's a different kind of space. It often happens in nature for me, and it often happens walking for a lot of people as well. So there's a physical element to that. Sometimes I've taken students out of my classrooms and we've gone for a walk and I've given them things to talk about. Part of that role of trying to inspire creativity. You need an environment that inspires divergent rather than convergent thinking. Kind of the opposite of a usual law environment, where a professor asks a question and all the students are worried that if they make a mistake, they're going to look an idiot. There's got to be the one answer, they think. Whatever that answer is, I've got to find it. That, of course, is convergent thinking. So creating a space where a number of answers are possible, where people can think about those kinds of questions without worrying about what they say. A couple of other things. Tony and David Kelly, in their great book called Creative Confidence, which I would recommend, talk about a relaxed attention, which I really like. That's called having a shower, or going for a walk, or daydreaming, or waking up in the night and not being stressed, but just allowing your thoughts to think about some of the things that you want to concentrate on, but in a relaxed kind of manner. The last things I want to say is about creativity. As I've said, it's deeply personal. Critical analysis and so on, I don't think has quite the same. But one's creativity is a very deeply personal thing. The other thing is that we as, for some of us older members of the profession or academic life and other people younger, have to model it. All the research says if you're trying to teach it and inspire it and you don't model it, it ain't going to happen. You've got to model it as a teacher or as a law firm partner or as a lawyer in a firm or wherever else you work. If you don't model creativity, nobody else is going to follow it. The problem with that as I've already told you, creativity is about risk-taking. It's scary. And for many of us as lawyers, it's not something we really like doing that often. We don't really want to take a risk. We don't want to be in a position where we might be scared about what we're doing. But that, I think, is one of the most important lessons for us if we're going to describe ourselves as leaders, to be able to do that. And we don't really want to have our students decide that at the end of their lives, well, this person's life did end, but she died of a medical condition, that's all. I think worse than that. But I saw this as I was walking through Highgate Cemetery a couple of years ago. I didn't make it up. So you probably kind of want to think, okay, where do I fit in this whole equation? So let's talk about the process. This is one of the processes. There are many. We had somebody talking about it just before lunch with, I think, 3 or 4 of these. But I'm going to talk about each of these, some in more detail than others. This is a process that has been described at Stanford in the D School, where I did my first initial training around design thinking in the D School. And I'm going to look at each of these steps individually. A few things I want to say about this process. It ain't linear. So take off our lawyery kind of ideas of you do this, and then you do this, and you do this, and then you get to the end result. And thank goodness I can give up on it all. It's not a linear process, even though it's kind of drawn as a linear process. I'm not normally a big PowerPoint person, and I thought, well, I could get a slide where they all go all over the place and open and close and do all those kinds of things that fancy people do. So I didn't do that because sometimes it makes me kind of feel a bit freaked out about it. So don't think of it as a linear process, nor do I want you to think about them as clearly defined steps. They merge, they overlap. And nor is it a process where you get to the end and that's it. Most of the time, design thinkers will tell you you've got to move back and move forward and move back in the process. So sometimes it's been described as an exploration. So let's talk about how. First of all, I want to suggest to you that design thinking often doesn't happen inside in an office. You've got to get out, and I'm going to talk about that in the context of one of my subjects in a moment. This is a lecture, I don't know if you call it a lecture, a walking lecture that I did in Dunedin, New Zealand, a couple of years ago, where we went out, took people out into the Botanic Gardens. Again, don't give people too much of a warning about this if they're lawyers, okay, because they won't turn up. Just say we're going to have a happy time in the morning and we'll find out what's going to happen. So I'm going to talk a little bit now about this particular process with these students. So I teach a subject called Law Apps back in Melbourne. Law Apps was modelled on a subject taught by my friend Tanina Rothstein at Georgetown, in which students build web-based applications that provide tailored legal information or advice to the end user. They mimic the thought processes of lawyers and any other professionals that might have been involved in the design of this. So we have in this photograph Emma, Jean, Dave, Nico, Lucinda and Keisu. They were in my class last year. Their job was to work on designing a prototype app for people in the elderly Chinese community that might have chronic illnesses or were elderly, to help them with what's called an advanced care directive. Do you have things like that here? You do? Okay, so some people know what that is. That is providing information to your doctor and your family. You're not capable of providing that advice about what you want to happen if you get really sick. So what I had noticed in the background to this is what I'd noticed when I taught this subject earlier on for I've been teaching, I think it's my 6th year now, was that my students were designing applications, but nobody was using them. And they weren't using them often because the students designed them with what they considered good legal language, good legal words, here and before, thereafter, and all those other kinds of words. And luckily we don't use quite as much Latin as you do here, but those kinds of words, and not really thinking about how the user would interact with it and whether it was actually useful. So I'm going to talk about the little journey that they went through in designing this prototype. And prototype really only had a couple of constraints around it. One, that the client was people in that cohort. Elderly Chinese people or people with chronic illness in the Chinese community in Melbourne. We've got a lot of Chinese people in Melbourne. The second thing is advanced care directives in my state, if they want to be legally binding, at least at the moment, have to be written. They're often a long form, they're difficult, they're complex, and they're often fairly traumatic, because I know I've done one with my father. They're quite difficult to do. And hardly anybody does them. So this project was to look at, could we use video? Could we have people speaking to video and put together a video where the people could express their concerns and what directives they wanted to have to the doctors? So the students were working with the community, but we're also working with people working in palliative care and oncology as well. So I'm going to talk a little bit about the kind of process. This is a screenshot of the end result, and we're going to come back to it in a little bit. So the first aspect that you've got to do is a thing called empathise. Okay? Connecting with and understanding people at their level. So the first part of this process was for the students to go out. I always make my students go out to the organisation. I don't let, in rare cases, the organisation come to them. I want my students to go out and get a feel for the environment. The first picture in Argentina, they went out to the back blocks of Argentina. You need to go out to the place where your users are. So they went out to the suburbs and they met elderly Chinese people. They met the people in the chronic illness society. They went to the community house where the people gather. They talked to these people. We had a few students, they self-selected for this group, that could speak Mandarin as well. Mandarin? Cantonese? I can't remember exactly. And they interviewed those people. They also interviewed intensive care specialists, palliative care people as well. So what did they learn? This was going to be a really hard project. What they learnt was, the feedback, Chinese people don't like to talk about death. Why do you want to talk about death? I'm happy. I don't want to talk about death. That's a real issue if you're going to do an advanced care statement. Secondly, they thought the family members would just ignore them anyway. They don't want the government or other organisations having access to their information. They don't want to do it if it's final. You know, you've done an advanced care statement and it's final. What happens if I change my mind? But they also realise that people don't understand them, and of course that's not limited to the Chinese community as well. When they talked to doctors, they found out a few things. They would really like to know what people thought. If they don't have an advanced care statement, they've either got to deal with the family and they could be fighting, so who gets to make the decision, or they don't have a family and then they've got no idea to make the decisions towards the end of the people's lives. And they don't, in their job, want to have to deal with family conflicts. They've already got to deal with the patient. They don't particularly want to deal with family conflicts. So I'm going to talk a little bit later about how that all played out. So the challenges and opportunities. First thing I want to say about empathising is it ain't brainstorming. So empathise with clients in human-centred design is not us getting into a room with some post-it notes on our own and brainstorming a solution. That's hard, again, because it means that we have to wait. And we as lawyers don't often like to wait. We really want to get to a solution quickly because that's our job. But we actually have to spend time working, understanding, watching, asking questions, and not being the expert in the room. So this is a challenge that I've also recognised. We as lawyers consider ourselves most of the time as experts in the room. Then if you can imagine if you get a doctor and a lawyer in the room, then it can be a real conflict. But let's just take it at the moment that lawyers generally consider themselves the expert in the room. Throughout this process, what I say to my students is you aren't the expert in the room. The experts in the room are the people you're working with. You might understand a process that you're going to take them through, but don't be the expert in the room. Global law firms that I've spoken to have got empathy interviews built into their agreements with some of their large clients. So they actually explicitly agree to empathy interviews as part of the process when they're working on large projects with their clients. Seems kind of crazy, but it's true. They also build it into the budget, explicitly into the budget with their clients. And the clients say it's worthwhile because they actually understand the issues early, not after they've come up with a solution and then they have to revise the solution. The next step is definition. Defining the problem or the issue. And again, it's got to be something that can change. You might define what the problem is at a particular point, and then in the process realise that that definition or the way you've defined the process needs to be changed. I'm not going to spend a lot of time on that because I want to talk about a couple of other ones. Ideation or ideate. I've mentioned convergent and divergent thinking. Ideation is also a little bit difficult for us as lawyers, I'm going to say, because, again, we try to come up with a solution. The best solution, the solution that we know is the best solution, and sometimes we try and sell it to our clients. But here, the idea is to come up with as many different solutions as possible and not be attached to any of them. One of the kind of processes that you do in a fun game is imagine you've got $5 to fix the problem. I did it around well-being in one of my classes at law school, not in my law apps class, another one. So you've got $5 and we're going to fix well-being for law students. Oof, that was fun. Now you've got $5 billion. You come up with a different solution. And then you give them other constraints. But you spend a lot of time coming up with different solutions. So this is a workshop we ran with community organisations, legal services providers back in Melbourne. You can see it doesn't look like a traditional kind of environment. People are standing up, they're moving, they're collaborating, they're talking. It's not one person's ideas, it's many people's ideas. This is one of the things that they came up with, which is dealing with community housing for women in crisis. This is a picture from Herbert Smith Freehills, large law firm based here, UK and Australia and in Asia as well. So I asked them, what do you use design thinking for? Is it just stuff that we do in law school? So they gave me 3 areas that they use design thinking in. They use it in a matter or a product level to understand the overall pain points for clients and markets. And they use it at a client-specific level to listen to the clients and work out what kinds of pain points they have. And they often work together with their clients in that. So in this photograph, there are people from partner level, solicitor level, and the client working. So they may work on their own, the firm, they may work with their clients, or they may in fact provide the training to the clients for the clients to do it themselves. And they have a national and a global design thinking network within the firm. I've mentioned a few of the challenges and opportunities here. Let's talk about prototyping. So prototyping, this is one of my classes where they're working on a particular prototype. I quite like seeing my students' faces in this. They make physical objects. You'll find in a lot of design thinking writing, they talk about using visuals and physical objects. So they are building physical objects. There are pipe cleaners, there's cardboard, there's things that they're not used to doing in a traditional law school environment. And when they build a prototype, and they were building a prototype for their fellow students here, they hand it over to their fellow students to get feedback. This is another challenge for my students, and perhaps for me as well, is when you build something, you love it. You want to tell people how good it is. And you hand it over to a person. Well, in fact, it's fairly interesting to watch it because normally you don't actually hand it over. You just hold on to it and say, hey, look how good it is. So the challenge here is to actually let go physically to the object and give it to another person and then shut up and listen. It's wonderful to watch and wonderful to see what the students learn in that process. To be able to give up ownership of a particular idea or an object in particular, something that they've spent some time thinking about and think is really good. Okay, so let's talk about the findings and what my students in the application that I was talking about before found and what they did. So I've told you their finding was that Chinese people didn't want to talk about death and sickness. What they learnt through their prototyping and their empathising was they needed to change it. So now the app, the prototype of the app, is quite different. What they learnt was that the community was interested in family. Family was very, very important. So now and I'll show you a screenshot of the end result in a little while, it emphasises that this app is about your family, providing information to your family about your wishes so that there's not going to be a conflict. If you're sick or you're dying, your family will be assisted by this process. It talks about empowerment, choices and values. They found that many of the people that they spoke to were actually not very fluent in either written or spoken English, so they provided a completely translated version of the app alongside the English version. They found that there were various language proficiencies, so that sometimes people would have a Chinese speaker and an English speaker assisting them, so the translations can sit side by side. Some people were illiterate in both Chinese and in English, so they provided videos to show and to speak to the people about the process. So those videos are explanations that people can watch and understand. This is the kind of feeling in the room, just getting a sense of it, of the process. A short one of my first experience of design thinking at Stanford. You've got to be prepared to look ridiculous sometimes. We ended up walking around with those headphones that were made out of pipe cleaners and aluminium foil around the Stanford campus getting feedback. So if you ever go to kind of campuses and people approach you looking like that, they're probably design thinkers, so just be nice to them and realise that they're frail human beings. Okay, so I'm going to move through a little bit more the building kind of process. So the end, at least of part of this process, is to build something. So my students, one of the prototypes, they built. Again, it's not the final product. The application that the Chinese group built is a prototype, a final prototype, but it will have more user testing. They will go back and get feedback in relation to it. I'm going to play you a short video of one of my students talking about what they did for this process.
Our app is for the elderly Chinese community, and it's digitalised as an advanced care directive, which is like a medical form that allows someone to express their wishes around future treatment. The elderly Chinese community are particularly disenfranchised when it comes to this because of barriers around cultural beliefs as well as literacy and language. So creating an app that allows them to record their wishes rather than write it down, which is how the form is at the moment, we can overcome some of those barriers. Being able to go out to Box Hill and meet a group of elderly Chinese people in their community centre and sit down with them with all these different interpreters, cross between Mandarin, Cantonese and English, and figure out what we needed to put in the app was a really fun experience.
So I've got a couple of screenshots just to show you what at least the final product looked like. This is the first page, and if you go down the page, you'll see a number of things. So there are images that were designed or at least decided by the students. They refer to a number of things that I've already mentioned. The idea of it's actually your values and your choices, the decisions that you make, that it's easy to use. That there will be video recordings, but you can revise at any time. It's not final. It's not something that you've decided now and can never do again. It's actually very easy to do. It's bilingual and that it's private and secure. Only the people that make it have access. They could provide the key to their doctor if they wish or to other members of the family. I'll briefly play a little video here of one of the videos that's in the application. It's going to work. Let's see.
我哋嘅生活將有一日結束。雖然我哋可以無法控制自己嘅壽命，但係我哋可以提先計劃我哋對將來嘅願望同埋家人嘅提出建議。預先護理計劃 ACD 係一份文案，可以俾你記錄未來嘅醫療、預世、離別嘅安排、理想嘅生活安排同埋其他事項嘅喜好。例如，你可以希望喺家中接受治療。如果你無法做出任何嘅決定，喺 ACD 可以指導醫療決定者代表做出你嘅醫療決定。 製作 ACD 對你家人及你提出醫療護理人員都有好處，促進家庭嘅團結。如果你無法表達自己嘅意見，但擁有 ACD， 將幫助你嘅家人做出非常困難嘅健康決定。同時喺危機同埋傷心嘅時刻，家人好難知道點樣做。通過你嘅意願 ，ACD 將幫助你嘅家人保持團結、堅強同埋完成你嘅意願。財務嘅問題，我哋其中好多人都擔心年老時嘅經濟問題。如果與家人討論你首選嘅醫療方式，可以減輕以後不必要嘅壓力、負擔同埋花費。授權人同埋醫生嘅知識幫你填寫 ACD， 可以保持你嘅尊嚴，確保你嘅家人知道你嘅意願。在你嘅無法表達你自己嘅意願嘅時候，ACD 幫你嘅醫生同埋家人更加了解你嘅健康嘅情況，同埋做出應有適當嘅選擇。
So, reasonably lengthy, but I just wanted to show you how the students decided that they should address a number of the issues that I've already identified. So, I'm about to come to the end of my presentation, and the reason that I want to show you this, third last slide, is to remind you that the process is not finished. They've got to this point, but it'll be revised, they will take further feedback, and so on. I won't spend more time on challenges and opportunities. I want to spend time on, you can have another look of an outdoor photograph, and thank you very much for the invitation and the opportunity to present today. Thank you.
Thank you so much, Professor Caslay, for joining us. Professor Caslay officially wins the award for farthest traveler joining us from Australia, so we are particularly grateful to him for coming to this part of the world. Thank you so much. We are going to take a 5-minute break. Our students have been hard at work implementing the framework that Gary just shared with us, and at 5 of 3, we will start hearing their ideas. They worked with a client to solve a non-legal problem that plagues the profession, and they will give us our ideas on how to fix it. We'll see you back here in about 5 minutes.
Makes so apparent, the legal profession is in a state of rapid change, and many law firms risk being left behind if they continue to rely solely on the quality of their legal services to sustain future business. Pepper Hamilton recognizes that clients view excellent legal advice as a table stakes capability, and that true differentiation requires a commitment to innovation across both core practice areas and critical support functions. By investing in creative price structures, multi-model project management, and new technologies in both the litigation and transactional arenas, Pepper can deliver bespoke solutions to clients in a transparent, secure, and collaborative manner. Visit pepperlaw.com to learn more.
This is obviously a very difficult decision. But in the meantime, I'm going to invite John Ondick, the founder of the Ondick Group, up. He has been working with these student teams all morning, coaching them through, thinking through the problem, talking with their clients. And he's just going to come up and ask our students and the clients about how the experience went for them.
So first I have to get something out because I got yelled at by multiple teams. They did not have 5 hours to accomplish this in. They had more like 3.5, and I got a lot of evil eyes from people that were going, it wasn't me. So without any further ado, it was really my distinct pleasure to spend the time with these 12 incredible students this morning. And I think we got to a good place. I was very impressed with all the presentations. Couldn't have happened without our 4 clients, 3 of whom are here. And so are there questions that you would like us to ask of the students in their process? Oh, I'm sorry.
Is this okay? Hi, I'm Roz Pitts. I'm the Director of Professional Development at CAT. I'm resident in the Charlotte office. And I guess I wanted to ask the teams, did you feel like you had enough information about what the problems are to be able to solve them?
Very quickly, I think what was really helpful about this process was first to be given a bit of a prompt about broader context, but then being able to sit down with the client and role play that through. And I know we certainly felt Tiffany, who's not here, she really gave her time and was really prepared to share a lot about her experience. That was fantastically useful.
I don't want to repeat that, but also we had a really nice rapport with our client where we would talk in the room by ourselves, and then she would come back in, and then, so it was a back and forth continual process.
Hi. Shannon Callahan from Nixon Peabody. I didn't really have a question, except for I wonder if what I shared colored what you came up with, right? It would have to, because it's a global problem, or sorry, at least an industry-wide problem. And I wonder if my perception of it, which is, knee-deep in the trenches, talking to lawyers every day who are unhappy or afraid to share they're unhappy, colored what ultimate solutions you came up with.
Yeah, I think it definitely did for us. So our group came from different backgrounds, some from finance, some from consulting. And if we had done this in a vacuum in just an academic setting, we probably would have said, scrap the whole billable hours system, do something different, and really done something that was really kind of big picture and grandiose, but maybe not realistic. And we really thought that we had the most tangible, best ideas when our client left the room and then came back and sort of evaluated the things we'd come up with, and we were able to narrow them down and make them a little bit more achievable.
Hi everybody, I'm Courtney Wiley, and I'm the Professional Development and Wellbeing Specialist at the new Faegre Drinker, which just merged onto one, formerly Drinker Biddle and Wreath, and Faegre Baker Daniels, excuse me. A lot of names in there. Now it's just Faegre Drinker. That's what we are now. But yeah, I guess I had one question, and I loved that you guys do this because this is my job now. My full-time job is doing this in my law firm. And I loved like some of the solutions that came up, and you guys did an excellent job, especially with such a small amount of time. What did you think about your own solutions? I guess is kind of what I'm curious about. Like how bought into them were you on some of those? Because I am really curious about that. Like, you know, because these are things that like if I were to go home is my law firm. If I were to go back to my law firm tomorrow and try and implement some of this stuff, like really, are they even things that like you guys would really? I know you have to sell them for the competition, and this will not affect the judges' scoring of you. But I am actually really curious.
Someone who is a consultant for many, many years, I want to hear this answer myself.
I was just talking to my client afterwards, and we were joking about how once I actually get to a firm, because I haven't actually been in one, you know, I might have completely different ideas or be like, wow, what we thought of is, you know, not entirely feasible, but it was interesting to come up with.
Well, I think to Courtney was our client. So I've summered at 2 different firms, and I've seen that certain initiatives do kind of work, and I know I've only been a summer, not an associate, but even in interacting with people and having conversations, it does have a meaningful impact on them when partners, you know, swing by their office. And it's that kind of like small incremental things that maybe those weren't our ideas here because we tried to pitch bigger, but they do have some kind of an impact. So I totally buy in.
Echoing the theme, we also buy in. I think the ICO has fantastic spin-off potential as well. I mean, you know, you can just imagine the drinker dimes, the cravat coins. I mean, it lends itself to a franchise that, you know, I'm very excited to be starting with you today, and I'm still pitching right now.
We forgot the Peabody Pennies.
So, for the 4 folks here representing the teams and maybe the folks who are here, what did you think of the process?
I thought it was pretty difficult in terms of the time crunch that we had, and also that like certain ideas we had, we told them to Courtney, and she was just like, no, this won't work. So there wasn't a lot of time to just have an idea, see if it'll have any impact at all within like a small setting, like maybe one floor, one group at the firm, and then try to scale it up. It's just taking a guess on whether or not this will fit. And also the process was kind of coming up with one solution for the entire problem, rather than maybe tailored solutions.
Yeah, I thought the process was really helpful at the early stage because we had to really focus on, you know, what is the problem itself. And I think early on our first instinct was to just think of solutions, and we were kind of throwing solutions up the board without doing the deep dive and doing that kind of initial work to really understand more deeply what was the root issue. So I found that helpful. I thought having that framework helped us organize our thoughts a little bit rather than just dive in and try to prescribe something without understanding what it was addressing.
Pretty much the same thing, but I mean, not everyone's ideas is going to make it in there. I think I came in at first, you know, too big picture, like, oh, we're going to restructure the whole thing. No, we got to keep it reasonable, feasible, and simple. So.
You didn't play nice with him.
It was my own fault. No.
Yeah. So, when you were what was the most challenging part? And I'll tee that up a little bit. In how did you find the question and answer period we talked about was so fundamental to everything else that followed? Where did you come up with the questions? What was the dialogue like among you?
To answer the questions during the Q&A?
Yeah, no, not that. During the client interaction, right? When you were doing that empathizing stage, walking in their shoes, right? Asking the why questions. Talk about that experience a little bit.
I think we all had different questions that we were addressing. We kind of go down the line with a few questions, then we rotate, go down the line with a few questions. It was interesting to see the different approach that each member of our team had with the line of questions that they had to kind of see where it led them. And the feedback we got from her would, design the next questions. So that was an interesting process for us.
Yeah, I thought the sort of initial instruction or idea of just asking why, and then once you get an answer, asking why again helped us, especially when we thought about, initially we just wanted to blame billable hours, and then we thought, well, actually, this is really an issue of the firm controlling its culture versus individuals, maybe one bad actor really being able to corrupt a firm's culture if they don't buy into the whole process, and trying to build a system where that would be disincentivized, if not totally gotten rid of. so it was definitely helpful to just kind of keep asking questions and dig into some of our clients' deeper thoughts about their company and industry.
So truthfully now, did anybody come back to the 4-year-old when you were asking the why questions? Did it cross your minds at all? Nothing I said registered, did it?
No, I forgot the 4-year-old example, I'm sorry.
I did too, but I think at a certain point we just asked so many questions that we forgot that we were trying to solve a problem. It was just trying to really understand the situation, with all of our backgrounds, and eventually we just kind of like, okay, like let's move on to the next step now.
Did any of the teams jump into the problem solving too early or really early after you asked a couple questions, you thought you heard what it was, and you were down now designing that solution?
I think to that point, perhaps not too early, but what we benefited from was the iterative process. I mean, not only did we go back and forth with Tiffany, but I know, John, we also had quite a substantive debrief about halfway through the process. And actually that was a really helpful moment where we realized we need to slightly tilt the rudder on our idea and sort of go back to really the basic point of what is the problem we're trying to solve. So I think that's what we benefited from, definitely.
Highlighted the process of the day for you guys? What was the highlight?
Winning will
Maybe
be the
it's too early to
highlight
ask that
soon.
question.
But working with Courtney was amazing, and also like my teammates. It was just so interesting how we were able to come up with so many ideas, and just it was a lot more than we could think of because we kept feeling like restrained. We can't get over the billable hour. We can't really change who our clients are and how demanding they are. So it's felt the box was small, but we just kept trying to push it as much as we could, and that felt great.
Really liked working with you guys too, but welcome to my world.
Do you think you will take that 5-step process of design thinking or some variation thereof back to the classroom, back to your case studies, whatever it's going to be?
I think, as a 1L, it was important to me just thinking more about my career and mapping it out and really making sure that's something that you design really big picture and then bring that larger structure back into the nuts and bolts of what you're trying to do. So for me, that was where I more readily applied it, but I'm sure we can come up with a way to do it with cases too.
I was going to say I'd like to stay in touch with my group so I can send them all my problems and they can solve them for me.
So, funny you should ask. So maybe a client question. Was this just an academic exercise, or is there staying power where some of these ideas or the compilation of them are going to go back to your firms and generate conversations?
I don't think this is an academic exercise at all. This is a problem that we literally face every single day, and I came to my team with a very honest, I think, assessment of what I see at my firm every day, what I see from my lawyers every day, and what I hope to see. And so, in looking at these presentations, I know that some might be really viable and some ideas might not be, but I, for one, would love to take them all back with me and pitch them around another room full of another set of really brilliant people and talk about it again and see what we can make stick. So this certainly wasn't academic for me. It was fun, and it felt innovative, and it felt really nice to have a student approach to a problem that does feel small box sometimes, as Courtney said earlier. So thank you all. I really appreciate it.
So win or lose, right? I mean, that just summed it all up. You did things that are really going to impact potentially the way people are going to do their real business. So that's great. And by the way, during all the presentations, not only was I looking at the judges, but there were a lot of other heads nodding yes at different times in here from, I'm assuming, folks who practice law for a profession, many of you anyway. And so I think this resonated, right? It's one thing to develop ideas, implement. Not that that's the easy part, but at the end of the day, that's the easy part. The implementation, the execution is really going to be the key.
So does that mean we get copies of all the presentations and this lovely? Can we have? Yes, Jen says yes.
There we go.
The students are okay with it.
Yeah. And I would also be curious if anyone from the
That's billable.
Billable hours raises its head again.
I would also be curious if anyone from the audience had reactions to what the pitches were and what the clients
view of the problem was, because you guys might have really different views of them from what we see.
Anybody want a microphone to share? Got one over here.
I think they were some lines that cross across in terms of wanting more shared participation in the workplace. And I think we have to be prepared for that. And I know many other industries are already doing that. But the themes were very similar, even when some of the solutions were different. So I think it's a resounding message to our sector that we have to change if we want to keep the best possible talent within. So I think that's the message you should bring back.
Thank you.
I agree with you. You're preaching to the choir. P.S. Everybody, this message has been out in the legal profession since 1990. Not new. Also, there was the task force report, came out in 2016. Also, there was the pledge, came out in 2018. We're still here. So, yes, I will absolutely bring this back to my firm, but I'm already a champion for this, right? So I want the audience to really think about this too, because it takes more than just a small group. We all need to be thinking about how we do this, and bringing back these ideas and keeping them front of mind at our own workplaces, in the different labor organizations that we work. Because I agree with you. I do think things need to change. I think we're getting there glacially, but it's starting to get traction. We're doing things like this, right? Future of the profession. And so I think that's a big difference too. But I do agree with you. I did just want to point that out, that it sounds great to say that. We've done very little in response to that so far as a profession.
All right, our judges are back. Thank you very much. I just wanted to take a quick minute and just say again how proud I am of our students. And of course, I'm a little biased as the Dean of Students, but I do always say that if you're feeling pessimistic about the world and our future, you should ask a couple Penn Law students about their ideas, and you're going to start to feel pretty good about the future. So I think we saw that all on display here, and even though we're going to announce some winners, not to be cheesy, they're all winners. All right, but in fact, we do have some the judges have reached a decision. We're going to start with first runner-up, who the team will get a $500 prize. So judges, will you please let us know your choice for first runner-up?
Sure. This was a very difficult decision. We probably deliberated longer than anybody wanted us to deliberate. Oh, excellent. Well done. I've seen a good tap dance from you, so that's good. But I want to reiterate that it was a hard decision because there were so many good ideas, and gosh, I can't believe that you guys came up with them in 5 hours and then got up here and presented them so... Whoa, right. And then presented them so beautifully. So thank you for your creativity and being so articulate and enjoyable to watch. And thanks for putting up with our Sharky questions. So. Okay, but I know there needs to be a winner. So our first runner-up is Team 2, the Wellness Leadership Initiative. Would you like to do that?
And the winner.
And now the judges will announce the winning team, which comes with a $1,000 cash prize. And of course, the bragging rights, priceless.
And the winner is Team 3 Canary Council.
Congrats.
the other two teams to come up to also get their gift as a thank you for participating in a prize for their innovative ideas. It is a book of the future, which means it doesn't have paper. So. Students for their engagement throughout the day, for our sharks for their amazing questions and insightful feedback, our clients for spending their day with us, to John for helping coach, and of course vamp as much as you can up here. So please join me in thanking everyone who participated in this inaugural Future of the Profession Initiatives Student Design Sprint. I hope we see a lot more projects like this. I think it's a lot of great ideas today. And so now I'll turn it over to Dean Ruger, who is going to introduce our final speaker of this conference.
Thank you, Felicia. And in transition, just let me acknowledge and thank this amazing, the participants that we just saw. So first to the Shark Tank judges, thank you for your ideas and serving. I would say you were a pretty supportive group of sharks. I think if I fell into that Shark Tank, you would kind of nudge us to shore, but that was, we appreciate that. To the clients, it was a great exercise. I look forward to more of this. And as Dean, I would say, yeah, it's not an academic exercise, but I want it to be very much an academic exercise, and think of the amazing students and others. And we're doing more as some other law schools to build this into our curriculum. And so we already have that with Professor Dahl's clinic, with Mike Murphy and Praveen Kasuri in the Entrepreneurship Law Clinic, with some other courses, and we're adding more as early as next semester to allow, and catalyze this. So, and I'm going to want to talk to all of the student participants about how we can do that better. I also got the sense it made me optimistic about what we're doing here in law school, and for a few reasons. Number one, your pitches were so creative, but I could tell you were law students, and I say that as a compliment because you had the originality, the creativity, but I like to think that you saw a consideration of kind of multiple values, not just a straight line goal, some concern with process and with different preferences, and some of the things that more traditional legal education might open your eyes to. So I do think it's a heartening in a way to see and think that lawyers can innovate, but innovate differently and maybe more sensitively to different concerns than some other professions, and that's heartening. This whole couple days has been encouraging for what we can do at this institution and collectively with the broader profession and with other law schools, and just a few things I think that emphasize why this is the kind of place to do these things. First of all, at a law school, we're always a little competitive with colleagues at other law schools, but we're ultimately as able to collaborate as be competitive, and certainly collaborate with other like-minded law schools. And so I do want to mention and express gratitude for the fact a lot of other innovators from other law schools have been here the last few days. People like Kat Moon from Vanderbilt. We had the deans from Suffolk Law School, Pitt Law School, professors from Richmond, from Brooklyn, Northwestern, NYU, Columbia, Union College, the dean, Carlos, and have I missed any other law schools in attendance? Yes, Georgetown, Professor Rothstein. Thank you. So you were in front, you moved, but yes, thank you. And there's many other schools working on this who are not here. I mean, it's fair to say there's several dozen law schools working in this space, and we want to and should collaborate. There's certainly no shortage of work to be done. A couple other things that were evident today and yesterday, and here I'm talking to those of you who are not on academic campuses. Those of us in academia, particularly at a broad university like the University of Pennsylvania, have an ability to connect with and connect you with experts from other fields. And so this is something where I invite you to partner with us. And if you want to discuss more with our health law colleagues and engineering colleagues and business school colleagues, we do that all the time in our kind of daily curriculum and research, and it's something that we can bring to this effort that those of you out in the profession may have a harder time getting access to. So that's another area. The other thing that's come up in a few panels, and I think of the cardiologist, Kiran, our ML graduate, where he talked about how initially when he made his pitch, his ideas weren't fully formed or data tested enough to receive venture money. He, being in academia here at Penn, was able to work in his lab with a less urgent budget and then take it out. And I think, frankly, a great advantage we have here in academia is we don't need to be profitable. That's not to say we're profligate with tuition money or donor money, but we can explore ideas that either in the short term or forever are not ever going to quite capture market funding and market interest. Now, we want to get grants, we want to partner, but I do think many of you who are working in the kind of for-profit business with either law firms or legal technology, we want your ideas that are great ideas that might expand access, but for whatever reason aren't quite gonna make the dollars and cents that would attract other kinds. I mean, and we also want to seek funding for projects like Kathy Carr mentioned yesterday, this guy who wrote a program about the criminal records expungement. That's the kind of thing, as we muster resources and talent, we would love to support. So in a sense, bring us your, I don't want to say, bring us your less than clearly profitable ideas. They might be profitable one day, and we can license them out, but it's something, this is, you know, I work with partners at the medical school, and, you know, it's almost, I'm thinking of something I've studied in past research, like the orphan drug model, where maybe we can help with this center and with this institution here and with other law schools, road testing ideas that may or may not have a clear market yet. But that's another thing. And again, I think the other thing related to that, and this leads into our final speaker, is that we as law schools can bring certainly a connection to the profession, certainly a desire to connect with folks in private practice, but also add in the imperative that we exist in many ways to train lawyers to serve the public interest, to expand access to justice, and that all of these ideas contribute to, and we can work together through technology, through regulatory reform, through the way lawyers work through their careers to make sure that we're providing not just more efficient law, but reaching more people, reaching more clients. And our last speaker, Jim Sandman of the Legal Services Corporation of America, couldn't embody that vision more. He represents, I think, the past, present, and future of our efforts here. Jim was a 1976 graduate of the University of Pennsylvania Law School, now the University of Pennsylvania Carey Law School, and had a distinguished career. I'll just summarize in the two main components, and I've heard Jim speak about the kind of this, where he worked in private practice, mostly at Arnold & Porter for a very long time. Extremely successful, was the managing partner of Arnold & Porter and a tremendous attorney. Always public and professionally spirited, but working in the private practice. And then about 9 or 10 years ago decided that he would take his immense talents in a different direction, and for the last almost a decade has been president of the Legal Services Corporation of America, the nation's most important public interest law firm, and kind of supporting public interest work around the country. I'll let, I think Jim is going to talk about the challenges and goals that he and his colleagues at LSC worked on, so I won't summarize that, but we've been very impressed with it. And then I'm pleased to say, and with Jim, as of about a week ago, ended his distinguished career as president of LSC, and he's part of our future and will be working with us on advising our public interest students, and we're figuring out, we're very glad that Jim, you'll be more involved here. Before I turn it over to Jim, this is the last time you'll hear from me, so that's not an applause line, but two other acknowledgments. Again, one of the reasons we're able to think long-term and kind of work on projects that have long-term payoff, not immediate payoff, is that we're extremely well supported by a range of donors, and led by the Carey Foundation, a partner, kind of a partner with our law school for decades to come, and very much believes in thinking proactively about the future of the profession. And I also want to thank, this has been such a great 2 days, and the vision and execution for this conference was done by our brilliant Chief Innovation Officer, Jen Leonard, so I do want to acknowledge all of your work. We couldn't be in better, and that's another reason for my optimism, is to have this effort in such great hands, and to work with Jen going forward. So again, I look forward to working with all of you. I will turn it over to Jim Sandman, and Jim, thank you for being here. We look forward to your remarks.
Thank you, Ted. Thank you, Ted, and thank you, Jen, for putting this conference together. I'd like to do three things. I'd like to give you my sense of where the legal profession currently stands on the path toward innovation. Second, I'd like to give you three takeaways based on what I heard over the past 2 days on how we might advance down the path of innovation. And finally, I'd like to give some suggestions on a way forward. My sense of where we stand today is that we are firmly stuck, superglued really, in Vijay Govindarajan's box 1, managing the present. We are focused on incremental improvements in current processes, on benchmarking against best practices, and on outcompeting the current competitors. We are analogous to the shipbuilders of 1903, focused on increasing engine power and ship speed with the goal of crossing the Atlantic faster. And if we keep at it, in 9 years, we will have designed by far the fastest ship ever known to humankind, the Titanic. We're seeing warning signals about the effects of not innovating and of focusing only on managing the present. We're seeing those warning signals from both ends of the economic spectrum. Among low-income people, the statistics are astonishing. The Legal Services Corporation in 2017 had the National Opinion Research Center at the University of Chicago do a national survey of the legal needs of low-income people across the country. The survey showed that 86% of the civil legal needs of low-income people either get no help at all or inadequate help. The statistics on the percentage of unrepresented litigants in our courts today are even more troubling. The National Center for State Courts estimates that in 74% of civil cases in state courts today, at least one of the parties does not have a lawyer. Think about that. What that means is that every case a law student reads in 3 years of law school is unrepresentative of what actually happens in the majority of cases in the United States today. I'm actually making a guess in saying that, but it's an educated guess. I would guess that every case in a law school casebook was litigated with lawyers on both sides. Otherwise, it's highly unlikely that the judge would have been able to write an opinion of the quality necessary to find its way into a casebook. No one ever tells a law student that what they're reading is not representative of what is going on in the courts of the United States today. And the numbers are even higher in certain categories of high-stakes, high-volume litigation, like evictions, where more than 90% of tenants facing eviction don't have a lawyer. In Domestic violence cases where a victim seeks a protection order, that's a civil case. The majority of them have to go it alone. These are symptoms of system failure. On the other end of the economic spectrum, you've got the results of the Citibank survey of big law firms for 2019. And what it showed was that demand for legal services among big law firms grew by a whopping 1.1% in 2019. Bruce McEwen yesterday described demand as flat in recent years for the services of big law firms. Big law firms, nevertheless, are increasing their revenue and their profitability. They're doing it by increasing their rates. So last year, when demand went up by 1.1%, rates went up by 4.5%. Think about that. Raising rates in the face of flat demand. Where is that headed? Is that innovation? What does that mean for where we're going to be in 2030? In fact, that's pernicious, because when profits per partner are going up in the face of flat demand, that breeds complacency on the part of the partners. They're doing just fine, thank you very much. That gives them no incentive to try to think about the future and to innovate and come up with new and different ways of delivering service to their clients. So I think we're stuck in box one for now. What do we do about that? Well, I take 3 lessons from what I heard over the past 2 days. First, when it comes to innovating, truly innovating, getting ourselves to box 3, we need to involve the participation of other disciplines. Any innovation initiative led solely by lawyers is an oxymoron. You cannot have innovation led only by lawyers. If we learned anything over the last 2 days, it's how much we have to learn from other disciplines. Some of the lessons are direct. You heard Ralph this morning from Penn Health talk about the creation of what he called automated hovering. Following up with patients to encourage compliance through text messaging, reminding people to take their medicine or to come back to have their blood pressure taken. There's a direct correlation between that learning and what goes on in the world of legal aid. Compliance in the world of legal aid is a problem, getting people to follow the advice they were given. They have busy lives and complicated lives, and they're often not able to do that. But something as simple as text messaging can be very effective in getting them to follow up. Another lesson, how much did we hear over the last 2 days about the importance of data in driving decisions, informed decisions about how to innovate, to test results, to guide future delivery of services? We've got 2 problems, though, in the legal profession. We don't have much data at all, as compared, for example, to health, where the Medicare system compels the collection of data, now decades of data that can provide a very valuable information base to figure out what's working and what's not. We need to do a much better job in the legal profession of collecting data. But we've got a second problem. As Professor Jim Greiner at Harvard Law School has put it, Jim heads something called the Access to Justice Lab, which does randomized controlled trials of legal interventions to figure out what works and what doesn't. And he puts it this way: in no field, he says, is resistance to rigorous empirical data stronger than in United States legal practice. Lawyers don't want to hear it. Get over it, folks. We need to hear it. This is something we can learn from other disciplines. That's lesson number 1. We need to be inviting the Wright brothers over to our meeting of shipbuilders in 1903 and have other disciplines well represented in any discussion of innovation in the legal profession. Takeaway number 2, we need direct user input into any discussion of innovation in the profession. We need to stop assuming that lawyers can serve as valid proxies when it comes to trying to assess the needs and wants of their clients. The National Legal Aid and Defender Association, represented by my friends over here, has what they call a client council, to get direct input from people and not to be dependent solely on legal aid lawyers to find out what the client community wants and needs. And I'm talking about the ultimate user, not the general counsel, but the corporate CEO or the corporate executives who are the ultimate users of the legal services that we're providing. They too often don't have a seat directly at the table. We need to hear from them directly. How can you implement user-centered design if users themselves are not participating in the process? So everything we heard about user design is a lesson to us that when we're talking about innovation in the legal profession, we need to have the clients, the users at the table. We also need to think about what we heard from VG yesterday about, remember the story he told about the poor people in rural India who had cardiac problems but who were completely overlooked by cardiac care because they were inaccessible and because the equipment was too heavy to get to them and required a reliable source of electric power. He described them as non-consumers. The system just overlooked them completely because they couldn't afford to pay, and it was determined that there was no way to serve them. Well, we've got populations like that among these people who are unrepresented litigants in our courts. We need to figure out a way to hear from them directly when we're trying to figure out what innovations might improve the delivery of legal services. And third, we need to recognize that the lawyer regulatory system we have in the United States is itself an impediment to innovation. This system of regulation of lawyers by lawyers, where lawyers become the sole arbiters of what is in the public interest and what is in the client interest. Lawyers are determining what is in the interest of other people. What hubris. No. We need to recognize that the lawyer regulatory system is prohibiting or at least impeding the delivery of integrated cross-disciplinary service, holistic service. What we're hearing is what clients want is holistic service from multiple providers, and our regulatory system is making that very difficult, if not impossible, for lawyers to participate in delivering. The regulatory system, restrictions on the unauthorized practice of law, it's impeding or prohibiting the development of positions like nurse practitioners, which you heard about this morning, which have made a big difference in improving the delivery of health care. We have a system where if you can't, we require a lawyer to do too much, with the result that if you can't afford a lawyer, you're consigned to no help of any kind. We've decreed that you're better off with nothing than with a paralegal who might have been well-trained and competent and experienced, may be regulated. Because in our system, that person might be engaged in the unauthorized practice of law and is not going to be able to help a person who otherwise has no help of any kind. So those are my three takeaways from the presentations we heard, that we need to have an interdisciplinary approach at every step when it comes to thinking about innovation in the practice of law. We need always to have a seat at the table for users directly, and we need to completely rethink the regulatory process. And by the way, when we do that, users, the public, needs to be at the table when it comes to reforming the regulatory system. We can't permit lawyers to do that by themselves. Where do we go from here? Innovation in the legal profession inevitably is going to have to occur at the micro level, institution by institution. But I think there's also a very important role for some broader institutions to play in innovation of the profession as a whole. And some things that I suggest need to happen can't happen simply at the micro level. So for example, rethinking the regulatory system, or bringing in a truly interdisciplinary approach. Can't be done provider by provider. You need to do that on a systemic basis. And who is going to do that? No big change ever happens without leadership. Somebody has to take responsibility for the problem and own it. Who is going to do that when it comes to thinking about innovation in the legal profession? Well, I think there are some candidates. One might be the University of Pennsylvania Carey Law School. And I'm not being facetious. I say that because I think that a law school like Penn, which sits at the center of one of the world's great research universities, has access to other disciplines that is going to be much easier to achieve than most other kinds of institutions that you might think of that could take ownership of this process. Look at the resources that are available here at Penn. So when you have a world-class law school situated in a world-class university, right away you have access to the breadth of thinking that we need to have available if we're truly going to innovate in the legal profession. A great law school can also help lead regulatory reform on a systemic basis, and also has the benefit of being able to incorporate its learning in doing these things into the education of the next generation of lawyers, so that you begin to see results in new thinking and innovative thinking right away. My bottom line is that this is doable. I've outlined some significant challenges. They pale in comparison to real challenges. Think about the challenge of innovation in the legal profession compared to what the Wright brothers were up against in 1903, inventing human air transportation. Think about what we're up against compared to the challenges that President Kennedy described in 1961 when he set the goal of landing a man on the moon and returning him safely to Earth before the decade was out. We're talking about small stuff. We can do this. And we must. The discussion over the last 2 days has proceeded most of the time as if what we were talking about was innovation in the development of a new product or just some professional service. We're talking about a lot more than that. What I've lived with for the last 9 years has to do with the way the justice system in the United States is functioning, or more accurately, is not functioning for the low-income people of our country. Our system is failing low-income people, millions of them every year, who are forced to try to navigate a legal system created by lawyers for lawyers on the assumption that everybody's got a lawyer. It's a system that works pretty well when you have a lawyer and horribly when you don't. What's at stake is justice, not just some consumer product or some professional service. Dean Ruger started us off yesterday by reminding us that it was lawyers who created the best invention of all time when it comes to government 223 years ago, 3 miles away at Independence Hall, when they came up with the Constitution of the United States. When the founders of our country and the framers of our national government got together to talk about what they were trying to achieve, do you know what they cited as their most important value, their highest goal, over and over again? Justice. Alexander Hamilton said, "The first duty of society is justice." Thomas Jefferson said, "The most sacred of the duties of government is to do equal and impartial justice to all its citizens." James Madison in Federalist Number 51 wrote, "Justice is the end of government. It is the end of civil society. It ever has been and ever will be pursued until it be obtained, or until liberty be lost in the pursuit." The very first line of the Constitution cites establishing justice as the core purpose of our national government. The first line of the Constitution reads, "We, the people of the United States, in order to form a more perfect union, establish justice." I think that's fascinating. The framers mentioned establishing justice as their goal before they mentioned providing for the common defense or ensuring domestic tranquility. I don't think their ordering was an accident. I think they recognized that a well-functioning, accessible system of justice is essential to societal stability. It's about the rule of law. You won't long have a nation to defend or worth defending without it. That's what we're talking about. Justice. We owe it to those great lawyer inventors of 223 years ago. We owe it to our fellow citizens who depend on our solemn pledge of justice for all to make sure that we're delivering on justice. Thank you.
Thank you so much, Jim, for closing out these last 2 days. They were incredible, at least from my perspective. I hope everybody else felt all of the energy, both here in Philadelphia and virtually, globally. I just want to say a few words of thanks. First, I want to thank Dean Ruger for his support of this initiative, to our advisory board for helping us refine our vision and develop the design for these 2 days, the Carey Foundation for bringing to life some of these projects that will allow us to advance these interdisciplinary conversations. I want to thank Catalyst Productions for helping us pull together all of these ideas and create the vision for these 2 days. I want to thank everybody at Pennovation, our colleagues at Penn Law who helped, especially Delilah Lewis, who was my right-hand person with all of the logistical tasks that needed to take place, and there were many. So Law 2030, the next 10 years will challenge this profession in ways that we have never been challenged before. We are not equipped in our current training and understanding to respond to those challenges without learning from other people and bringing other disciplines and other people around campus, other law schools into the conversation. You know, there was a woman here today, I'm not sure if she's still here, Lisa Graybell, but she reached out and she wanted to come because her daughter, who is a freshman in college, is thinking about going to law school, and she wanted to come to this event. And she said, it occurred to me when I saw Law 2030 that if my daughter were to go to law school, that's about when she would be entering the profession. And I want to know what you all are doing to make sure that it's a better profession than what it is today. And that is what we're here to do. We're here to do a better job for the people that we serve. And we talked about this at the beginning. And her daughter is a person that we who work at law schools will serve. And we need to be thinking in new ways about how we serve them. I have a role at the law school as the Chief Innovation Officer. I had the opportunity to participate in an executive education program at Wharton for Chief Innovation Officers. And the biggest takeaway from that program was that the role of a CIO is not to come up with ideas. And in fact, if your CIO is the person coming up with all of the ideas, that person is a bad CIO. The role of a CIO is to create an environment in which people feel comfortable bringing up new ideas and thinking in new ways and bringing together new voices, bringing people from other disciplines so that you can connect with one another. And I hope the past 2 days have shown that we are serious here about doing that. The number of times I walked around and I heard somebody say, I didn't think that I would have anything in common with this person over here, but I'm working on a project that completely relates to what that person's doing, and we need to talk more. I also wanted to note, I think, that the winning team for the student design sprint was the only team that had a student who was not at the law school on the team, which to me just shows the strength of interdisciplinarity. It's somebody who thinks differently and brings new ideas to the conversation. This is a University of Pennsylvania Carey Law School initiative, but it is not a Penn Law initiative alone. And it will be a failure if we do not continue to bring all of you into the conversation. This is only the beginning. We welcome your thoughts, your creativity, your passion for change. Thank you again. I hope you are well, and we look forward to seeing you in the future. enjoyed Law 2030, a global conversation about the future of the profession, but this is not the end, it's only the beginning. We want to hear from you about what we should do at the Future of the Profession initiative to move these great ideas forward. Please email me at jenleo, Leo, @law.upenn.edu. Thanks so much for joining us.